ಚಿಕ್ಕ ಅಂದರೆ ಹೊಸದಾಗಿ ನಮ್ಮ ವೈದ್ಯ ವೃತ್ತಿಗೆ ಕಾಲಿಡ್ತಕ್ಕಂಥ ಯುವ ವೈದ್ಯರಿಗೆ ಅವರ ಉತ್ತೇಜನ ಮಾಡೋದಕ್ಕೋಸ್ಕರ ನಾವು ಪೇಪರ್ ಪ್ರೆಸೆಂಟೇಷನ್ನು, ಕೇಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ನು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಆ ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳಂತ ಹಮ್ಮಿಕೊಂಡಿದ್ದೇವೆ. ಅವರಲ್ಲಿರ್ತಕ್ಕಂಥ ವಿದ್ಯಾವಂತಿಕೆಯನ್ನು, ಬುದ್ಧಿವಂತಿಕೆಯನ್ನು ನಮ್ಮ ಮುಂದೆ ತೋರಿಸಲಿಕ್ಕೆ ಇದೊಂದು ಒಳ್ಳೆಯ ವೇದಿಕೆಯಾಗಿ ಪರಿಗಣಿಸುತ್ತದೆ. ಮತ್ತು ಈ ನಿಟ್ಟಿನಲ್ಲಿ ನಮಗೆ ಕೆಲವೊಂದು ಸಮಸ್ಯೆಗಳಿರ್ತದೆ. ಉದಾಹರಣೆಗೆ ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ ನಡೀತಾ ಇರ್ತದೆ. ಹಲ್ಲೆನ ತಡೆಗಟ್ಟೋದಕ್ಕೆ ಕಾನೂನಿದೆ, ಮತ್ತು ಆ ಕಾನೂನನ್ನು ಮಾರ್ಪಡಿಸಿ ಸಹ ಕಳೆದ ವರ್ಷ ಸೆಷನ್ನಲ್ಲಿ ಪಾಸ್ ಮಾಡಿರ್ತಾರೆ. ಆದರೆ ಆ ಒಂದು ಕಾನೂನನ್ನು ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ ಅನುಷ್ಠಾನಗೊಳಿಸ್ತಾ ಇಲ್ಲ. ಅದಕ್ಕೆ ಸರ್ಕಾರ ಇದರ ಬಗ್ಗೆ ಹೆಚ್ಚಿನ ಗಮನ ಹರಿಸಿ ಪೊಲೀಸರಿಗೆ ಉತ್ತಮ ಒಂದು ಕನ್ವಿಕ್ಷನ್ ಆಗಿದೆ.
ಎಷ್ಟು ವರ್ಷ ಆದರೂ ಒಂದು ಕನ್ವಿಕ್ಷನ್ ಆಗಿಲ್ಲ. ಅದರಿಂದ ಏನಾಗುತ್ತೆ ಅಂದರೆ ಆ ಕಾಯ್ದೆ ಬಗ್ಗೆ ನಂಬಿಕೆನೇ ಹೋದಂಗಾಗುತ್ತೆ.
ಹೌದು,
ಅದ್ರ ಬಗ್ಗೆ ನೀವು ಅಸೋಸಿಯೇಷನ್ ಕಡೆಯಿಂದ ಯಾಕೆ ಅಷ್ಟು ಸ್ಟ್ರಾಂಗ್ ಇದು ಮಾಡೋದು?
ಅಲ್ಲ, ನಾವು ಸ್ಟ್ರಾಂಗ್ ಆಗಿ ಸರ್ಕಾರದ ಜೊತೆ ಚರ್ಚೆಗಳು ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಮತ್ತು ಕೆಲವೊಂದು ಮುಷ್ಕರಗಳನ್ನ ಸಹ ನಾವು ಮಾಡಿದ್ವಿ. ಇದನ್ನು ಅಚ್ಚುಕಟ್ಟಾಗಿ ಕಾಯ್ದೆ ಇದೆ, ಪುಸ್ತಕದಲ್ಲಿದೆ, ಅದನ್ನು ಕಾರ್ಯರೂಪಕ್ಕೆ ತರಬೇಕು. ಅದಕ್ಕೆ ಎಲ್ಲ ಪೊಲೀಸ್ ಅಧಿಕಾರಿಗಳಿಗೆ ಅವರು ಕ್ರೈಮ್ ಮೀಟಿಂಗ್ ಅಂತ ಮಾಡ್ತಾರೆ SP ಆಫೀಸಲ್ಲಿ. ಪ್ರತಿ ತಿಂಗಳು ಕ್ರೈಮ್ ಮೀಟಿಂಗ್ ಮಾಡುವಾಗ ಈ ಕಾಯ್ದೆ ಬಗ್ಗೆ ಅವ್ರಿಗೆ ಹೆಚ್ಚಿನದಾಗಿ ತಿಳಿಸ್ಕೊಡ್ಬೇಕು ಅಂತ ನಾವು ಕೆಲವು ಕಡೆ ಹೋದಾಗ ಪೊಲೀಸ್ ಅಧಿಕಾರಿಗಳಿಗೆ ಈ ಕಾನೂನಿನ ಬಗ್ಗೆ ಅರಿವಿರೋದಿಲ್ಲ. ಅವ್ರಿಗೆ ಅರಿವು ಮೂಡಿಸುವಂಥ ಕೆಲಸನ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಜೊತೆಯಲ್ಲಿ ಸರ್ಕಾರದ ಮೇಲೂ ಸಹ ಒತ್ತಡವನ್ನು ಏರ್ತಾ ಇದ್ದೇವೆ. ಸೊ ಅದಾದರೆ ನಮ್ಮ ವೈದ್ಯರೆಲ್ಲ ನೆಮ್ಮದಿಯಾಗಿ ಜನರಿಗೆ ಸೇವೆ ಸಲ್ಲಿಸಲಿಕ್ಕೆ ಅನುಕೂಲ ಆಗುತ್ತೆ.
ಕಾಂಪ್ರಮೈಸ್ ಆಗ್ತದೆ.
ಹೌದು,
ಭೌತಿಕ ಪ್ರಕರಣಗಳು ಅದರಿಂದ ಏನಾಗ್ತದೆ ಅಂತಂದ್ರೆ ಇಷ್ಟೇನಾ ಅಂತ ಲೆಕ್ಕಕ್ಕೆ ಜನರಲ್ಲಿ ಒಂದು ಭಾವನೆ ಮೂಡಾಗುತ್ತೆ. ಒಂದು ಅಥವಾ ಎರಡು ಕನ್ವಿಕ್ಷನ್
ಅದೇ ಕ್ಲೋಸ್ ಆಗುತ್ತೆ. ಒಂದು 2-3 ಆದ್ರೂ ಕನ್ವಿಕ್ಷನ್ ಆದರೆ
ಎಲ್ಲೋ ಆಗಲಿ ಒಂದು ಆಕ್ಷನ್ ಆಗಿದ್ದು ಸ್ವಲ್ಪ ಹೈಲೈಟ್ಸ್ ಆಯ್ತು ಅಂದರೆ ಜನರದ್ದು ಸ್ವಲ್ಪ ಭಯ ಬರುತ್ತೆ.
ಇಲ್ಲ, ಕೆಲವೊಂದು ಆಗಿದ್ದಾವೆ. ದಕ್ಷಿಣ ಕನ್ನಡದಲ್ಲಿ, ಕೋಲಾರದಲ್ಲಿ, ತುಮಕೂರಲ್ಲಿ ಒಂದೊಂದು ಕನ್ವಿಕ್ಷನ್ ಆಗಿದೆ. ಬಟ್ ಏನಂದರೆ ಅವ್ರಿಗೆ ಅಪೀಲ್ ಹೋಗೋಕ್ಕೆ ಅವಕಾಶ ಇರ್ತದೆ. ಮುಂದಿನ ಕೋರ್ಟಿಗೆ ಹೋಗಿ ಸುಮಾರು ವರ್ಷಗಳು ನಡೀತದೆ. ಅವಾಗ ಅವರು ವೀರಾವೇಶದಿಂದ ಓಡಾಡ್ಕೊಂಡಿರ್ತಾರೆ ತಾವು ಹೇಳ್ದಾಗೆ. ಸೊ ಹಾಗಾಗಿ ಕಠಿಣವಾಗಿ ಶಿಕ್ಷೆ ಆಗ್ತಾ ಇಲ್ಲ ತಾವು ಹೇಳ್ದಾಗೆ. ಅದ್ರ ಬಗ್ಗೆ ನಾವು ಸರ್ಕಾರದ ಮೇಲೆ ಒತ್ತಡ ಇರೋದಕ್ಕೋಸ್ಕರ ಈ ಸಮ್ಮೇಳನದ ಮೂಲಕ ಸರ್ಕಾರವನ್ನು ಒತ್ತಾಯ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ನಾನು.
ನಿಮ್ಮ ಬೇಡಿಕೆಗಳು ಎಲ್ಲವೂ ಸ್ಪಂದನೆ ಮಾಡ್ತಾರೆ ಸರ್ಕಾರ?
ಹೆಚ್ಚಿನದಾಗಿ ನಮಗೆ ಈಗ ಹೆಚ್ಚಿನ ತೊಂದರೆ ಆಗ್ತಾ ಇರೋದು ಸಣ್ಣ ಮತ್ತು ಮಧ್ಯಮ ಗಾತ್ರದ ಆಸ್ಪತ್ರೆಗಳಿಗೆ. ಈ KPME ಅಂದರೆ ತಮ್ಗೆ ಗೊತ್ತಿರ್ಬೋದು, ಖಾಸಗಿ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಸಂಸ್ಥೆ, ವೈದ್ಯಕೀಯ ಸಂಸ್ಥೆಗಳ ನಿಯಂತ್ರಣ ಕಾಯ್ದೆ ಅಂತ ಇದೆ. ಆ ಕಾಯ್ದೆನಲ್ಲಿ ಫೈರ್ ಸೇಫ್ಟಿ ನಾರ್ಮ್ ಅಂತ ಮಾಡಬೇಕು ಅಂತಿದೆ. ಚಿಕ್ಕ ಹಾಸ್ಪಿಟ್ಲ್ ಇರ್ತದೆ, ಇದು ಯಾವಾಗಲೋ ಕಟ್ಟಿಸ್ಕೊಂಡಿರ್ತಾರೆ. ಆ ಫೈರ್ ನಾರ್ಮ್ ಪ್ರಕಾರ ಆಸ್ಪತ್ರೆ ಸುತ್ತ ಇಷ್ಟೊಂದು ಜಾಗ ಬಿಡಬೇಕು, ಮತ್ತು ಒಂದು 20,000 ಲೀಟ್ರ್ ಇರ್ತಕ್ಕಂಥ ಟ್ಯಾಂಕ್ ಇಟ್ಕೋಬೇಕು ಅಂತ ಎಲ್ಲ ಸುಮಾರು ಇದೆ. ಅದೆಲ್ಲ ಬೇಡ. ನಾವು ಸಂರಕ್ಷಣೆಗೆ ಚಿಕ್ಕ ಆಸ್ಪತ್ರೆಗೆ ಏನು ಬೇಕೋ ಅದನ್ನೆಲ್ಲ ಮಾಡ್ಕೋತೀವಿ. ನಾವೇನು ಹಾಗೆ ಫೈರ್ ಸೇಫ್ಟಿ ಬೇಡ ಅಂತ ಹೇಳ್ತಿಲ್ಲ. ಯಾಕೆಂದರೆ ಎಲ್ಲಾದರೂ ಅವಘಡಗಳು ಆಗಲೇಬೋದು. ಆ ಅವಘಡಗಳಿಗೆ ಏನೇನು ಚಿಕ್ಕದಾಗಿ ಮಾಡೋಕ್ಕೆ ಸಾಧ್ಯವೋ ಅದೆಲ್ಲ ಮಾಡೋಕ್ಕೆ ನಾವು ತಯಾರಿದ್ದೀವಿ. ಆದರೆ ಅಷ್ಟೊಂದು ಸ್ಟ್ರಿಕ್ಟಾಗಿ ಯಾವ ದೊಡ್ಡ ಆಸ್ಪತ್ರೆಗಳು, ಕಾರ್ಪೊರೇಟ್ ಆಸ್ಪತ್ರೆಗಳು, ಅಲ್ಲೆಲ್ಲ ವೆಂಟಿಲೇಟರ್ಸು ಅದು ಎಲ್ಲ ಜಾಸ್ತಿ ಇರ್ತದೆ. ಕೆಲವು ಚಿಕ್ಕ ನರ್ಸಿಂಗ್ ಹೋಮಲ್ಲಿ ಅವೆಲ್ಲ ಇರೋದೇ ಇಲ್ಲ. ಸೊ ಅಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಫೈರ್ ಆಗೋ ಸಾಧ್ಯತೆಗಳು ಕಡಿಮೆ ಇರ್ತದೆ. ಅಂಥ ಸಂಸ್ಥೆಗಳನ್ನ ಗುರುತಿಸಿ ಅವುಗಳಿಗೆ ಈ ಕಾನೂನಲ್ಲಿ ಸ್ವಲ್ಪ ಇದನ್ನು ಎಕ್ಸಂಪ್ಷನ್ಸ್ ಕೊಡಲಿಕ್ಕೆ ನಾವು ಸರ್ಕಾರದಲ್ಲಿ ಮನವಿ ಮಾಡಿದ್ದೇವೆ. ಅದರ ಬಗ್ಗೆ ಮಾನ್ಯ ಹೋಮ್ ಮಿನಿಸ್ಟರ್ ಜೊತೆ ಮತ್ತು ನಮ್ಮ ಹೆಲ್ತ್ ಮಿನಿಸ್ಟರ್ ಜೊತೆ ನಾವು ಸಾಕಷ್ಟು ಮೀಟಿಂಗ್ಗಳನ್ನು ಮಾಡಿ ಈಗ ಇದು ಕಡೆ ಹಂತಕ್ಕೆ ಬಂದಿದೆ. ಸದ್ಯದಲ್ಲಿ ಅದರದ್ದು ಉತ್ತಮವಾದ ಇದು ಹೊರಗೆ ಬರ್ಬೋದು. ಅಂದರೆ ರಿಸಲ್ಟ್ ನಮಗೆ ಒಳ್ಳೆಯ ಉತ್ತಮವಾದ ರಿಸಲ್ಟ್ ಸಿಗ್ಬೋದು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾವು ಭಾವಿಸಿದ್ದೇವೆ. ಆದರೂ ಸರ್ಕಾರನ ಅದ್ರ ಬಗ್ಗೆ ನಾವು ಒತ್ತಾಯ ಮಾಡ್ತಾನೆ ಇದ್ದೀವಿ. ನಿರಂತರವಾಗಿ ಆ ಒಂದು ಬೇಡಿಕೆನ ಈಡೇರಿಸಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾವು ಸರ್ಕಾರದೊಂದಿಗೆ ವ್ಯವಹರಿಸ್ತಾ ಇದ್ದೇವೆ. ಅದೇ ರೀತಿ ನಮ್ಗೆ ಗೊತ್ತಿರ್ಬೋದು, ಮಿಕ್ಸೋಪತಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಪೇಪರ್ಗಳಲ್ಲೆಲ್ಲ ಬರ್ತಾ ಇರ್ತದೆ. ಈಗ ಆಯುರ್ವೇದ ಮಾಡಿರ್ತಕ್ಕಂಥ ವೈದ್ಯರು ಅಲೋಪತಿನ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡೋದಕ್ಕೆ ಅವರಿಗೆ ಟ್ರೈನಿಂಗ್ ಕೊಡಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಕೆಲವೊಂದು ಈ ಒಂದು ನಮ್ಮ ರಾಷ್ಟ್ರೀಯ ವೈದ್ಯಕೀಯ ಮಂಡಳಿ ಕಡೆಯಿಂದ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದನ್ನು ನಾವು ಪಕ್ಕಾ ವಿರೋಧಿಸ್ತಾ ಇದ್ದೇವೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದಿಂದ. ಯಾಕೆಂದರೆ ನಾವು ಅವರು ಆಯುರ್ವೇದ ಮತ್ತು ಆಯುಷ್ ಏನು ಪದ್ಧತಿಗಳಿದೆ ಆ ಪದ್ಧತಿಗಳಿಗೆ ನಾವು ಸಹಕಾರ ಕೊಡ್ತೇವೆ. ಅವರು ಆ ಪದ್ಧತಿಯನ್ನು ಅನುಸರಿಸಲಿ, ಅವ್ರ ಬಗ್ಗೆ ನಮ್ದು ಯಾವುದೇ ಚಕಾರ ಇಲ್ಲ, ವಿರೋಧ ಇಲ್ಲ. ಆದರೆ ಅವರು ಅಲೋಪತಿಯನ್ನು ಕಲಿಸಬಾರ್ದು, ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಬಾರ್ದು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಮ್ದಷ್ಟೇ. ನಾವು ಆಯುರ್ವೇದನ ನಾವು ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಲ್ಲ. ಅದೇ ರೀತಿ ಅವರು ಸಹ ಅವ್ರು ಏನು ಕಲ್ತಿರ್ತಾರೋ ಆ ಕಲ್ತಿರ್ತಕ್ಕಂಥ ವಿಚಾರದಲ್ಲಿ ರೋಗಿಗಳಿಗೆ ಚಿಕಿತ್ಸೆ ಕೊಡಬೇಕು. ಅವ್ರಿಗೆ ಫಾರ್ಮೋಪತಿ ಅನ್ನೋದನ್ನು ದಯವಿಟ್ಟು ಇಂಟ್ರಡ್ಯೂಸ್ ಮಾಡಬೇಡಿ, ವಾಪಸ್ ತಗೊಳ್ಳಿ. ಅವರವ್ರೇನೇ ರೆಗ್ಯುಲರ್ ವೈದ್ಯರು ಏನು ಕಲ್ತಿರೋ ವೈದ್ಯರು ಇರ್ತಾರೆ, ಅವ್ರಿಗೇನೋ ಜಾಸ್ತಿ ಇದೆ. ಅವ್ರ ಬಗ್ಗೆ ಹೆಚ್ಚಿನ ಕ್ರಮ ತಗೋಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸಾರ್ವಜನಿಕರ ಕಡೆಯಿಂದನೂ ಒತ್ತಡ ಇದೆ. ಸೊ ಹಾಗಾಗಿ ಸಾರ್ವಜನಿಕರನ್ನು ಒತ್ತಡ ಮಾಡಬೇಕು. ಅಂದರೆ ಯಾರು ನಕಲಿ ವೈದ್ಯರು, ಯಾರು ಇದು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಮ್ಮ KPMEನಲ್ಲಿ ಒಂದು ಬೋರ್ಡ್ ಮಾಡಿದ್ದಾರೆ. ಒಂದು ಹಸಿರು ಬೋರ್ಡು ಮತ್ತು ಒಂದು ನೀಲಿ ಬೋರ್ಡು. ನೀಲಿ ಬೋರ್ಡು ಆಯುರ್ವೇದರು ಹಾಕಬೇಕು, ಹಸಿರು ಬೋರ್ಡನ್ನು ಅಲೋಪತಿಯವರು ಹಾಕ್ಕೋಬೇಕು. ಸೊ ಅವಾಗ ಏನಾಗುತ್ತೆ, ಈ ಕಲರ್ ನೋಡಿಕೊಂಡು ಇವನು ಅಲೋಪತಿ ವೈದ್ಯ, ಇವನು ಆಯುರ್ವೇದ ವೈದ್ಯ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಗುರುತಿಸ್ಲಿಕ್ಕೆ ಅನುಕೂಲ ಆಗಲಿ ಅಂತ ಮಾಡಿದ್ದಾರೆ. ಆದರೆ ಸಾಕಷ್ಟು ಕಡೆ ಇನ್ನೂ ಆ ಬೋರ್ಡ್ಗಳೇ ಹಾಕೋತಾ ಇಲ್ಲ. ಆಮೇಲೆ ತಮಗೆ ಗೊತ್ತಿರ್ಬೋದು, ಈಗ ಕ್ವ್ಯಾಕ್ಸ್ ಅಂದರೆ ಯಾರು ಅಂದರೆ ಅವ್ರು ಏನೂ ಕಲ್ತಿರಲ್ಲ, SSLCನೂ ಓದಿರಲ್ಲ.
ಬೋರ್ಡ್ ಪಾಲಿಸಿ ಸರ್ಕಾರ ಮಾಡಿದ್ರೆ ನೀವು ಮಾಡಿದ್ರೆ
ಸರ್ಕಾರ
ಮಾಡಿದ ಮೇಲೆ
ಇಂಪ್ಲಿಮೆಂಟ್ ಆಗಿಲ್ಲ ಇನ್ನೂ ಸಹ. ಅದಕ್ಕೆ ಮಾಡಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾವು ಎಲ್ಲ ಜಿಲ್ಲಾ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣಾಧಿಕಾರಿಗಳು, ಅದಕ್ಕೆ ನೋಡಲ್ ಅಧಿಕಾರಿ ಇರ್ತಾರೆ, ಜಿಲ್ಲಾಧಿಕಾರಿಗಳು ಅಧ್ಯಕ್ಷರು ಇರ್ತಾರೆ. ಸೊ ಎಲ್ಲರ ಮೇಲೆ ನಾವು ಒತ್ತಡನ ಹೇರ್ತಾ ಇದ್ದೀವಿ. ಆದಷ್ಟು ಬೇಗ ಅದು ಇಂಪ್ಲಿಮೆಂಟ್ ಆದರೆ ಯಾರು ಆಯುರ್ವೇದ ಚಿಕಿತ್ಸೆ ಕೊಡ್ತಾನೆ, ಯಾರು ಅಲೋಪತಿ ಚಿಕಿತ್ಸೆ ಕೊಡ್ತಾನೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನೀವು ಬೋರ್ಡ್ ನೋಡ್ಕೊಂಡೇ ಹೋಗ್ಬೋದು. ಅದೊಂದು ಆಗಬೇಕು. ಮತ್ತೆ ಏನೂ ಕಲ್ತಿರದೆ ಇರ್ತಕ್ಕಂಥವ್ನು, SSLC ಓದಿರ್ತಾನೆ, ಯಾರೋ ಡಾಕ್ಟರ್ಗಳಿಗೆ ಕೆಲಸ ಮಾಡ್ತಿರ್ತಾನೆ, ಅವನು ಈ ಡಾಕ್ಟರ್ ಏನೇನು ಕೊಡ್ತಾರೆ ಔಷಧಿ ಅಂತ ಕಲ್ತ್ಕೊಂಡಿರ್ತಾನೆ. ಜ್ವರಕ್ಕೆ ಏನು ಕೊಡ್ತಾರೆ, ಬೇದಿಗೆ ಏನು ಕೊಡ್ತಾರೆ ಅಂತ ತಿಳ್ಕೊಂಡು ಅದನ್ನು ಅವನು ಇಲ್ಲಿ ನೋಡ್ಕೊಂಡಿರ್ತಾನೆ. ಅದನ್ನೇ ಹೋಗ್ಬಿಟ್ಟು ಅಲ್ಲಿ ಕ್ಲಿನಿಕ್ ಮಾಡಿಬಿಟ್ಟು ಅವನು ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡ್ತಾನೆ. ಅವರು ಇದ್ದಿದ್ದು ಡೇಂಜರ್ ಸಮಾಜಕ್ಕೆ, ರೋಗಿಗಳಿಗೆ. ಸೊ ಹಾಗಾಗಿ ಅಂಥವ್ರನ್ನ ಸೆದೆ ಬಡಿಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಕಾನೂನನ್ನು ಕಠಿಣವಾಗಿ ನೀವು ಹೊರಡಿಸ್ಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸರ್ಕಾರದ ಈ ಮೂಲಕ ನಾನು ಸರ್ಕಾರವನ್ನು ಒತ್ತಾಯಿಸ್ತೇನೆ. ಕಾನೂನಿದೆ, ಆದರೆ ಅದು ಇಂಪ್ಲಿಮೆಂಟ್ ಆಗ್ತಾ ಇಲ್ಲ. ಕ್ವ್ಯಾಕ್ಸಿಗೆ ದಂಡ ಅದೆಲ್ಲ ಇದೆ, ಆದರೆ ಏನೂ ಆಗ್ತಾ ಇಲ್ಲ. ಸೊ ಇನ್ನು ನಾವು ಬರೀ ನಮ್ಮ ಬೇಡಿಕೆಗಳನ್ನು ನೋಡ್ಕೊಳ್ಳೋದು ಅಷ್ಟೇ ಅಲ್ಲದೆ ನಾವು
ಎಸೆನ್ಷಿಯಲ್ ಸರ್ವಿಸ್ ಅಲ್ಲ.
ಹೌದು,
ಪ್ರತಿಭಟನೆ ಅಷ್ಟು ಸೀರಿಯಸ್ ಆಗಲ್ಲ.
ಅಲ್ಲ, ಪ್ರತಿಭಟನೆ ಮಾಡಕ್ ಹೋದ್ರೆ ಕೋರ್ಟ್ ಅಡ್ಡ ಬರ್ತದೆ.
ಅಲ್ಲ, ವಾಸ್ತವ ಸರ್.
ಕೋರ್ಟ್ ಏನ್ ಹೇಳುತ್ತೆ, ನೀವು ಚಿಕಿತ್ಸೆ ನೀಡಿ,
ಕಂಡೀಷನ್ ಆಗ್ತದೆ, ಎಮರ್ಜೆನ್ಸಿ ಸರ್ವಿಸ್ ಕೊಡಲೇಬೇಕಂತಾನೆ ಒಂದು ಕಂಡೀಷನ್ ಆಗ್ತದೆ.
ಹೌದು,
ಹಿಂಗೆ ಏನಾಯ್ತು ಅಂತಂದ್ರೆ ಡಾಕ್ಟ್ರ್ ಹೆಂಗಿದ್ರೆ ನಮ್ಮವ್ರು ಬರ್ತಾರ ಅನ್ನೋದಕ್ಕೆ ಒಂದು ಜನರಲ್ಲಿ ಭಾವನೆ ಬಂದಿಲ್ಲ. ಅದಕ್ಕೆ ನೀವು ಸ್ವಲ್ಪ ನಾನು ಸರ್ವಿಸ್ ಕೊಡುವಂತನಲ್ಲ, ನಿಮಗೂ ಸ್ಪಂದನೆ ಮಾಡ್ಬೇಕಲ್ಲ. ಹೌದು, ಸರ್ಕಾರನೂ ಮಾಡಬೇಕು, ಜನರು ಮಾಡಬೇಕು. ಕೋರ್ಟ್ಗಳು ಸಹ, ಕೋರ್ಟ್ಗಳು ನಾವು ಸ್ಟ್ರೈಕ್ ಮಾಡ್ತೀವಿ ಅಂತಂದ್ರೆ ನಮ್ಮ ಮೇಲೆ ಟೀಕಾ ಪ್ರಹಾರ ಮಾಡ್ತಾರೆ. ಮತ್ತೆ ನಾವು ಮಾಧ್ಯಮದವರು ಸಹ ನಮ್ಗೆ ಸಹಕಾರ ಕೊಡಬೇಕು ಆ ನಿಟ್ಟಿನಲ್ಲಿ. ಯಾಕೆ ಅಂತಂದ್ರೆ ಸರ್, ಇನ್ನೊಂದು ಕೋರ್ಟ್ ಪ್ರಕರಣದೊಳಗ ನೀವೇ ಜಾಸ್ತಿ ಎವಿಡೆನ್ಸ್ ಬರಲ್ಲ.
ಅಲ್ಲ, ಕೋರ್ಟ್ ಪ್ರಕರಣ ಅಂದ್ರೆ
ಯಾಕೆ ಬೇಕು ಅಂತಂದ್ರೆ ಲೋಕಲ್ ಇರ್ತಾರಲ್ಲ, ಯಾಕೆ ಬೇಕು ಅನ್ನೋ ಲೆಕ್ಕಕ್ಕೆ ಎಷ್ಟೋ ಎವಿಡೆನ್ಸ್ ಇರಲಾರ್ದೇ ಕೆಲವು ಇದಾಗಿದೆ.
ಅಲ್ಲ, ಅದು ಬೇರೆ ವಿಚಾರ. ಸ್ಟ್ರೈಕ್ ವಿಚಾರ ನಾನು ಹೇಳ್ತಾ ಇರೋದು. ಸ್ಟ್ರೈಕ್ ವಿಚಾರಕ್ಕೆ ಬಂದ್ರೆ
ಎಲ್ಲ ವಿಷಯದಲ್ಲೂ
ಹೌದೌದು, ಅದನ್ನ ಒಪ್ಕೋತೀನಿ. ಮತ್ತೆ ಇನ್ನೊಂದು PCPNDT ಕಾಯ್ದೆ ಅಂತ ಇದೆ. PCPNDT ಕಾಯ್ದೆನಲ್ಲಿ ಏನು ಮಾಡ್ತಾರೆ, ಜಿಲ್ಲಾ ಮಟ್ಟದಲ್ಲಿ ಈಗ ಅಲ್ಟ್ರಾಸೌಂಡ್ ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ಅಲ್ಟ್ರಾಸೌಂಡ್ ಮಾಡುವಾಗ ಕೆಲವೊಂದ್ಸರಿ ಅವ್ರ ರೋಗಿಯ ದಾಖಲೆಗಳನ್ನ ಮಾಡೋದು ಎಲ್ಲ ಚಿಕ್ಕ ಪುಟ್ಟ ತಪ್ಪುಗಳು ಮಾಡಿರ್ತಾರೆ. ಚಿಕ್ಕ ಪುಟ್ಟ ತಪ್ಪುಗಳಿಗೇನೆ ಆ ಸ್ಕ್ಯಾನಿಂಗ್ ಸೆಂಟರ್ನ ಬೀಗ ಹಾಕೋದು ಅಂತೆಲ್ಲ ಮಾಡ್ತಾರೆ. ಅದು ತಪ್ಪು. ಆದರೆ ಸೆಕ್ಸ್ ಡಿಟೆಕ್ಷನ್ ಮಾಡೋದು ಮತ್ತೆ ಭ್ರೂಣ ಹತ್ಯೆ ಮಾಡೋದು ಅದನ್ನೆಲ್ಲ ಮಾಡೋ ಅಂಥವ್ರನ್ನ ಪತ್ತೆ ಮಾಡಿ ಅವ್ರಿಗೆ ಅವ್ರ ಆಸ್ಪತ್ರೆನ ಪರ್ಮನೆಂಟಾಗಿ ಕ್ಲೋಸ್ ಮಾಡಿಸ್ಲಿ. ಅದಕ್ಕೆ ನಮ್ಮದು ಸಕಾರಾತ್ಮಕವಾಗಿ ನಾವು ಸ್ಪಂದಿಸ್ತೇವೆ. ಅಂಥ ವೈದ್ಯರನ್ನ ನಾವು ಸಹ ಧಿಕ್ಕರಿಸ್ತೇವೆ. ನಮ್ಮ ಸಂಘದಿಂದ ಅವ್ರನ್ನ ಬೇಕಾದ್ರೆ ಹೊರಗಾಕ್ಲಿಕ್ಕೂ ನಾವು ಸಿದ್ಧ ಇದ್ದೇವೆ. ಅಂಥ ವೈದ್ಯರಿಗೆ ಶಿಕ್ಷೆ ಕೊಡಿ. ಸಣ್ಣ ಪುಟ್ಟ ತಪ್ಪು ಮಾಡೋ ಅಂಥ ವೈದ್ಯರಿಗೆ ರಕ್ಷಣೆ ಕೊಡಿ. ಅವ್ರಿಗೆ ತಿದ್ಕೊಳ್ಳೋಕ್ಕೆ ಒಂದು ಅವಕಾಶ ಕೊಡಲಿಕ್ಕೆ ಆ ಕಾನೂನಲ್ಲೇ ಅವಕಾಶ ಇದೆ. ಆ ಕಾನೂನನ್ನು ಉಪಯೋಗಿಸ್ಕೊಂಡು ತಾವು ರಕ್ಷಣೆ ಕೊಡಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾನು ಈ ಮೂಲಕ ಸರ್ಕಾರಕ್ಕೆ ಒತ್ತಾಯವನ್ನು ಮಾಡ್ತೇನೆ. ಮತ್ತೆ ನಮ್ಮಲ್ಲಿ ಯಶಸ್ವಿನಿ ಆರೋಗ್ಯ ಸ್ಕೀಮನ್ನು ನಿಲ್ಲಿಸಿದ್ರು, ಮತ್ತೆ ಶುರು ಮಾಡಿದ್ದಾರೆ. ಬಟ್ ಅದು ಇನ್ನೂ ಟೇಕ್ ಆಫ್ ಆಗಿಲ್ಲ. ಶುರು ಮಾಡಿ ಮತ್ತೆ ಅದಕ್ಕೆ ಕಾರಣ ಏನಂತಂದರೆ, ಕೆಲವು ಪ್ರೈವೇಟ್ ಹಾಸ್ಪಿಟ್ಲ್ಗಳು ಎಂಪ್ಯಾನಲ್ ಆಗಬೇಕು. ಎಂಪ್ಯಾನಲ್ ಆಗೋಂಥ ಹಾಸ್ಪಿಟ್ಲ್ಗಳಿಗೆ ಈ ಚಿಕಿತ್ಸೆಗೆ ವೆಚ್ಚ ತುಂಬ ಕಡಿಮೆ ಇದೆ. ಅಷ್ಟು ವೆಚ್ಚ ಅಂದರೆ ತಗೊಂಡು ಚಿಕಿತ್ಸೆ ಕೊಡಲಿಕ್ಕೆ ಆಸ್ಪತ್ರೆಗಳಿಗೆ ಕಷ್ಟ ಸಾಧ್ಯ ಆಗುತ್ತೆ. ಸೊ ಅದನ್ನು ಸರಿಪಡಿಸಿ ಚಿಕಿತ್ಸೆಗೆ ಬರೋ ದರಗಳನ್ನು ಸ್ವಲ್ಪ ಹೆಚ್ಚಳ ಮಾಡಿ, ಮತ್ತು ಎಲ್ಲ ಆಸ್ಪತ್ರೆಗಳಿಗೆ ರೆಪ್ರೆಸೆಂಟೇಟಿವ್ಸ್ ಎಸ್ಪೆಷಲಿ ಫ್ರಮ್ ನಾರ್ತ್ ಕರ್ನಾಟಕ ಇಲ್ಲೇ ಜಾಸ್ತಿ ಇದ್ದಾವೆ ಆಸ್ಪತ್ರೆಗಳು. ಆ ಥರ ಎಂಪ್ಯಾನಲ್ ಆಗಲಿಕ್ಕೆ ಮುಂದೆ ಬರ್ತಕ್ಕಂಥ ಆಸ್ಪತ್ರೆಗಳು ಬೆಂಗಳೂರಿಗಿಂತ ಹೆಚ್ಚಾಗಿ ನಾರ್ತ್ ಕರ್ನಾಟಕದಲ್ಲಿ ಇದ್ದಾವೆ. ಅವ್ರನ್ನ ರೆಪ್ರೆಸೆಂಟೇಟಿವ್ಸ್ನ ಕರೆಸಿ ಅವ್ರ ಜೊತೆ ಚರ್ಚೆ ಮಾಡಿ ಒಂದು ಚಿಕಿತ್ಸಾ ವೆಚ್ಚವನ್ನು ನಿಗದಿಪಡಿಸೋದಕ್ಕೆ ನಾನು ಸರ್ಕಾರದನ್ನು ಒತ್ತಾಯಿಸ್ತೇನೆ. ಅದೇ ರೀತಿ ಈ ಬಾಲ್ಯ ವಿವಾಹ ಮತ್ತು ಬಾಲ್ಯ ಗರ್ಭಪಾತ ಆಗ್ತದೆ, ಈಗ ತಾನೇ ಹೇಳಿದ್ನಲ್ಲ, ಅದಕ್ಕೆ ಏನು ಮಾಡ್ತಾರೆ ಡಾಕ್ಟ್ರು, ಈಗ ಒಬ್ಬರು 18 ವರ್ಷದಿಂದ ಕೆಳಗಿನ ಗರ್ಭಿಣಿ ಮಗು ಬಂದರೆ ನಾವು ವೈದ್ಯರೇನಂತ ಗೌಪ್ಯತೆ ಕಾಪಾಡಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಅವ್ರದ್ದು ಏನು ಹೇಳಲಿಕ್ಕೆ ಹೋಗೋದಿಲ್ಲ. ಆದರೆ ಅವ್ರದ್ದು ಡೆಲಿವರಿ ಟೈಮಿಗೆ ಬಂದಾಗ ಅದು ಬಾಲಗರ್ಭಿಣಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಬಾಲಗರ್ಭಿಣಿ ಮಾಡಿದ ರೇಪ್ ಮಾಡಿದ್ದಾರೆ, ಅದು ಮಾಡಿದ್ದಾರೆ, ಕೇಸ್ ಮಾಡಬೇಕು, ನೀವು ಯಾಕೆ ಇಂಟಿಮೇಟ್ ಮಾಡಲಿಲ್ಲ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ವೈದ್ಯರ ಮೇಲೆ ಸುಮ್ಮನೆ ಕಂಪ್ಲೇಂಟ್ಗಳನ್ನು ಹಾಕೋದು, ಇದು ಮಾಡೋದು ಮಾಡ್ತಿರ್ತಾರೆ. ಆದರೆ ಅದನ್ನು ಗುರುತಿಸ್ಬೇಕಾಗಿರೋದು ನಮ್ಮ ಮಹಿಳಾ ಮತ್ತು ಮಕ್ಕಳ ಕಲ್ಯಾಣ ಇಲಾಖೆ ಇಲ್ಲಿರ್ತಕ್ಕಂಥ ಅಧಿಕಾರಿಗಳು ಅದನ್ನು ಪತ್ತೆ ಮಾಡಿ ಅವ್ರಿಗೆ ಸೂಕ್ತವಾಗಿ ಅವ್ರ ಮೇಲೆ ಕ್ರಮ ತಗೊಳ್ಬೇಕು. ಅದನ್ನು ಬಿಟ್ಬಿಟ್ಟು ಆ ವೈದ್ಯರು ಇನ್ಫಾರ್ಮ್ ಮಾಡಿಲ್ಲ ಅನ್ನೋ ಒಂದೇ ಕಾರಣಕ್ಕೆ ಅವ್ರ ಮೇಲೆ ಕ್ರಿಮಿನಲ್ ಕೇಸ್ಗಳನ್ನೆಲ್ಲ ಬುಕ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದು ತಪ್ಪು, ಅದನ್ನು ನಿಲ್ಲಿಸ್ಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸರ್ಕಾರವನ್ನು ನಾನು ಒತ್ತಾಯ ಮಾಡ್ತೀನಿ. ಇಷ್ಟೆಲ್ಲ ನಮ್ಮ ಮುಖ್ಯ ಬೆಳವಣಿಗೆಗಳಿದೆ. ತಾವೆಲ್ಲ ಬಂದು ಸಹಕರಿಸಿದ್ದಕ್ಕೆ ತಮಗೆ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸ್ತೇನೆ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಪತ್ರಿಕಾ ಮಾಧ್ಯಮದವರಿಗೂ ಮತ್ತು ಎಲ್ಲ ವೈದ್ಯ ಬಂಧುವರಿಗೆ ಹಾರ್ದಿಕ ದೀಪಾವಳಿಯ ಮತ್ತು ಕನ್ನಡ ರಾಜ್ಯೋತ್ಸವದ ಶುಭಾಶಯಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ಹೋದ ವರ್ಷ ಯಲಹಂಕದಲ್ಲಿ ನಾನು ಚಾರ್ಜ್ ತಗೊಂಡಿದ್ದೆ. ಈ ಒಂದು ವರ್ಷ ಆಯಿತು. ಈ ಒಂದು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಕನಿಷ್ಠ 140 ಶಾಖೆಗಳಿಗೆಲ್ಲ ನಾವು ನಮ್ಮ ಬಾಲ್ಕಿ ಬಸವ ಕಲ್ಯಾಣದಿಂದ ಹಿಡಿದು ಮಂಗಳೂರು, ಚಾಮರಾಜನಗರ ಎಲ್ಲ ಕಡೆಯೂ ಅಡ್ಡಾಡಿ ಪ್ರತಿಯೊಂದು ಶಾಖೆಗಳಲ್ಲಿರುವಂಥ ಕುಂದುಕೊರತೆಗಳನ್ನು ನೋಡ್ಕೊಂಡು ಅಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಚಟುವಟಿಕೆಗಳ ಬಗ್ಗೆ ಅರಿವು ತಿಳಿಸಿ, ಅಲ್ಲದೆ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯಲ್ಲಿರುವಂಥ ಕೆಲವು ಸ್ಕೀಮ್ಗಳ ಬಗ್ಗೆ ಅವರಿಗೆಲ್ಲ ಮಹತ್ವವನ್ನು ಹೇಳಿಕೊಟ್ಟು, ಅಲ್ಲದೆ ಜನವರಿಯಿಂದ ಈಗ ನಮ್ಮ ಅಧ್ಯಕ್ಷರು ಹೇಳಿದರು KPME ಬಗ್ಗೆ ಏನಾಗಿದೆ, ಒಂದು ಆಸ್ಪತ್ರೆ ಹೊಸದಾಗಿರಲಿ ಅಥವಾ ನವೀಕರಣ ಮಾಡಬೇಕಾಯ್ತಪ್ಪ ಅಂತಂದ್ರೆ KPMEದ ಒಂದು ಪರ್ಮಿಷನ್ನು ಸರ್ಕಾರದಿಂದ ನಾವು ಪಡೀಲೇಬೇಕು. ಈ ಸರ್ಕಾರದಿಂದ ನಾವು ಪಡೆಯಬೇಕಾತಪ್ಪ ಅಂತಂದರೆ ಅದಕ್ಕೆ ಫೈರ್ NOC ಎಂಬುದು ಒಂದು ಕಡ್ಡಾಯವಾಗಿ ಮಾಡಿದ್ದಾರೆ. ಇದು ಮೊದಲು ಕಡ್ಡಾಯವಾಗಿ ಇದ್ದಿಲ್ಲ. ಈಗ ಕೇವಲ ಹೋದ ವರ್ಷ ಅಕ್ಟೋಬರ್ನಲ್ಲಿ ರಾಮಯ್ಯ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ ಒಂದು ಬೆಂಕಿಯ ಅವಘಡ ಆದ ನಂತರ ಪ್ರತಿಯೊಂದು ಆಸ್ಪತ್ರೆಗಳಿಗೂ ಕಡ್ಡಾಯವಾಗಿ ಮಾಡಿದ್ರು. ಇದನ್ನು ಪ್ರತಿಯೊಂದು ಆಸ್ಪತ್ರೆ ಅಂದರೆ ಈ ಒಂದು ಸಣ್ಣ ಕ್ಲಿನಿಕ್ಕಿಂದ ಹಿಡಿದು ಸಣ್ಣ ಮಧ್ಯಮ ಗಾತ್ರದ ಮತ್ತು ಏನಂತಾರೆ ಕಾರ್ಪೊರೇಟ್ ಹಾಸ್ಪಿಟಲ್ ಎಲ್ಲರಿಗೂ ಫೈರ್ NOC ಕಡ್ಡಾಯ ಮಾಡಿದಾಗ ಈಗಿನದೆಲ್ಲ ನವೀಕರಣ ಮಾಡ್ಬೋದು ಮತ್ತು ರಿಜಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿಸ್ಕೊಳ್ಳೋಕೆ ಏನಂತ ನೋಂದಣಿ ಮಾಡಿಕೊಳ್ಳೋಕೆ ಭಾಳ ತೊಂದರೆ ಆಯಿತು. ಯಾಕಂದರೆ ಈ ಫೈರ್ NOC ಏನು ಇದಾವ ಅವನ್ನ ಪಾಲಿಸಲು ಯಾವ ಆಸ್ಪತ್ರೆಗಳಿಗಿಂದು ಸಾಧ್ಯ ಇಲ್ಲ. ಅದರ ಆಸ್ಪತ್ರೆಯನ್ನು ಪ್ರಾರಂಭ ಮಾಡ್ತಾರೆ, ಅದರ ಸುತ್ತಲೂ ಅವರು ಫೈರ್ ಬ್ರಿಗೇಡ್ ವಾಹನ ಓಡಾಡಲು 4 ಕಡೆ ವಾಹನ ಇದಿರಬೇಕು. ಆಮೇಲೆ 1 ಲಕ್ಷ ನೀರು ಹಿಡಿಯುವಂಥ ಒಂದು ಸಂಪ್ ಕೆಳಗಿರಬೇಕು. ಮೇಲೆ 20-25 ಸಾವಿರ ಇಂಥವೆಲ್ಲ ಇದ್ದಾಗ ಸಣ್ಣ ಪುಟ್ಟ ಆಸ್ಪತ್ರೆಗೆ ಆಗೋದಿಲ್ಲ. ಸೊ ಇದ್ರ ಸಲುವಾಗಿ ನಾವು ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘವರು ಜನವರಿ 25ರಿಂದ ಇಲ್ಲಿವರೆಗೆ ಅಕ್ಟೋಬರ್ 25ರವರೆಗೆ ಕನಿಷ್ಠ ನಮ್ಮ ಆರೋಗ್ಯ ಮಂತ್ರಿಗಳನ್ನು ಒಂದು 4 ಸಲ, ಆಮೇಲೆ ಗೃಹ ಮಂತ್ರಿಗಳೊಂದು 3 ಸಲ ಭೇಟಿಯಾಗಿದ್ದಲ್ಲದೆ ವಿಕಾಸಸೌಧ ಮತ್ತು ಆರೋಗ್ಯ ಸೌಧದಲ್ಲಿ ವಿಧಾನಸೌಧದಲ್ಲಿಯೂ ಸಹ ಜಂಟಿ ಮೀಟಿಂಗ್, ಜಂಟಿ ಸಭೆ ಮಾಡಿ ಅದರಲ್ಲಿ ಆರೋಗ್ಯ ಸಚಿವಾಲಯದ ಪದಾಧಿಕಾರಿಗಳು, ಆ ನಂತರ ಗೃಹ ಖಾತೆಯ ಸಚಿವರು ಮತ್ತು ಫೈರ್ ಡಿಪಾರ್ಟ್ಮೆಂಟು ಎಲ್ಲರೂ ಕೂಡಿ ನಾವು ಅವರಿಗೆ ಮನವರಿಕೆ ಮಾಡಿಕೊಟ್ಟಿವಿ. ಈ ಒಂದು ಏನಂತಲ್ಲ ಸಣ್ಣ ಮತ್ತು ಮಧ್ಯಮ ಗಾತ್ರದ ಆಸ್ಪತ್ರೆಗಳಿಗೆ ನಿಮ್ಮ ಇವೇನು ಮಾನದಂಡಗಳು ಹಾಕಿರಿ ಅವು ಆಗೋದಿಲ್ಲ. ಅದಕ್ಕೆ ಇದನ್ನು ಕಂಪ್ಲೀಟ್ಲಿ ಸರಳೀಕೃತ ಮಾಡಿ ಏನಂತಲ್ಲ ಸಣ್ಣ ಮತ್ತು ಮಾಧ್ಯಮ ಗಾತ್ರದಂದ್ರೂ ಫೈರ್ ಎಕ್ಸಂಪ್ಷನ್ ಮಾಡಿರಿ. ಅದರ ಟೋಟಲಿಯಾಗಿ ಏನಂತಲ್ಲ ಫೈರ್ ಇವರು ಬೇಕಿಲ್ಲ ಅಂತಿದ್ದಿಲ್ಲ. ಫೈರ್ ಪ್ರತಿಯೊಂದು ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ನಾವು ಎಕ್ಸ್ಟಿಂಗ್ವಿಷರ್ಸು, ಹೈಡ್ರೆಂಟ್ಸು ಇವೆಲ್ಲ ಮೇಂಟೈನ್ ಮಾಡ್ತೀವಿ. ಆದರೆ ಇದೆಲ್ಲ ಉಳಿದು ಮೇಂಟೈನ್ ಮಾಡೋಕ್ಕಾಗೋದಲ್ಲ. ಸೊ ಅದರಿಂದ ವಿನಾಯಿತಿ ಮಾಡಿರಿ ನಮಗೆ ಅಂತೇಳಿ ಕೇಳಿಕೊಂಡಿದ್ದಕ್ಕೆ ಅವರು ಏನಂತಲ್ಲ ಇದನ್ನು ಎಲ್ಲರೂ ಆರೋಗ್ಯ ಸಚಿವರಿಗೂ ಎಲ್ಲರಿಗೂ ಅವ್ರಿಗೆ ಮನವರಿಕೆ ಆಯಿತು. ಹಾಗೆ ಈಗ ಅದನ್ನು ಆಲ್ಮೋಸ್ಟ್ ನಾವೇನು ಸಜೆಷನ್ ಮಾಡಿದ್ವಿ ಅವೆಲ್ಲವಕ್ಕೂ ಅವರು ಒಪ್ಪಿಕೊಂಡು ಒಂದು ಕಾಯ್ದೆನ ತರೋರಿದ್ದಾರೆ. ಈ ಇಷ್ಟೊತ್ತಿಗೆ ಬರಬೇಕಾಗಿತ್ತು, ಅಕ್ಟೋಬರ್ ಇದರೊಳಗಾಗಿ ಈ ಹಬ್ಬಗಳೆಲ್ಲ ಬಂದ ಸಲುವಾಗಿ ಸ್ವಲ್ಪ ಅದನ್ನು ಅಲ್ಲಿಂದ ಈಗ ಸೆನ್ಸಸ್ ಒಂದು ಗಣತಿ ನಡೆದ ಸಲುವಾಗಿ ಭಾಳಷ್ಟು ಜನ ಅಧಿಕಾರಿಗಳು ಆ ಕಡೆ ಇದ್ದದಕ್ಕೆ ಅದು ಹಿಂದಕ್ಕೆ ಬಿದ್ದಿದೆ. ಮೋಸ್ಟ್ಲಿ ಇನ್ನೊಂದು 15-20 ದಿವಸದಲ್ಲಿ ನಮಗೆ ವರದಿ ಬರ್ಬೋದು. ಸೊ ಇಂಥ ಒಂದು ಕಾಯ್ದೆ ಬಂತಂತಂದ್ರೆ ಭಾಳ ಅನುಕೂಲ ಆಗುತ್ತದೆ. ಅಲ್ಲಂತ ಎಲ್ಲ ಆಸ್ಪತ್ರೆಗಳಿಗೂ ಇದು ಅನುಕೂಲ ಆಗ್ತದೆ. ಇನ್ನೂ ಒಂದು ಅಂದರೆ ಮೊದಲು ಫೈರದ್ದು ಏನಾದರೂ ನಾವು ಪರ್ಮಿಷನ್ ತೊಗೋಬೇಕಾದ್ರೆ ಪ್ರತಿ ಸಲ ನಾವು ಬೆಂಗಳೂರಿಗೆ ಹೋಗ್ಬೇಕಾಗ್ತಿತ್ತು. ಸೊ ಈಗ ನಾವು ಇಷ್ಟು ಕಷ್ಟಪಟ್ಟು ಎಲ್ಲ ನಾವು ಕಂಟಿನ್ಯೂಸ್ ಆಗಿ 8-10 ತಿಂಗಳಿಂದ ಎಲ್ಲರನ್ನು ಭೇಟಿ ಹೇಳೋ ಸಲುವಾಗಿ ಈಗ ರಾಜ್ಯ ಮಟ್ಟದಿಂದ ಜಿಲ್ಲಾ ಮಟ್ಟಕ್ಕೆ ಅವರು ಜಿಲ್ಲಾ ಮಟ್ಟದಲ್ಲಿ ಅಗ್ನಿಶಾಮಕ ಅಧಿಕಾರಿಗಳಿಗಿಂತ ಪಡಿಬಹುದು ಅಂತೇಳಿ ಹೇಳಿದ್ದಾರೆ. ಸೊ ಈ ಒಂದರಿಂದ ಇದು ಒಂದು ನಮಗೆ ನಮ್ಮ ಒಂದು ಹೋರಾಟಕ್ಕೆ ಸಿಕ್ಕಂಥ ಒಂದು ಪ್ರತಿಫಲ ಅಂತ ನಾವು ಹೇಳ್ಬೋದು. ಇಷ್ಟೆಲ್ಲ ಇದು ಮಾಡಿದ್ದೀವಿ. ಅಲ್ಲದೆ ನಮ್ಮ ಗಂಗಾವತಿ ಭತ್ತದ ನಾಡು, ತಮಗೆಲ್ಲ ಗೊತ್ತಿದೆ, ಹನುಮ ಜನಿಸಿದ ನಾಡು. ಇಂಥ ಒಂದು ನಾಡಿನಲ್ಲಿ ಪ್ರಪ್ರಥಮವಾಗಿ ಗಂಗಾವತಿಯಲ್ಲಿ ನಾವು ಒಂದು 91ನೇ ಏನಂತಲ್ಲ ಸ್ಟೇಟ್ ಕಾನ್ಫರೆನ್ಸನ್ನು ಮಾಡಿದ್ವಿ. ಇದಕ್ಕೆ
ಇಲ್ಲಿಯ ಈ ಒಂದು ವೈದ್ಯ ಸಮ್ಮೇಳನ, ಕರ್ನಾಟಕ ರಾಜ್ಯ ವೈದ್ಯ ಸಮ್ಮೇಳನ ತುಂಬ ಚೆನ್ನಾಗಿ ನಡೀತಾ ಇದೆ. ಸೊ ಅದಕ್ಕೆ ಗಂಗಾವತಿಯ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘಕ್ಕೆ ಹಾಗೂ ಗಂಗಾವತಿಯ ನಾಗರಿಕರಿಗೆ ನಾವು ಧನ್ಯವಾದವನ್ನು ಹೇಳ್ತೇವೆ. ಇನ್ನು ಮುಂದಿನ ವೈದ್ಯ ಸಮ್ಮೇಳನ ನಮ್ಮ ಶಿವಮೊಗ್ಗದಲ್ಲಿ ನಡೀತಿದೆ. ಅಲ್ಲಿ ಕೂಡ ತಾವೆಲ್ಲ ಬರಬೇಕು ಅಂತ ಈ ಮೂಲಕ ತಮ್ಮೆಲ್ಲರಿಗೂ ಕೂಡ ನಾವು ಆಹ್ವಾನ.
ಇದಾದ ನಂತರ ಸಾರ್ವಜನಿಕರಿಗೆ ಅನುಕೂಲವಾಗಲಿ ಎಂಬ ಒಂದು ಉದ್ದೇಶದಿಂದ ನಾವು ಸಾಕಷ್ಟು ಸಮಾಜಮುಖಿ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು, ಅಂದರೆ ವೈದ್ಯರ ನಡೆ ಹಳ್ಳಿಯ ಕಡೆ, ವೈದ್ಯರ ನಡೆ ಶಾಲೆಯ ಕಡೆ, ಇದಲ್ಲದೆ ಅಂಗಾಂಗ ದಾನ, ದೇಹದಾನ ಮತ್ತು ಪರಿಸರ ಸಂರಕ್ಷಣೆ ಬಗ್ಗೆಯೂ ಸಹ ನಾವು ಸಾಕಷ್ಟು ಅರಿವು ಮೂಡೋ ಕಾರ್ಯಕ್ರಮವನ್ನು ನಮ್ಮ ಸುತ್ತಮುತ್ತ ಗಂಗಾವತಿ ಮತ್ತು ಹಳ್ಳಿಗಳಲ್ಲಿ ನಾವು ಹಮ್ಮಿಕೊಂಡಿದ್ದೀವಿ. ಇದೇ ರೀತಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಎಲ್ಲ ಶಾಖೆಗಳು ಸಹ ತಮ್ಮ ಊರುಗಳ ಸುತ್ತಮುತ್ತ ಇಂಥೆಲ್ಲ ಸಮಾಜಮುಖಿ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಹಮ್ಮಿಕೊಂಡಿದ್ದಾವೆ. ಸೊ ಇದು ಏನಂತಲ್ಲ ನಾವು ಸಮಾಜಕ್ಕೆ ನೀಡುವ ಒಂದು ಅಳಿಲು ಸೇವೆ ಅಂತಲೇ ಹೇಳ್ಬೋದು. ಸೊ ಇಷ್ಟು ಏನಂತಲ್ಲ ಇದನ್ನು ನಡೀತಾ ಇದೆ. ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದು ನಮ್ಮ ಒಂದು ಇದನ್ನು ಕವರ್ ಮಾಡಿದಂಥ ತಮಗೆಲ್ಲರಿಗೂ, ಪತ್ರಿಕಾ ಮಾಧ್ಯಮದವೆಲ್ಲರಿಗೂ ಏನಂತಲ್ಲ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಗಂಗಾವತಿ ಮತ್ತು ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ತುಂಬ ಹೃದಯ ಧನ್ಯವಾದಗಳನ್ನು ನಾನು ಅರ್ಪಿಸ್ತಾ ಇದ್ದೀನಿ.
ಸೊ ನಮ್ಮ ಕರೆಗೆ ಹೋಗ್ಬಿಟ್ಟು ಆಗಮಿಸಿದಂಥ ಎಲ್ಲ ಪತ್ರಿಕಾ ಮಾಧ್ಯಮಕ್ಕೆ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸುತ್ತಾ, ಇವತ್ತು ಸೈಂಟಿಫಿಕ್ ಕಮಿಟಿ ಇನಾಗ್ರೇಷನ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಅಂದರೆ ನಿನ್ನೆ ವರ್ಕ್ಶಾಪ್ ಇನಾಗ್ರೇಷನ್ ಮಾಡಿದ್ವಿ, ಅಂದರೆ ಕಾರ್ಯಾಗಾರ ಉದ್ಘಾಟನೆಗೊಂಡಿತ್ತು. DC ಸಾಹೇಬರು ಮತ್ತು ನಮ್ಮ SP ಸಾಹೇಬರು ಬಂದರು. ಇವತ್ತು ಏನಿದೆ, ಇವತ್ತಿನಿಂದ ನಾಳೆವರೆಗೂ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್, ಅಂದರೆ ಎಲ್ಲ ವಿಷಯಗಳ ಬಗ್ಗೆ ಚರ್ಚೆ ತಿಳಿದ ತಜ್ಞರು ಬರ್ತಾ ಇದ್ದಾರೆ. ಬೆಂಗಳೂರಿಂದ ಆಸ್ಟರ್, CMI, ಅಪೋಲೋ, ನಾರಾಯಣ ಫೋರ್ಟಿಸ್ ಬರ್ತಿದ್ದಾರೆ. ಹಾಗೂ ಬೇರೆ ವೈದ್ಯರು ತಮ್ಮ ಅನುಭವಗಳನ್ನ ಇಲ್ಲಿ ಹಂಚಿಕೊಂಡು ಮುಂದಿನ ವೈದ್ಯರಿಗೆ ದಾರಿ ತೋರಿಸ್ತಾರೆ. ಸೊ ದಯವಿಟ್ಟು ತಾವೆಲ್ಲ ಪತ್ರಿಕಾ ಮಾಧ್ಯಮ ಇದರಲ್ಲಿ ಪಾಲ್ಗೊಳ್ಬೇಕಂತ ಕೇಳ್ಕೊಳ್ತಾ, ನಮ್ಮ ಕರೆ ಹೋಗ್ಬಿಟ್ಟು ಆಗಮಿಸಿದ ನೀವೆಲ್ಲರೂ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದಗಳು ತಿಳಿಸ್ತಾ, ಅಲ್ಪ ಉಪಹಾರ ಸೇವನೆಗೆ ನಮ್ಮೊಳಗೆ ಬರಬೇಕಂತ ಕೇಳ್ಕೊಳ್ತೀನಿ. ಥ್ಯಾಂಕ್ ಯು.
ಯಾರು
Hello, hello. With great pride and enthusiasm, we welcome you all to the scientific session inauguration of Medicon 2025, a celebration of knowledge, innovation and learning. Science is the foundation of progress, and today's inauguration marks the beginning of thought-provoking sessions, inspiring discussions and transformative ideas. To begin this grand occasion, let us have the honor of inviting our distinguished dignitaries onto the dais. First and foremost, we invite the dynamic and dedicated leader of our association, Dr. V.V. Chinivalar Sir, the State President of IMA Karnataka State Branch, to kindly come onto the dais. Joining him, we cordially invite the ever-energetic and efficient State Honorary Secretary of IMA KSB, Dr. Suriraju V. Sir, to please come onto the dais.
It's time to welcome the esteemed dignitaries to grace this scientific inauguration. We are deeply honored to welcome our inaugurator, Dr. Honegoda sir, past President IMA KSB. We are equally delighted to welcome our chief guest, Dr. S.P. Lakol sir, past President IMA KSB to the stage. We also would like to call upon the guest of honor, Dr. G. Chandrapa sir, Rajotsava awardee and senior IMA KSB member Gangavati. We would also like to call upon Dr. A. Somaraju sir, senior IMA KSB member.
We now invite the leaders who carry forward the mission of IMA KSB with dedication and purpose. Dr. Veer Bhadraya PA, incoming president of IMA KSB. Next, we have Dr. Harish Vilantabettu, president-elect IMA KSB. Dr. Shankar Narayana KG, state treasurer of IMA KSB. May we request you all to kindly come onto the dais and grace the occasion. And also, now we take great pleasure in inviting Dr. Pawan Kumar Patil, the respected KMC observer, to kindly come onto the dais and grace the occasion with his presence.
We also invite the academic and organizing pillars of Medicon 2024. Dr. Malanagowda H, organizing chairman, Dr. A.S.N. Raju, president IMA Gangavati branch, Dr. K.M. Madhusudan, chairman, Medicon scientific committee, Dr. Amarish Patil, organizing secretary, Dr. Nagaraj H, secretary, IMA Gangavati branch. Please join us on the dais.
Ladies and gentlemen, let's give a big round of applause to all our esteemed dignitaries who have graced the dais this morning for the scientific session inauguration of Medicon 2025. May the session ignite ideas, inspire young minds, and strengthen our collective journey in the world of medicine.
To begin this inspiring morning on a divine note, let us invoke the blessings of the Almighty. We now invite Dr. Krupa to lead us with the invocation.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते
सुराळि परिपालन परं पाशमान पाशाकुशधरं भूसुराळि परिपालन परं वन्दे निशमहं वारणवदनं नन्दीश वाहन वरनन्दनं वन्दे निशमहम्. Thank you.
Thank you, Dr. Krupa, for the soulful and serene invocation, setting the perfect tone for the auspicious morning. Now, let us rise for the IMA prayer and flag salutation, which symbolize our unity, dedication, and service to the medical fraternity. We request Dr. Nagaraj H, the Honorary Secretary of IMA Gangavati branch, to kindly lead us in the prayer and flag salutation.
Good morning. Please repeat after me. I am a prayer. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. I am a flag salutation. Only I will say. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Dr. Nagraj sir, for leading us with pride and purpose in upholding the IMA spirit. To extend a warm and heartfelt welcome to all our dignitaries, guests and delegates gathered here for the scientific session inauguration, we now invite Dr. ASN Raju, the dynamic president of IMA Gangavati branch, to deliver the welcome address.
Respected dignitaries on the dais, distinguished faculty members, dear delegates, and my beloved IMA family, very warm welcome to each one of you. Firstly, I like to extend a warm welcome to our IMA KSB President, Dr. V.V. Chinwala sir. Welcome, sir. I also extend a warm welcome to IMA KSB Honorary Secretary Dr. Sundaraju Will sir. It is my honor to extend a warm welcome to today's scientific session program inaugurator Dr. Honegoda sir, past President IMA KSB. Welcome sir. It's my pleasure to welcome Dr. S.B. Lakwal sir, past President IMA KSB. It's my proud privilege to extend a very warm and heartfelt welcome to Dr. Chi Chandrappa sir, Rajyotsava awardee and a senior IMA Gangavati member. On behalf of 91st Medicon and IMA Gangavati, I also welcome Dr. A. Somaraju sir, senior IMA Gangavati member. A warm welcome to you sir. It gives me immense pleasure to extend a warm welcome to our IMA incoming President, Dr. Veerbhadraya T.S. sir. Welcome, sir. On behalf of 91st Medicon, IMA Gangavati, also welcome IMA KSB President-elect, Dr. Harish Delantabettu, sir. Also welcome IMA KSB Treasurer, Dr. Shankar Narayan KH, sir. It is indeed privilege to extend a warm and respectful welcome to KMC Observer Dr. Pavan Kumar Patil sir. I also welcome 91st Medicon Chairman Dr. Malangoda H. I extend a warm welcome to the Scientific Committee Chairman, Dr. K. N. Madhusudan, sir. I also welcome 91st Medicon Organizing Secretary, Dr. Amrish Patil. Lastly, I welcome IMA Gangavati Branch Secretary Dr. Nagaraj H. It is indeed a matter of immense pride and privilege for me, on behalf of 91st Medicon and IMA Gangavati branch, I extend a warm and heartfelt welcome to each one of you to the scientific session inauguration of 91st Medicon. This scientific program is a heart of medical conference. It embodies our collective pursuit of knowledge and spirit of inquiry and commitment to continuous learning. These sessions offer a platform to interact between senior experts, young professionals and academicians, where wisdom meets enthusiasm and experience inspires innovation. We are truly grateful to the eminent speakers and faculty who have traveled from across the state and beyond to share their valuable insights. Your presence elevates the stature of the conference and enriches the minds of all participants. Once again, on behalf of 91st Medicon and IMA Gangavati, I extend a cordial welcome to all our distinguished guests and delegates. We hope you will cherish not only the academic excellence of this conference, but also the warmth, hospitality and culture heritage of Kishkinda. Thank you. Jai Hind, Jai Karnataka, long live IMA.
Likewise, I also welcome our IMA Gangavati President, Dr. A. Sanravishwar, to his inaugural function. I request Dr. Hanmantappa sir to hand over the floral bouquet.
Hello. Now we move to the most awaited moment of this morning, the formal inauguration of the scientific session of Medicon 2025. We request our dignitaries on the dais to kindly come forward and inaugurate the session. Now we have lighting of the lamp as a symbolic gesture to bring in light to this occasion.
ಸ್ವಲ್ಪ ಹಿಂದೆ ಬನ್ನಿ ಸರ್, ಹಂಗೆ ಸ್ವಲ್ಪ ಹಿಂದೆ ಬನ್ನಿ. ಅದೇ ಅಣ್ಣ, ಸ್ವಲ್ಪ ಸೈಡ್ ಅಣ್ಣ.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम्.
Hello. It is our privilege to invite our inaugurator for the inaugural address. Now invite our inaugurator, Dr. Honegoda sir, to please give the inaugural address.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಬಹಳ ಚಿಕ್ಕವನು ಈ ಸೆಷನ್ನನ್ನು ಇನಾಗ್ರೇಟ್ ಮಾಡಲಿಕ್ಕೆ, ಆದರೆ ದಿಗ್ಗಜರು ಇದ್ದರೂ ಸಹ ನನಗೊಂದು ಅವಕಾಶವನ್ನು ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ನನ್ನ ಹೃದಯಪೂರ್ವಕವಾದ ಧನ್ಯವಾದಗಳನ್ನು ಗಂಗಾವತಿ ಬ್ರಾಂಚ್ಗೆ ಹೇಳ್ತಿದ್ದೇನೆ. ಇಲ್ಲಿ ನೆರೆದಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಚಂದ್ರಪ್ಪನವರು ಹಾಗೂ ರಾಜ್ಯೋತ್ಸವ ಪ್ರಶಸ್ತಿ ಅಂತ ವ್ಯಕ್ತಿಯ ಮುಂದೆ ನಾವು ಮಾತಾಡೋದು ಕಷ್ಟ ಅನ್ನೋ ಕಾಣುತ್ತೆ. ಆದರೂ ಸಹ ನನಗಿಲ್ಲಿ ಕೊಟ್ಟಿರ್ತಕ್ಕ ಜವಾಬ್ದಾರಿಯನ್ನು ನಿರ್ವಹಿಸೋಕ್ಕೋಸ್ಕರ ಸಣ್ಣದ 2 ಮಾತುಗಳನ್ನು ಹೇಳಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತೇನೆ. ನಮ್ಮ ರಾಜ್ಯ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದ ಚಿನ್ನಿವಾಲ ಅವರೇ ಹಾಗೂ ನಿಕಟಪುರ ಅಧ್ಯಕ್ಷರಾದಂಥ ವೀರಪ್ಪ ಹಾಗೂ ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ಮುಂದಿನ ವರ್ಷಕ್ಕೆ ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ಹರೀಶ್ ತೆಲಂಗ್ ಭಟ್ ಅವರೇ ಹಾಗೂ ಸೋಮರಾಜು ಹಿರಿಯ ಸದಸ್ಯರಾದ ಗಂಗಾವತಿಯವರೇ ಹಾಗೂ ನನ್ನ ಸ್ನೇಹಿತರಾದಂಥ ಲಕ್ಕೋಳವರೇ ಹಾಗೂ ಕಾರ್ಯದರ್ಶಿಗಳಾದಂಥ ಸೂರ್ಯರಾಜು ಅವರೇ, ಪವನ್ ಪಾಟೀಲ್ ಅವರೇ ಹಾಗೂ ರಾಜು ಅವರೇ ಹಾಗೂ ಮಲ್ಲನಗೌಡ ಅವರೇ, ಎಲ್ಲರಿಗೂ ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಇರತಕ್ಕಂಥ ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರವನ್ನು ತಿಳಿಸ್ತಾ, ನನ್ನ ಸ್ವಾಗತವನ್ನು ತಿಳಿಸ್ತಾ ಮತ್ತು ತಳಗೆ ಕೂತಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಹಿರಿಯ ಸದಸ್ಯರು ಮತ್ತು ಕಿರಿಯ ಸದಸ್ಯರಿಗೂ ನನ್ನ ಹೃದಯಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಹೇಳ್ತಾ, ಏನೆಂದರೆ ಇಲ್ಲಿ ಕಾನ್ಫರೆನ್ಸನ್ನು ತೆಗೆದುಕೊಳ್ಳೋಕ್ಕೇ ಭಾಳ ಕಷ್ಟಪಟ್ಟು ಆ ಒಂದು ಲೇಡಿ, ಅವರ ಹೆಸರು ನನಗೆ ಗೊತ್ತಿಲ್ಲ, ಡಾಕ್ಟರ್ ವೀಣಾ ಅವರನ್ನು ಇಲ್ಲಿ ಸ್ನಾಗಿಸ್ಬೇಕು ಅಂತ ಕಾಣುತ್ತೆ. ಕಾರಣ ಇಷ್ಟೇ, ಆ ಅಲ್ಲಿ ಮಾತಾಡಿರ್ತಕ್ಕಂಥ ಮಾತು, ಅವರ ಹೇಳಿದ್ದಂಥ ವಿಷಯಗಳನ್ನ ನೋಡಿದರೆ ನನಗೇನೋ ಇದೆ ಅಂತ ತಿಳ್ಕೊಂಡೆ. ಅದು ಇದೆ, ತುಂಬ ಚೆನ್ನಾಗಿ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ತುಂಬ ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮಾಡುತ್ತಾ ಇದ್ದಾರೆ. ಈ ಥರ ಒಂದು ತಾಲೂಕು ಲೆವೆಲಲ್ಲಿ ಆ್ಯನ್ಯುವಲ್ ಕಾನ್ಫರೆನ್ಸನ್ನು ಮಾಡ್ತಾ ಇರೋದು ಆ್ಯಕ್ಚುಲಿ ಒಂದು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇದ್ದರೆ ಒಂದು ಇವೆಲ್ಲ ಸುಲಭವಾಗ್ತದೆ. ಇಲ್ಲಿ ಏನೂ ಇಲ್ಲದಂಥ ಪ್ರದೇಶದಲ್ಲಿ ಇಷ್ಟು ಅದ್ಧೂರಿಯಾಗಿ ಮಾಡ್ತಾ ಇರ್ತದ್ದು ತುಂಬ ಹೃದಯದ ಸ್ವಾಗತವನ್ನು. ಹಾಗೂ ಸುವರ್ಣ ಮಹೋತ್ಸವ 50 ವರ್ಷಗಳು ಕಳೆದಿದೆ ಈ ಶಾಖೆಯ ಈ ಶಾಖೆಗೆ ನನ್ನ ಹೃದಯಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಹೇಳ್ತಾ ಇದ್ದೇನೆ. ಹಾಗೂ ಈಗ ಇನ್ನೊಂದು ಅಂದರೆ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಬೇಕಾಗಿರ್ತಕ್ಕಂಥದ್ದು, ಈಗ KMCಯಿಂದ ಒಂದು 5 ವರ್ಷಕ್ಕೆ ಒಂದು ಸಾರಿ ರಿಜಿಸ್ಟರ್ ಮಾಡಬೇಕು. ಯಾರು ಮಾಡಿಸಿಲ್ವೋ ದಯವಿಟ್ಟು ಮಾಡಿಸಿ. 5 ವರ್ಷ. ಈಗ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ನು ಅಪ್ಗ್ರೇಡಿಗೋಸ್ಕರ, ನಿಮ್ಮ ನಾಲೆಡ್ಜಿಗೋಸ್ಕರ ಈಗ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅದನ್ನು ಕ್ರೆಡಿಟ್ ಪಾಯಿಂಟ್ಸ್ಗಳನ್ನ ತಗೊಳ್ಳಿ, ಮುಂದೆ ಸಾರಿ. ಅಪ್ಗ್ರೇಡ್ ಆಗದೇ ಹೋದರೆ ಈ ದಿನಗಳಲ್ಲಿ ನನ್ನಂಗೆ ಓಲ್ಡ್ ಡಾಕ್ಟರ್ ಆಗ್ತೀವಿ, ಪ್ಯಾರಾಸೈಟಮಲ್ನೇ ಬರ್ಕೊಂಡಿರ್ಬೇಕಾಗತ್ತೆ. ಈಗ ಹಲವಾರು ಸಂಸ್ಕಾರಗಳಾಗಿ ತುಂಬ ಉತ್ತಮವಾಗಿ ಇದು ಆರೋಗ್ಯ ಸಮಸ್ಯೆ ಮುಂದುವರೆದಿದೆ. ಆರೋಗ್ಯ ಏಳಿಗೆ ಆಗ್ತಾಯಿದೆ. ಎಲ್ಲರೂ ಆರೋಗ್ಯದ ವಯಸ್ಸು ಈಗ 70-80 ವರ್ಷಕ್ಕೆ ದಾಟಿದ್ದಾರೆ, ಎಕ್ಸ್ಪೆಕ್ಟೆಡ್ ವಯಸ್ಸು. ಹಾಗೂ ಈ ಮಾತುಗಳನ್ನು ಹೇಳಲಿಕ್ಕೆ ನನಗೆ ಅವಕಾಶ ಕೊಟ್ಟಂಥ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಹೃದಯಪೂರ್ವಕವಾದ ವಂದನೆಗಳನ್ನು ಹೇಳ್ತಾ ನನ್ನ ಮಾತನ್ನು.
Dr. Honegoda sir, a visionary IMA leader, past state president, also a senior member of the Karnataka Medical Council, and is also the best Krishika awardee of Karnataka. Thank you very much sir for your inspiring words and for gracing this occasion with a valuable presence. Thank you sir. Please give a huge round of applause. Now, I would like to call upon Dr. A. Somaraju sir to address the gathering.
IMA Karnataka State Branch and our friend and colleague Dr. V. Chinwala, Dr. Honegoda, past President IMA KSB, Dr. Veerabhadraya, Chief Guest of today's function, Dr. Chandrapa, all the office bearers of the state IMA, all the honorable speakers of today's scientific session, all my colleagues from IMA Gangavati and delegates from all the parts of Karnataka. It is an honor for IMA Gangavati to host such a wonderful state conference. I really appreciate all the efforts of state as well as our local IMA to make the conference a grand success. Today we are going to have a feast of lectures from eminent speakers in various subjects like Dr. Shivkumar Kumbar, Dr. Jay Prakash Patil, Dr. Manoj Butte, Dr. Girish Navasundi, Dr. Manoj Patil, Dr. Nataraj KS, Dr. Sandeep Kumar, Dr. Rudresh Tabali, Dr. Nishal N. Hegde, Dr. Nagesh Malesh, and Dr. Durai. We extremely thank all the guests, delegates and speakers and organizers attending this and participating in this grand function. I wish the IMA State Conference a grand success. Thank you.
Hello. Thank you so much, sir, for your motivating and heartfelt words, which will truly inspire our medical fraternity. Now, we invite our beloved leader, Dr. V.V. Chiniwala, sir, the State President of IMA Karnataka State Branch, whose vision, energy and dedication has taken IMA KSP to new heights. We call upon the stage to address the gathering, sir.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ರಾಜ್ಯದ ನಾನಾ ಭಾಗಗಳಿಂದ ಬಂದಂಥ ಸದಸ್ಯರೇ, ಪ್ರತಿನಿಧಿಗಳೇ, ವೇದಿಕೆಯ ಮೇಲೆ ಆಸೀನರಾದಂಥ ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರೇ, IMA KSP ಪದಾಧಿಕಾರಿಗಳೇ, ಮುಂಭಾಗದಲ್ಲಿರುವ ಗಣ್ಯಮಾನ್ಯರೇ, ಮಹನೀಯರೇ, ಮಹಿಳೆಯರೇ, ಎಲ್ಲರಿಗೂ ದೀಪಾವಳಿಯ ಮತ್ತು ಕನ್ನಡ ರಾಜ್ಯೋತ್ಸವದ ಶುಭಾಶಯಗಳೊಂದಿಗೆ ಇಂದಿನ ಈ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ಸ್ ಉದ್ಘಾಟನೆಯನ್ನು ಮಾಡಿರುವಂಥ ನಮ್ಮ ನೆಚ್ಚಿನ ನಾಯಕರಾದಂಥ ಡಾಕ್ಟರ್ ಹೊನ್ನೇಗೌಡರು, ಮಾಜಿ ಅಧ್ಯಕ್ಷರು ಮತ್ತು KMC ಮೆಂಬರ್ ಅವರೇ, ಡಾಕ್ಟರ್ SB ಲಕ್ಕೋಳವರು ಮಾಜಿ ಅಧ್ಯಕ್ಷರು, ನಮ್ಮ ಹಿರಿಯರು ಡಾಕ್ಟರ್ ಚಂದ್ರಪ್ಪನವರು 15-20 ವರ್ಷಗಳ ಹಿಂದೆ ನಮ್ಮ ಗಂಗಾವತಿಯಲ್ಲಿ ಒಂದು ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡಬೇಕು, ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡಿರಿ ಅಂತಂಥೇಳಿ ನಮಗೆ ಬಹಳ ಸಲ ಹೇಳಿದರು. ಅವರ ಒಂದು ಕನಸನ್ನು ನಾವು ಇಂದು ಈಡೇರಿಸಿದ್ದೀವಿ ಅಂಥೇಳಿ ನನಗೆ ತುಂಬ ಸಂತೋಷವಾಗುತ್ತದೆ. ಸೊ ಅವರ ಸಮ್ಮುಖದಲ್ಲಿಯೇ ಈ ಒಂದು ಸೈಂಟಿಫಿಕ್ ಉದ್ಘಾಟನೆಗೂ ಸಹ ಅವರು ಅಂತೆಲ್ಲ ಅತಿಥಿಗಳಾಗಿ ಬಂದಿದ್ದಾರೆ. ಅವರಿಗೂ ನಮ್ಮ ಹಿರಿಯ ಸರ್ಜನರಾದಂಥ ಡಾಕ್ಟರ್ A ಸೋಮರಾಜು ಅವರಿಗೂ ಸಹ ನಾನು ಸುಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಇಂದು ನಡೆದಿರುವಂಥ ಈ IMA ಸೈಂಟಿಫಿಕ್ ಉದ್ಘಾಟನೆ ವೈದ್ಯಕೀಯ ಜ್ಞಾನಯಾತ್ರೆಯ ಮತ್ತೊಂದು ಮಹತ್ವದ ಹಂತವಾಗಿದೆ. ವಿಜ್ಞಾನ ಮತ್ತು ಮಾನವೀಯತೆಯ ಸೇತುವೆಯಾಗಿರುವ ವೈದ್ಯ ವೃತ್ತಿಯು ಪ್ರತಿದಿನವೂ ಹೊಸ ಆಯಾಮಗಳನ್ನು ಹುಡುಕುತ್ತಲೇ ಇದೆ. ಈ ವೇದಿಕೆ ಕೇವಲ ಅಧ್ಯಯನದ ಸ್ಥಳವಲ್ಲ, ಇದು ಅನುಭವಗಳ ವಿನಿಮಯ, ಹೊಸ ತಂತ್ರಜ್ಞಾನಗಳ ಹರಿವು ಹಾಗೂ ನವೀನ ಸಂಶೋಧನೆಗಳ ಸ್ಪಂದನೆಗಾಗಿ ಸೃಷ್ಟಿಸಲ್ಪಟ್ಟ ಪವಿತ್ರವಾದ ಒಂದು ವೇದಿಕೆಯಾಗಿದೆ. ನಮ್ಮಲ್ಲಿ ಪ್ರತಿಯೊಬ್ಬರೂ ಇಲ್ಲಿ ಪಡೆದ ಜ್ಞಾನವನ್ನು ನಮ್ಮ ಸೇವಾ ಕ್ಷೇತ್ರದಲ್ಲಿ ಅನ್ವಯಿಸಿದಾಗ ಮಾತ್ರ ಈ ಸಮ್ಮೇಳನದ ಸಾರ್ಥಕತೆ ಅರಿಯುತ್ತದೆ. ಆರೋಗ್ಯ ಕ್ಷೇತ್ರವು ಇಂದು ವೇಗವಾಗಿ ರೂಪಾಂತರಗೊಳ್ಳುತ್ತಿದೆ. ಕೃತಕ ಬುದ್ಧಿಮತ್ತೆ, ಡಿಜಿಟಲ್ ಆರೋಗ್ಯ ಸೇವೆ ಮತ್ತು ಪ್ರಿವೆಂಟಿವ್ ಹೆಲ್ತ್ ಕೇರ್ ಇವುಗಳೆಲ್ಲ ನಮ್ಮ ಸೇವೆಗೆ ಹೊಸ ಮಾರ್ಗಗಳನ್ನು ತೆರೆದಿವೆ. ಆದರೆ ಈ ಬದಲಾವಣೆಯ ಮಧ್ಯೆಯೂ ರೋಗಿಯು ನಮ್ಮ ಕೇಂದ್ರ ಬಿಂದು, ಮಾನವೀಯತೆ ನಮ್ಮ ಮೂಲ ಧ್ಯೇಯ ಎನ್ನುವುದನ್ನು ನಾವು ಸದಾ ನೆನಪಿನಲ್ಲಿಡಬೇಕು. ಈ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ಗಳು ಹೊಸ ವಿಚಾರ, ಹೊಸ ಪ್ರೇರಣೆ, ಹೊಸ ದೃಷ್ಟಿಕೋನ ನೀಡಲಿ ಎಂದು ನಾನು ಹಾರೈಸುತ್ತೇನೆ. IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ಭಾಗವಹಿಸಿರುವ ಎಲ್ಲ ವೈದ್ಯ ಬಂಧುಗಳಿಗೆ ಹಾರ್ದಿಕ ಶುಭಾಶಯಗಳನ್ನು ಕೋರುತ್ತಾ, ನಾವು ಒಂದಾಗಿ ಕಲಿಯೋಣ, ಒಂದಾಗಿ ಬೆಳೆಯೋಣ, ಒಂದಾಗಿ ಸೇವೆ ಸಲ್ಲಿಸೋಣ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ. IMA ಚಿರಾಯುವ.
Thank you, sir, for your ever-inspiring leadership and motivating words that always energize our IMA family. We now move on to honoring our esteemed guest. I like to call upon Dr. Honnegowda sir to come forward, and I request the dignitaries, the guests that we are honoring today. We have Dr. Honnegowda sir, Dr. SB Lakkol, Dr. Raj Mohan sir, the first secretary of IMA Gangavati that was established in 1975 under the leadership of late Dr. K. Narayana Achar. Please give a huge round of applause to all the three guests of honor.
ಅಕ್ಟೋಬರ್ 25, 1975ರಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಗಂಗಾವತಿ ಸ್ಥಾಪನೆಗೊಂಡಿತ್ತು. ಅದೇ ಅಕ್ಟೋಬರ್ 25, 2025ರಲ್ಲಿ ನಾವು 50 ವರ್ಷದ ಅಮೃತ ಮಹೋತ್ಸವನ ಆಚರಣೆ ಮಾಡ್ತಿದ್ದೇವೆ. ಈ ನಮ್ಮ ಕವಿ ಸ್ಮರಣೀಯ ಕ್ಷಣದಲ್ಲಿ ನಿಮ್ಮ ಮಂದಿಗೆ ಕಳಿತಿದ್ದೀವಲ್ಲ, ಅದೇ ನಮಗೆಲ್ಲರಿಗೂ ಭಾಳ ಒದಗಿ ಹೋದಂಥ ಅದೃಷ್ಟ ಅಂತ ಹೇಳ್ಕೊಳ್ತಾ, ಈ 1975ರಲ್ಲಿ ಈ ಸಂಘದ ಸ್ಥಾಪನೆ ಮಾಡಿದಂಥ ಕಾರ್ಯದರ್ಶಿಗಳಾದಂಥ ಡಾಕ್ಟರ್ ರಾಜ್ಮೋಹನ್ ಸರ್ ಅವರು ನಮ್ಮೊಂದಿಗಿದ್ದಾರೆ. ಇದಕ್ಕಿಂತ ವಿಸ್ಮಯ ಇನ್ನೇನಾದ್ರು ಬೇಕಾ? ಸೊ ಜೋರಾದ ಚಪ್ಪಾಳೆ ಅದ್ಭುತವಾದ ವ್ಯಕ್ತಿಗೆ ಕೇಳ್ಕೊಳ್ತಾ, ಡಾಕ್ಟರ್ ರಾಜ್ಮೋಹನ್ ಸರ್ ಅವರು ನಮ್ಮ ಕಂಪ್ನಿಯಲ್ಲಿ ಕಾರ್ಯನಿರ್ವಹಿಸಿ ಈಗ ಬೆಂಗಳೂರಲ್ಲಿ ಕಾರ್ಯನಿರ್ವಹಿಸ್ತಾ ಇದ್ದಾರೆ. ಅವರು ಸಮಾಜಮುಖಿಗಳ ಕೆಲಸಗಳನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ನಮ್ಮ ಗಂಗಾವತಿಯಲ್ಲಿ ಕೂಡ ಸಮಾಜಮುಖಿ ಕೆಲಸಗಳನ್ನು ಮಾಡೋಕ್ಕೆ ಪ್ರೇರೇಪಣೆ ನೀಡಿದ್ದಾರೆ. ಅದೇ ಅವರ ಪ್ರೇರೇಪಣೆ ಒಂದು ನಮ್ಮ ಹಿರಿಯರಾದಂಥ ಡಾಕ್ಟರ್ ಸೋಮರಾಜು ಸರ್ ಅವರು, ಡಾಕ್ಟರ್ ಚಂದ್ರಪ್ಪ ಸರ್ ಅವರು ಕಳೆದ 30 ವರ್ಷಗಳಿಂದ ರೆಸಿಡೆನ್ಷಿಯಲ್ ಸ್ಪೆಷಲಿ ಏಬಲ್ಡ್ ಶಾಲೆಯನ್ನು ನಡೆಸ್ತಾ ಇದ್ದಾರೆ. ರೆಸಿಡೆನ್ಷಿಯಲ್ ಅಂದರೆ ವಸತಿ ಸಹಿತ ವಿಶೇಷ ಚೇತನ ಮಕ್ಕಳ ಶಾಲೆಯನ್ನು ನಡೆಸ್ತಿರೋಂಥ ನಮ್ಮ ಚಂದ್ರಪ್ಪ ಸರ್ ಮತ್ತು ಸೋಮರಾಜು ಸರ್ ಅವರು ಕೂಡ ಜೋರಾದ ಚಪ್ಪಾಳೆಯನ್ನು ಬಯಸ್ತಾರೆ. ಇವರೊಂದಿಗೆ ಡಾಕ್ಟರ್ ಮಾಧವ್ ಶೆಟ್ಟಿ ಸರ್ ಅವರು ನಮ್ಮ ಹಿರಿಯರು, ಅವರು ಕೂಡ ಭಾಳ ಉತ್ತಮವಾದ ಕೆಲಸ ಇದ್ದಾರೆ. ಸೊ ಈ ಕ್ಷಣದಲ್ಲಿ ಎಲ್ಲ ನೆರೆದಂಥ ಎಲ್ಲರಿಗೂ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದ ತಿಳಿಸಿದ ಧನ್ಯವಾದಗಳು.
Every memorable moment deserves a word of gratitude. To express our heartfelt appreciation to who all have contributed to the success of this inauguration, we invite Dr. K.N. Madhusudan Sir, the Chairman of Medicon Scientific Committee, to propose the vote of thanks.
We now like to felicitate our KMC observer, Dr. Pawan Kumar Patil sir. We request you to come forward to the dais, sir. Please give a huge round of applause to Dr. Pawan Kumar Patil sir.
ಸೈಡ್ ಬರ್ರ ಒಬ್ರು ತೆಗಿರಿ.
ನಾವು ಪಾಲ್ಗೊಳ್ಳುವಂಥ ಪ್ರತಿ ಸಮಾವೇಶಕ್ಕೆ ನಮ್ಮ ಕರ್ನಾಟಕ ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲ್ ಅವರು ಪಾಯಿಂಟ್ಸ್ಗಳನ್ನ ಕೊಡ್ತಾರೆ. ಆ ಕರ್ನಾಟಕ ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲ್ನ ಅಬ್ಸರ್ವರ್ ಆಗಿ ಬಂದಿರುವಂಥವ್ರು ಡಾಕ್ಟರ್ ಪವನ್ ಕುಮಾರ್ ಪಾಟೀಲ್ ಅವರು ಅಂತ ಹೇಳಿ, ನಮ್ಮ ಗದಗಿನ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿಕ್ ಸರ್ಜನ್ ಅವರು. ಸೊ ನಾವು ಮಾಡ್ತಿರೋಂಥ ನಮ್ಮ ಈ ಅಧಿವೇಶನ ಅಥವಾ ಕಾನ್ಫರೆನ್ಸು ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ ನಡೀತಾ ಇದೆಯೋ ಇಲ್ವೋ, ಜನರಿಗೆ ಮುಟ್ಟುವಂಥ ಕಾರ್ಯಗಳು ನಡೀತಾ ಇಲ್ಲ ಅಂತ ಅಬ್ಸರ್ವ್ ಮಾಡೋಕ್ಕೆ ಬಂದಂಥ ಡಾಕ್ಟರ್ ಪವನ್ ಕುಮಾರ್ ಪಾಟೀಲ್ ಅವರಿಗೂ ಕೂಡ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸಲು ಇಷ್ಟಪಡುತ್ತೇವೆ.
Every memorable event deserves a word of gratitude. To express our heartfelt appreciation to who have contributed to the success of this inauguration, we invite Dr. K.N. Madhusudan, the Chairman of Medicon Scientific Committee, to propose the vote of thanks.
Good morning to all the esteemed dignitaries on the dais, respected guests, colleagues and delegates. As the chairman of Scientific Committee of Medicon 91, it is both an honor and a privilege
to deliver the vote of thanks on this momentous occasions. One, the inauguration of our scientific session set against the profoundly relevant theme, health for everyone, everywhere. And the second most important occasion is IMA Gangavati is completing 50 years as on today, which was started in 1975 by my father, late Dr. K. Narayanachar, and the secretary, Dr. Rajmohan sir, has come all the way from Bangalore. First and foremost, I extend our deepest gratitude to our inaugurator, Dr. Honnegoda sir, for your inspiring inaugural address. Your words resonated deeply with the essence of this year's theme, the urgent need for accessible, equitable, and inclusive healthcare. Your perspective on bridging the gap between the medical advancement and community level health delivery has laid a compelling foundation for the discussions ahead. I would also sincerely thank our chief guest, Dr. S.B. Lakol sir, our guest of honors today, our own. So what an occasion. 50 years of IMA Gangavati and our own people are the guests of honors today. I sincerely thank Dr. G. Chandrappa sir, Rajotsava awardee, for having come and accepted our invitation and has taken the seat. Thank you, sir. I also thank another guest of honor, Dr. A. Somraju sir, who has given his gracious presence and thought-provoking remarks. I also thank Dr. V.V. Chiniwala sir. Your emphasis on public health, policy integration, and technological innovation truly encapsulated the spirit of health for everyone, everywhere, reminding us that modern medicine must reach beyond hospitals and laboratories into every home and village. To our respected dignitaries on the dais, all the IMA KSB team which has come, Dr. Veerbhadraya, Dr. Harish Galantapettu, Dr. Shankar Narayan, Dr. Surya Raju, Secretary, I thank each one of you for having come and participated in the scientific session inauguration. A heartfelt thank you to all our keynote speakers, invited faculty, and scientific contributors. Your willingness to share your knowledge and expertise with us is what makes this platform dynamic and transformative. From cutting-edge clinical research to community health innovations, your contributions will help illuminate the path toward more equitable healthcare system. To my fellow members of Scientific Committee, I thank you all from the bottom of my heart. Curating a scientific program of this scale with sessions that reflect both scientific rigor and real-world relevance is no small feat. Your tireless efforts, sleepless nights, and constant collaboration have brought this vision to life. I must also thank our conference organizers, the main three pillars, Dr. Mallangoda H, Organizing Chairman, Dr. Amrish Patil, Organizing Secretary, Dr. Baswaraj Singnal, Organizing Treasurer, and the team of 50th year, Dr. A.S. and Raju, Dr. H. Nagaraj, and Dr. Avinash Padmashali. I thank each one of you for having worked so hard, and we are seeing what it is today. Finally to our delegates, students, young researchers, and healthcare professionals, thank you for being here in such impressive numbers. Your presence brings vitality to this forum. Let us all remember that the journey is to achieve health for everyone, everywhere. It begins with shared knowledge, open minds, and collaborative action. This conference is a step in that direction. As we proceed with the sessions ahead, I encourage you all to engage actively, ask questions, challenge ideas, and seek inspiration. Let us not only listen, but also contribute for the world, informed voices, ethical minds, and compassionate hearts in the pursuit of universal health. With that, I once again thank each and every one of you. Let us carry this mission forward, not just within these walls, but out into the community we serve. Thank you, and all once again.
Thank you, sir, for your thoughtful words and for your excellent leadership in making this scientific event a success. With that, we conclude the inauguration of the scientific session. Let's carry forward the enthusiasm and knowledge from this morning into the academic sessions ahead. Wishing all participants a day filled with learning, networking and inspiration.
Good morning everyone. Scientific session will start both all A and all B. Please, you can move to all B as well, whichever you people like the topic. Topics have been displayed in front of the hall as well as in the Medicon 25 WhatsApp group also. Please do enjoy the scientific session. Thank you.
Let us now begin the first scientific session of the day. I would like to call upon the chairmen of the first session, Dr. Somaraju sir, Senior Surgeon Gangavati, Dr. Malavai Gowda sir, Consultant Orthopedician Channapatna, Dr. Sudhindra T, General Surgeon from Hoskote. I would also like to call upon our first speaker, Dr. Sunil Kari sir, onto the stage.
Hello. 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 Good morning, everybody. And let us start with the real part of this scientific program. So we are starting with the first part of the scientific session. So the first speaker, he actually doesn't need much of an introduction. He's already famous. As a customary, I am going to introduce my senior at KMC Hubli, Dr. Sunil Vasudev Kari. He is a well-known general surgeon and especially he is very famous for the management of diabetic foot. He has completed his MBBS from JNMC, Belgaum, and then did his MS General Surgery from KMC Hubli. Presently, he is the proprietor of Saudamini Memorial Hospital. He is a senior consultant, diabetic foot surgeon, and head of the Department of Diabetic Limb Salvage, Chief Diabetic Foot Salvage Team, a consultant diabetic foot and ankle biomechanics, is a consultant for diabetic footwear designing, and also director Mandakini Medi Engineering Health Private Limited. With this short introduction, I welcome you, sir, to take the dais.
Thank you. Thank you, Chairman, sir, for the nice introduction. At the outset, let me thank the organizing team of 91 Medicon Gangavati for inviting me to just share my 25 plus years experience on limb salvage and diabetes. And it's really a pleasure. I just have two announcements. Number one, yesterday doctors who were not there for the foot care workshop, they can have, we have left with only 20-22 kits where you can keep it in your waiting hall for the patients to know about foot care and what doctor has to know day-to-day practice from Monday onwards. we have designed 2026 calendar. You can keep it and you can see that every foot can be salvaged. So those kits are available. Those who have not received, you can collect it from my boys who have come over there. So let me begin. This is a one, we call it as a DFD, diabetic foot disease. It's a syndrome. It has got multiple variables. Multiple things are involved in this. But what I can do in my clinic with resource poor setups. We need not to have too many gadgets. So I will present you how we have built up a new concept by which we can save every limb. My basic outline will be pick up feet at risk first. What is DFU? Ulcer. What is DFW? You have created a wound after operating. What is DFI? It is an infection. What is DFO? It is an osteomyelitis. What is Charcot foot? Charcot foot doesn't have ulcer, but it is deformed with fracture of all the foot bones. There is no accident, there is no trauma. I am standing for long duration, I am diabetic, I am going to break my feet. That is Charcot. It is autoimmune. It is autonomic neuropathy ending up with fractures in the feet. What is footwear science? What is exercise science? Everyone sitting in this hall, all the doctors are shouting at every diabetic patient, walk, jog, run. You need to have an evidence before you advise this exercise. What are the new challenges we are going to see in next coming 10 years? Very, very interesting challenges we are going to see in this foot area. What is the take-home message? These are the basic clinical knowledge. Let me give you a simple amputation. A small injury to the toe, you immediately tell to the patient, a mindset is fixed here. You are telling every patient, so what was the first amputation in the world which was done? Let me show you this. Can you see? This is the first amputation in the world by Ernst Bergmann in Berlin, 1901. Look at it, no anesthesia, 10 people are holding it and tuck, no gloves, nothing. Below knee amputation done. Everything is over there. This is the first amputation in 1901 which was done. What is new now? 2025, high-tech OTs, high-tech gadgets, everything is high-tech. Procedure has remained same. Nothing has changed. Let us bring something change. Let us prevent this. Since 100 years, we have been working on the same with big setups. We need to bring our clinical knowledge, bring up this clinical research in this area. Now, this is basic. We have our own body, International Working Group on Diabetic Foot, where they planned this stratification. It was established in 1996. 2023, we had again 160 countries meet at one place to save the limbs. St. Vincent's Declaration, I don't know how many of you are aware of St. Vincent's Declaration. If you start working on saving the limb today, 2025, within 5 years, you should reduce the amputation by 50%. So this is a grading I explained yesterday. Karnataka, let us look at Karnataka, and I go to North Karnataka because I am from Hubli. We are having 3 CR population in Karnataka is having around 6.68 population and 67% literacy. We don't find much difficulty in educating patients, but 40% are illiterate. It's a big challenge. 10% are diabetic. 70 lakh people diabetic in Karnataka. Look at DFU. 25% suffer in their lifetime. 17.5 lakh DFUs are there with us. Out of that, 50% get infected. 8.75 lakh are there with us. And amputation, exactly 25% end up. Look at the number. It's very bad. It's very bad. So we need to act. We need to work. At a rural level, we have to start working on it. This is going to be the next global footprint. This is how it is going to be in next 10, 20 years. Everywhere there is going to be a volcano. Look at it, 17.5 lakh. Look at diabetics. Every individual has got 2 feet. So 1.4 CR limbs are at risk. And DFD, recently I think sir was telling us around 3 lakh plus doctors are there. I look at those who reach physicians, 1,25,000 as a physicians. Look at the burden. DF burden 280 per person, 70 DFUs per person, and per day load. Look at the load. What you are going to see in coming years in your clinic. It will be a huge load of limbs, and this is going to be every month, every day. I have calculated. This is how a big issue is going to come up in next 10 years. What is the mission? The first conference on diabetic foot was conducted in Melbourne in UK in 1986. And what is today, 2025? It's just 50 years period. It started, we understood well in last 50 years. Diabetic foot is common, complex and costly. Common, complex, recurrence, relapse, failures are highest in this area. Clinical and radiological healing are the two evidences you have to give to the patient. You can't say, Gaya Maideti ni Aramadi. No. Wound has healed is not an evidence in diabetic foot. You have to have a radiological evidence because bones are very much nearer. What we have not achieved in last 50 years, preventing first ulcer. In entire world, nobody could prevent the first ulcer. Healing of an ulcer, thousands of material are available, but we are reaching 100 days or more than 100 days or 1 year, 2 year, healing happens. But within no time, within 1 year, 60% recur very badly. So this is a picture. So we have failed miserably in these three areas. I am going to give you what is functional limb. Since childhood, we see this Mickey Mouse serial. Look at that quickness, how reflexly the walking style is there. That is called functional limb. Whether such kind of functional limb is there now? No. The Mickey has aged, it is diabetic and it is with walker now. He is unable to go now. The Mickey is diabetic. Every individual is going to be diabetic. So look at it. In North Karnataka, in Karnataka, whether the feet are happy, are they cared, are they safe, are they functional? They have to be functional. Why they are non-functional? Because of altered biomechanics in diabetes. Due to sensory neuropathy, they become insensate. Motor neuropathy, they become rigid. Autonomic neuropathy, they become non-functional. These are the basic reasons they end up with non-functional limb. Screening, three things are important. Yesterday I showed you PNP, peripheral neuropathy assessment, pulse, check for the vascular assessment, check for the footwear and footwear analysis. I'll give an example for this. If you don't do this, patient will end up with all these thermal burns. A simple ingrowing toenail was referred by a physician to the surgeon and they missed and he ended up with below-knee amputation. A simple ingrowing toenail was excised. You created a bigger area and supply was less, demand was more, and he ended up with below-knee amputation. Such things should never happen. A wound which was not healing since past 3 months, heavy antibiotics were given, admitted for many a times. It was only because of insole which was curled up like this, which was hitting that little toe repeatedly. 100 rupee insole made a big change in this patient, everything healed. Please apply these basics in your practice. This is what we see daily. Pre-ulcerative, ulcerative, non-ulcerative, active diabetic foot, chronic. Fine. Neuropathic, neuroischemic, ischemic, and we saw during this corona, acute ischemic, critical ischemic. Please remember this white line. Renal foot is the worst foot. Nothing has come up yet in the world. Renal foots are the worst. Cardiac foot. Many of the patients, I get call from cardiologists, he is not recovering but he is behaving like this. His foot is loaded with pus. We just explore the foot and he is back into the ward within 48 hours. HIV is no more a chronic disease, acute disease, it's a chronic. HIV with diabetes, it's a big trouble. Foot in skin problems, foot in necrotizing fasciitis, psychiatry patients. We get many psychiatry patients with diabetes. And recently, I was very happy to see a school has been started for special child. We have got many special child who are 23, 24 diabetes. and I have done a limb salvage surgery for them, and they are so difficult to manage. They keep on removing all the dressings. They don't keep the dressing only, special child. They just remove the dressing. But still we have to save the limbs. This is what is DFU, DFO, DFI, and this is non-ulcerative. I want you to observe in days to come. This is going to be the big number. ಎಲ್ಲ ಸರ್ಜನ್ಗಳು ಎಲ್ಲರ ಬಟ್ಟೆಗಳನ್ನು ತೆಗಿತಾ ಇದ್ದಾರೆ ಗ್ಯಾಂಗ್ರೀನ್ ಆದ ಕೂಡಲೇ. ಸೊ ಯಾವ ಕಾಲು ಲೋ ರಿಸ್ಕ್ ಇಲ್ಲ, ಎಲ್ಲ ಕಾಲು ಹೈ ರಿಸ್ಕ್. ಒಂದು ಟೋ ಹೋದರೆ ಸಾಕು, ಇಟ್ ಈಸ್ ಹೈ ರಿಸ್ಕ್. ಒಮ್ಮೆ ಅಲ್ಸರ್ ಆದರೆ ಸಾಕು, ಹೈ ರಿಸ್ಕ್. ಸೊ ದರ್ ಈಸ್ ನೋ ಅಸೆಸ್ಮೆಂಟ್, but still many people are assessing, wasting their time. The moment the patient is without a toe, it is understood he is high risk. Don't waste your time in spending too much of assessments. Spend time on vascular assessment. Don't spend on neuropathy assessments. This is a stairway of amputation. Every foot is normal. Primary care is very important. Secondary care is equally, and tertiary care. We have normal PNP, DFU, DFI. People come to me, sir, one ಕಾಲು ಹೋಗಿದ್ರಿ, ಇನ್ನೊಂದು ಕಾಲು ಉಳಿಸ್ರಿ. Rehab, it has become a big issue now. It is going to be a big issue in coming days. Both spectrum. You want to prevent ulcer, you want to see that it should heal, then both area you need footwear science. You need to understand what footwear your patient has to wear. Unlock behaviors of the diabetic foot. Very important thing. Please, I will give very simple tips for you. What is neuropathy behavior, what is vasculopathy behavior, what is immunopathy behavior, and what is neuroischemic behavior. Every day we search patients. And every day for this neuropathy, we give them some kind of a good footwear or application of the soothing agent. Next, slight change in color of the third and fourth, fifth toe. ಏನಾಗೋದಿಲ್ಲ, ಸ್ಟಿಲೋಸ್ ತಗೋ, ಒಂದು ಎಕೋಸ್ಪರಿನ್ ತಗೋ, ಆ್ಯಂಡ್ ಜಸ್ಟ್ ಸಣ್ಣ ರಕ್ತನಾಳ ಎಲ್ಲ ಬ್ಲಾಕ್ ಆಗ್ಲಿಕ್ಕತ್ತಾವ, ನಥಿಂಗ್ ಮಚ್ ಕ್ಯಾನ್ ಬಿ ಡನ್. ನೋ. ನೆಕ್ಸ್ಟ್, ಎ ಗ್ರೇಟ್ ಟೋ, ಎ ಸ್ಮಾಲ್ ಅಲ್ಸರ್ ಇಸ್ ಕ್ರಿಯೇಟೆಡ್ ದೇರ್, neuroischemic. Immunopathy, well demarcated lesion, was in ICU in medical college for 1 week, and he was referred that nothing can be done, and he ended up in my place. Just look at how they behave. This foot, this toe will come back to you with gangrene because you have missed the ulcer down there. Anything you feel hard there, please trim it, shave it. There is a hidden ulcer down. Callus, there is always ulcer down. And same toe comes back to you telling, sir, ಇದು black agidri, wet agada, gangrene agada, because you have missed it. Don't miss these things. Second, because he has been told, sansanna arteries the block agava, he never went anywhere, and the foot became long. Long. Now we have got excellent vascular surgeons. They open up all the vessels. The theory is all the vessels can be opened. They reach down up to the dorsal spadies and open the plantar arch. The digital vessels, there is only basement membrane thickening. The moment you establish a pressure. So this is a knowledge. A slight change in color in any of your patients, refer to the vascular department. Neuroischemic feet. Simple cardiac assessment. ECG lead was kept for more than 10 minutes, and this patient, the paramedical staff was attending a call, and 10 minutes had led to this cause. I asked the patient, ಏನಾಯ್ತು, ಗಾಯ ಹೆಂಗಾಯ್ತು? ಸರ್, ಅದೇನೋ ಹಚ್ಚಿಟ್ಟಿದ್ರಿ, ECG ತೆಗಿಯಾಕತ್ತಿದ್ರಿ, ಒಂದು 10-15 ನಿಮಿಷ ಫೋನ್ನಾಗ ಮಾತಾಡ್ಕೊತಿದ್ರಿ, ತೆಗೆದ ಮನೆಗೆ ಬಂದು ನೋಡ್ತೇನೆ ಹಿಂಗಾಗಿದೆ. This is a behavior, what limbs are showing now. Very important. It is very tender, just like newborn babies, it is behaving.
Sir, you are left with 1 more minute.
Demarcation, sir. It is spread into the gastrosoleal totally. You have to explore it, and it is immunopathy behavior, and we did Belloni, and he died. So immunopathy is worst. We get seasonal presentations. ಮಳೆಗಾಲನಾಗ, ಬೇಸಿಗೆಗಾಲನಲ್ಲಿ, ಚಳಿಗಾಲದಲ್ಲಿ ಕಾಲುಗಳು ವೆರೈಟೀಸ್ ಆಗಿ ಕ್ರಾಪ್ಸ್ನಲ್ಲಿ ಬರ್ತಾವೆ ನನಗೆ. ಬೇಸಿಗೆಗಾಲ ಬಂತು, ಹಾಟ್, ಎಲ್ಲ ಕಡೆ ಈಗ ಡೆವಲಪ್ಮೆಂಟ್ ಸ್ಟಾರ್ಟ್ ಆಗಿಬಿಟ್ಟಿದೆ. ಸೊ ವಿ ಹ್ಯಾವ್ ಅ ವೆರಿ ಸ್ಪೆಷಲಿ thermal burns. Then you have got, you can see here thermal burn, you can see here web space infection, and this is called itching leading to the cellulitis. Footwear, this is how cause and cure, both are there with you. Cause, you can see type, wear, insole, outer sole, size, seam, adherence and toe filler. We want a compromised diabetic foot demands such kind of a comfort as the puppy is enjoying in this footwear. Such comfort we want to give to the feet. Strap should never be used. You can see heel, entire counter has to be there. No Jitendra style narrow 4-foot shoes. We do this every day in childhood, wearing left to right, but this patient does every day right in front of us. Check for the outer sole. Yadon ki Barat, 9 and 8, many of the patients are wearing like this, and insole is torn out. You can see the cure with the footwear, very 4-foot, everything cleared, mid-foot, you give rocker bottom, everything clears, hind-foot, within 90 days, 80 days, everything clears. Customize. Yesterday there was a question, customized footwear. You can see we do this, very customization, and patient is absolutely fine. Not to prescribe. Such kind of footwears and such kind of materials, never give it. How to practice in resource poor clinics? This patient came back to me, sir, ನೀವು ಚಪ್ಪಲಿ ಕೊಟ್ಟಿದ್ರೆ ಹಾಕ್ಕೊಂಡಿದ್ದೆ ಮತ್ತೆ ಬಂದದ. He said, ನನಗೆ ರೊಕ್ಕಿಲ್ಲ. I can't pay you again 600 rupees for this. Do something. Then I said, okay, this is the area which is having maximum pressure. I am a cobbler in my clinic. Because if I say something to a cobbler, he never understands that science. I have got all the setup in my clinic. I have purchased insole, silicone. I made 100 cuts in that, 1 inch by 1 inch, which was costing me 800. For the patient, it came 10 rupees. I just placed that. Can you see it healed in 100 days? Now, ಪ್ರತಿ 2 ತಿಂಗಳ 3 ತಿಂಗಳು ನನ್ನ ಕಡೆ ಬರ್ತಾನೆ, ಸರ್ ಅದು 10 ರೂಪಾಯಿ ಪೀಸ್ ಕೊಡ್ರಿ ನನ್ನ ಕಡೆ ಅಂತೇಳಿ. And he places it, it goes away. See, this is possible. This is possible. I cure diabetic foot, never say to any patient, there is no cure in diabetic foot. It is only arrest. As long as he walks, he will say in cancer, give always plantigrade foot, chewable, braceable foot, and keep foot in remission as you keep it. And these are the 2 last videos I want you to enjoy. This is how I look at diabetic DFU. I hope all of you have seen this Terminator movie. He thinks he has done the job. And he thinks, and within no time, you tell the patient, Atma aramagi hog anteli. He starts walking. And 3rd month he comes back to me. And this is how our diabetic foot ulcers are. 60% they come back to you within 1 year. Please remember these clips. If you don't prevent the recurrence, nothing is going to happen. And what we do, dressing. Look at the guy. We are also trying to close the wounds. He is also trying to close the window. He is focused. He is looking at a hole. He wants to close. At the end, he notices there is something wrong. It is not closing at all, in spite of jumping. There is somebody stuck there. Don't look at hole in the foot. Look body as a whole. Why it is not healing? Why body is not responding? Please look in that manner. So these are the things which I have yesterday explained to you, which will not take much of my time. I will straightway go to the challenges, which is the challenge that the rural guy has to be saved. We don't want any Jaipur foot for him. This is a line your patients are going to ask in next coming year. Sir, ನಾಲ್ಗಿ ತಲೆ ನೋಡಕ್ಕೆ ಹೋಗ್ಬೇಡ್ರಿ, ಮೊದಲು ಕಾಲು ನೋಡ್ರಿ, ನನ್ನ ಕಾಲು ಉಳಿತೈತಿಲ್ಲೋ. Look at my feet first and predict the rate of amputation. In next, I am completing, I think, 20 minutes. Already there are not less than 60 amputations are done across the globe, and we miss in our day-to-day practice barefoot walk, worn-out footwear, and exercise. Please don't allow exercise for every patient if they have ulcer. Don't advise them. If there is an ulcer, don't advise. And it is a medical problem, is a myth. It is a mechanical problem. Dressings don't heal the wounds, properly selected. Now, this is the 2 slides. Don't write antibiotics unnecessarily. The moment you see, ಗಾಯ ಮಾಡಲಿಕ್ಕೆ ಗುಳಿಗೆ ಕೊಡ್ರಿ ಸರ, ಚಲೋ ಗುಳಿಗೆ ಕೊಡ್ರಿ ಸರ ಗಾಯ ಮಾಡಲಿಕ್ಕೆ. Wrong concept. Never write any medicines.
Sir, your time is up.
You
Please
have
summarize.
these. And this is a new challenge, what you have. Number of steps per day.
Sir, your
Thank
time
you.
is up.
Please take
Please
away.
conclude.
No cure in diabetic foot. It is a temporary arrest. Ulcer-free days are the indicators of outcome. Don't blame diabetes for amputation. Never ever blame diabetes. Please explore what went wrong. Thank you. We would like to have victory like this. Our toes should show this kind of a victory. Thank you so much.
Thank you, sir, for your a wonderful talk on diabetic foot and its management and its prevention. Because of shortage of time, there will be no question and answer session for this.
Next, good morning everyone. First of all, I would like to thank for giving us an opportunity. I thank the organizers for giving us an opportunity. And today I call upon the second speaker for today's session, Dr. Rajshekhar KT. He is a leading orthopedic surgeon and a robotic joint replacement surgeon from Apollo Hospital, Bannerghatta Road, Bengaluru. And briefly I want to present his academic achievements. He has done Master in Orthopedics from Bangalore Medical College in September 2002. He has done MBBS from JJM Medical College, Davangere. And he has done MCH Orthopedics from University of Seychelles, USAIM, in March 2016. Fellowship in Joint Replacement Surgeries at Mumbai, at Breach Candy, Hinduja and Leelavati Hospital. And he has done fellowship in Adult Reconstruction and Joint Replacement of the Ranawat Orthopedic Center at Hospital for Special Surgery, New York. He has 11 national and international journals to his publications to his credit. And he is interested in hip and knee replacement surgeries and pelvis tubular fracture fixation. Over to you, sir.
I thank you, everyone, and thank you for organizing committee for giving this wonderful opportunity in the wonderful morning for the presentation of my work here. Okay. So I'm going to present about my work on robotic surgeries and hip and knee replacement surgeries. This is my journey started. I am always grateful to my teachers, Dr. Ranawat and Dr. C.J. Tucker and Dr. Pachore and in Bombay and USA. Unfortunately, he's recently passed out, and he is the one who is the joint replacement surgeries to establish in India. He taught us a lot of students of my teachers and everyone. So he is the one who operated Vajpayee, and he is the legend, and lots of great work he has done. So the common questions to the lot of orthopedic and non-orthopedic and other faculties is that what is the robo will do? Will do all the surgery? Will do the implantation? Will be there is a skin cut? These are the common questions by the people. So the robo is just a cutting tool and a machine. It will help me to do the best surgery, and it has enough. The surgeon is the best robo. We should have enough knowledge in doing the surgery. The robo is the cutting tool, and it is a software, and it is your registration is very important here. It is a garbage in and garbage out. If your registration is wrong, the whole thing can go wrong. So the surgeon should be aware of it, what he is doing, what it is doing, or what we surgeon should address it in right time, timely and appropriately, and correct it. So the all implantation is not by the robo, it is the surgeon does it. It just helps to take the alignment, it helps us to cut the bone cuts, it helps to find out the gaps and soft tissue balance, and it helps us to find out the proper position and fixation. So my journey in automatic robo, we started with the computer surgery in 2002. He is the first in Southeast Asia. Our boss, Dr. C.J. Tucker, started his robo in Mumbai. So this is how the computer surgery was that. You can see this, there is a gap, so the medial laterally alignment, everything. So it was a wonderful tool, and we published in 2004, 5 and Karnataka, Vairog, Western Regional Orthopedic Conferences, All India Conferences. We published these papers, and this is the textbook of this computer surgery. So what was this problem with the navigation was that it was not a CT based, it is all based on the manual jigs. We need to, computer will help us to guide the bone fixation, and it helps us to fix it. But a lot of variation can occur. So all these knee replacement surgery is based on the alignment philosophy. And if the car aligned is well, the tire will not wear faster. Similarly, this alignment, if is good, that this is a thigh bone, this is a leg bone, this is a femoral component, tibial component, this plastic will not wear faster. This is the principle of knee replacement. So till 2033, we are always used to use the navigation or computer surgery. Then when the computer was not working, then we established our own technique to get the alignment in a board, femur and tibia. I published this in Journal of Orthoplasty. Dr. Ranavat gave us award in this. And similarly, the board tibia. So in Indian patients and Asian patients, it was very difficult to do surgery sometimes because of long-standing osteomalacia, board femur. It's difficult to get the alignment. So these errors in the cuts can go wrong. So I published my own papers and navigate innovation technique to get a proper cut. And this is how we published it. So with this, now the robo we got, and robo is helping me with my experience of my own innovative technique and computer surgery. I was able to get a good work because of the robo. It is my best assistant, I can say. Whatever I want, it will do it. And it will help me to fine-tune the gaps and fine-tune the bone cuts and alignment fixation. So we can choose, there are different alignment philosophies there. We can use whatever the alignment in this, and I really done 7,000 joints. And it is based on the CT scan. How we do the robotic surgery, I'll give you. And we have two robots, Mako and QVIS. And what we do is, first we do the CT scan here, and it shows the three-dimensionally the center of femoral head, and it takes the center of tibia, that is the center of femoral component, and the center of tibia proximally and distally. With this, it gives us the plan. What is the size of femur? What is the size of the tibia? And it gives us the alignment. What is the exactly aligned? Before surgery, how much was the alignment? After surgery, how much is the alignment? Any fine-tuning thing we can do. Intraoperatively, we can see there is a, before surgery, there is a laxity of 7 and 3. Then we can adjust this and cut the bone. It becomes balanced, equal 10 and 10. That is like that. Similarly, in the bending view, it was tight on the medial side. After balancing, it becomes equal. This is how this robotics works, and you will be able to get an excellent alignment. So a lot of people feel that robotic surgery takes time. No, it is not actually. We can see this is my operating time. Hardly 15 minutes extra it takes. And this is how the fixation we can get, the perfect fixation. So this is another alignment X-ray post-surgery, robotic surgery, you can get an experience. So the non-CT based is difficult to do. CT based is the best because we can pre-operatively plan well with the CT, and if the non-CT based, if you say intraoperatively, we can do a lot of mistakes while registering the points in the femoral component on the tibia. So in the fixed deformities, it's difficult to do registration with a non-CT based. So CT based robotics are the best. And this is how the BMI of more than 40 or up to 45 were able to get a perfect alignment and fixation. This is an excellent alignment of the patient. And we can see this is an example in the complex knees like this. We are able to do the wonderful job. This man was around 72 or 75. He was not able to walk. Yes, a lot of people had a fear to undergo surgery now also because of a lot of inadequacy in the awareness and fear in the complications. So the same man, you can see how he is walking comfortably without any issue. So this is just in not even 1 month. he is walking. And similarly, there is another severe deformities. You can see this. The pre-operation, how he is badly varus deformity, and you can see this post-surgery is walking wonderfully well. So technology is in our hands. How we to use it and do the surgery, the best thing you can see. So this is a lot of people have fear, they are able to sit or not. You can see this man is sitting comfortably, cross-leg sitting, and lots of people, I have examples, I can give n number of examples. So this, you can see n number of people are able to sit cross-leg and they're enjoying their quality life. Starting from, say, 18-year-old man, he was avascular necrosis to up to 70s, 80s, many are there here, different age groups. Many people can also able to perform the dance. So this quality life will be improved with these people. The knee replacement surgery is really a boom to this such with the arthritis knee. They're not able to do their activities. They're feared of going to say day-to-day activities like walking or household activities, going to temples, all those, many are been depressed and not able to do. Their quality life is improved a lot. You can see this as such examples where they can do dancing and everything. So we have been published these robotic surgeries in various journals, and these are some of them are accepted for publications. So this is about the knee replacement surgery. I am just briefly going to tell about the hip replacement surgery with robo. The crux of hip replacement surgery is the exact cup position, limb length, offset, and maintaining the equal limb length. So this is a very important thing in hip replacement surgery. So these things we can do precisely with conventional. A lot of people, experienced surgeon can do that, but still can occur complications because of the error in judgment. So with robotic we can do a very good surgeries. There are hip replacement, a lot of people have fear and they dislocation and limb length is the problem. And there are different varieties of implant comes, cemented, non-cemented and hybrid. And this is the non-cemented one where there is a porous coated and there is a porous coated cup and a poly liner and a metal head. So this is the ceramic metal on poly, and newer bearing surfaces like ceramic on poly is the best bearing surface. It lasts more than 20, 25, 30 years. And a lot of people ask for ceramic on ceramic. I don't recommend because it's both on hard and hard surface. It can cause ceramic on ceramic fractures. So I've seen this is the ceramic on ceramic fractures. And you can see this is a ceramic head broken. So hence ceramic on poly is the best in robotic, conventional or robotic hip replacement surgeries, non-cemented. Because why it is, it long lasting and durability, there are not much any issues of fractures. So we have this Robo Mako for the both a hip and knee, and also we have QVIS. The Mako is meant for the hip replacement surgeries. We can see this is the pre-op X-ray of the patient. We can precisely plan the cup size. What is my center of rotation? And we can also plan we can see this where the cup is sitting before surgery, and what is my, if the patient is standing on inclination, what is my cup version, combined version, all those things values should be seen. And we can cut the neck, how much is this thing. So precisely we can plan the center of femoral component center and cup rotation center. And we can see this is how before surgery, if I do this much cut, my limb length will be this much, this is my stem size is this much. So without any, we can prevent all these things, we can preoperatively, before surgery we can plan and we can do the surgery. So this is intraoperatively, you can see this is the robotic pins are put and this is an exposure. And this is the robotic camera. You can see this is the cup which is showing here and we are removing here. This is the blue color is the how much you are going to remove. And you can see this after removal of the cartilage and everything, it is white out. Similarly, this is the procedure of cup implantation. You can see after removing, we're going to put the cup remove. This is the cup implantation with the robot. So here, Manually, we are going to do implant it, but reaming and positioning, everything is fine. But again, the robot will tell us how much the pressure is going to put with a robotic even to get the perfect cut. And we can, after reduction, we can see there is no dislocation. The combined anti-version is very good. And this is how the limb length we can assess. You can see this is the pre-op X-ray of the patient, and we can see this is a perfect position of the cup and femoral and equal limb length. So this is immediately post-op. Patient is walking within 6 hours walking. So this gives a lot of confidence for the people, and a lot of people who have young generations with avascular necrosis. This is a common thing after COVID, and there is no other advanced stage of avascular necrosis. Primarily, in the beginning, we can treat it conservative line of management, but nothing is going to cure it. This is another engineer. He is able to walk comfortably. He is back to his work. He was a civil engineer. So he is another working in an airport, and you can see there is no limb length, no limb, and you can see he is climbing comfortably with both hip replacement surgery. After the avascular necrosis, he was feared his life and he feared his job, whether to go back to work or not. You can see quality life. You can see he's able to squat comfortably, and you can see he can do the namaskar also. So these are the advantage of a CT-based robo, and perfectly we can do. So this is an advantage of newer technology, where you can see this is a very badly fracture, acetabular fracture, where the patient had a foot drop, bedridden, is a teacher, and he couldn't go to work. So what we did is, we did a CT scan. We did a CT scan, which was very badly comminuted fracture. How to place the cup is a concern here. So the newer technology is, when we do the CT scan, we developed a 3D image, like, virtual reconstruction of acetabulum we can do, and we can measure the offset and everything compared to opposite side. We can do a virtual surgery on the table here before surgery. We can place the cup exactly how we can. We can see this how badly damaged acetabulum. And we did the same thing intraoperatively, and we can see able to place the cup, and this is how able to do a hip replacement. And 10 years back, this is the 3D model. So the guy was back to similar. So like that example, we have further advanced. You can see there is another case of badly damaged acetabulum, where we have the newer technology where we reconstruct the acetabulum also with the 3D model. Badly damaged hip, you can see, we can't think of any hip replacement here. We reconstructed we prepared the acetabulum with the screws, with the 3D picture we can see. This is an advance in this thing. Same thing we reproduce on table, we're able to reproduce here. So similarly, the elderly lady 75, very badly acetabulum, with a 3D reconstruction of done, and we reconstruct the acetabulum. You can see there is a cup, artificially made cup, which is earlier. When hip replacement, you have prepaid cup. Here, it is based on CT model. We are reconstruct the cup, and this is we are able to reproduce it. And we can see this is how well able to maintain the equal limb length, reconstruct acetabulum. This lady is back on feet, and she is able to walk without any problems. So it gives a good quality of life. With the technology, if you use it, the newer generation technologies, it will help a lot of people, and we can do the best job. And it is a lot of 60 to 70, 80 years of age people, and the younger generation of hip replacement patient, the quality life, definitely, I can assure that 15, 20 years to 25 years without any much problem. I thank you very much for your...
Thank you very much, sir, for completing within the time given. And I know it's very difficult to conclude within 20 minutes of the topic. And there are 2 minutes left, 2 to 3 minutes for the question and answer. If there are no questions, we'll proceed to the next speaker. Thank you, sir.
Next, we have Dr. Srishail Chiniwala from Secure Hospital, Hubballi, here to talk about the topic of red flag symptoms and signs in GI disorder. Please give a huge round of applause for our speaker today.
Dr. Srishail Chiniwala.
Dr. Seychal Chinwalar is our man from Gangavati. We have seen him grow up and becoming a surgeon. I'm very proud to say he's a student of Dr. Ardhanari, the famous gastroenterologist. He's done his MBBS, MS, and MRCS, and DNB in surgical gastroenterology. He's a consultant surgical gastroenterologist at Secure Hospital, Hubli. Other hospital, KLE, Suchirayu Hospital, Hubli. He has got experience of 10 years. Other post director, Hubli Secure Multispecialty Hospital. His areas of interest: hepato, pancreatico-biliary surgery, advanced laparoscopic and robotic surgery, advanced endoscopic procedures, enteroscopy, ERCP, EUS. Dr. Sushil Chinwala, you are invited to start your speech.
Thank you, sir. Thanks for those kind words and introduction. Always a pleasure to be here in Gangavati and give a talk. I thank the IMA Gangavati organizing team for giving me this opportunity here today. So I'm speaking on the red flag symptoms and signs in GI disorders. William Osler, we know this quote from him: medicine is a science of uncertainty and an art of probability. We know the science behind the medicine, but how we go about this job is actually an art. So I have chosen this topic keeping in mind the mixed kind of audience with different specialties. I have selected very few symptoms which are actually the red flag. Means that we need to pause, stop, assess these patients who have these complaints, evaluate them further without any further delay. So I've chosen few symptoms from the upper GI, HPB, even a general symptoms and the lower GI. And also few signs which we know about this, but we need to re-emphasize them again. So coming to first symptom, that's the dysphagia. It's a symptom of esophagus. This is a short history of one female with 65-year-old female developed a progressive dysphagia for solids and liquids associated with weight loss, had a vomiting, very thin built. So obvious diagnosis is that she has a CA esophagus. But when I put an endoscope, it was very surprisingly there was no lesion except for a very tight OG junction. So which was suggestive of a achalasia cardia. So for confirmation, did a esophageal manometry and then even CT, because at this age, it's very unlikely. And this patient ended up with undergoing a laparoscopic Heller's cardiomyotomy. So dysphagia is a symptom of esophagus. Unless 50% of the lumen is involved, patients usually don't develop. And the most difficult substance to swallow is actually water. Most of the patients, at least 60 to 70%, when they say there is dysphagia, they have some positive findings on endoscopy. And even neurobulbar or pseudobulbar palsy can also cause worsening of the swallowing. So other common causes for dysphagia are postcoicoid web, stricture esophagus, and CA esophagus. All of these require an endoscopy. And usually the one question that we need to ask them is what is the level at which they feel the dysphagia. More often than not, it is usually the lesion is lower down than what they say. Any associated symptoms like weight loss, change of voice, or a chest pain indicates that there is some malignancy lingering. So next red flag symptom is a vomiting. This is patient with 25-year-old male came with a right lumbar pain, bilious vomiting, soft abdomen, but ultrasound was showing a cholelithiasis. So he was referred for a laparoscopic cholecystectomy to me, but the symptoms didn't match the findings of ultrasound. So did an endoscopy on him. It showed that there is D2, D3, there was a narrowing. The scope could not pass beyond the duodenum second part. So it was suggestive of most probably SMA syndrome, but a CT was done, which actually showed that he had a malrotation of the small bowel. All the small bowel loops were on the right side, and the large bowel loops were on the left side. So this patient ended up having a laparoscopic LADS procedure with a cholecystectomy. Another female, an 18-year-old female with acute onset of bilious vomiting, usually started vomiting immediately after taking food. There are no other complaints, very thin built. This patient on endoscopy again had a dilated stomach with duodenum, lot of bile inside. So there was a definitive SMA syndrome in this patient, and she needs a duodenojejinostomy. There is a narrowing in the D3, D4 junction. Another male patient who was a chronic steroid abuser, was taking steroids Visalone for more than 5 to 6 years, recently stopped. Then he developed weight one question that needs to be asked is the color of the vomitus, whether it's watery, food, bilious, blood, or fecal. That suggests or shows us where exactly is the level of the obstruction. Along with that, we need to focus on the clinical examination and get a few basic tests done, which will tell us what kind of a problem she has. So, coming to the next is a pain. I always tell all of the patients that pain is good because it brings you to that problem. They will seek the medical intervention early. So this was a patient with a 13-year-old who had only right hypochondriac pain, occasional vomiting, but nothing, no jaundice. LFT was normal. On ultrasound, there was a dilated CBD. So MRCP suggested that there was a dilated bile duct. This is the extrahepatic duct you can see here. This is the extrahepatic duct. Intrahepatic ducts are not dilated comparatively to what the extrahepatic is dilated. The distended GB. She also has a dilated pancreatic duct. So this was a case of choledochal cyst. So she required a excision of the choledochal cyst with a hepaticojejunostomy. So coming to abdomen pain, the first question that we ask is where exactly the pain is. The patients with upper GI pain usually suggest that they have pain in the epigastric region, whereas the mid-gut patients, they have pain around the umbilical, and the lower GI symptoms they have around the hypogastric region. So the next is what kind of onset, whether acute or chronic, the character of the pain, whether it's colicky or throbbing kind of a pain. Referred pain, usually the acute cholecystitis, right hypochondriac patient pain, usually radiates to the tip of the scapula on the right side. Any subdiaphragmatic collections or irritation that have a referred pain to the tip of the shoulder. And patients with pancreatitis, they have epigastric pain severe, which radiates to the back. Along with this, we need to ask about the aggravating and relieving factors. Food commonly aggravates in patients with gastritis or a gastric ulcer. In pancreatitis, definite history of alcohol, and even once they have developed pancreatitis, food also can aggravate pancreatitis. So the relieving factors are in duodenal ulcer, food actually helps in relieving the pain. In patients with obstruction, vomiting might sometimes relieve temporary motions or flatus in a subacute obstruction. So any change in the pattern of symptoms suggests either that the initial diagnosis was wrong or they might have developed a further complications. And like patients who have come with acute cholecystitis or appendicitis, you have admitted and posted for next day surgery. By next day, they might have worsened because of the perforation causing a peritonitis. Any patient with excruciating pain not relieved by any of the medications, you need to suspect a vascular event. It could be a ischemic bowel, or it could be a ruptured aortic aneurysm. Our patients who have hypotension and tachycardia along with pain indicates that there might be intra-abdominal sepsis or bleeding. Other non-medical causes you need to remember are one, MI. Many patients complain of lower chest pain or epigastric pain. You need to evaluate for, look for MI. And other medical causes like even herpes zoster, unless you examine the patient, when they say that there is a right side pain, usually single dermatomal involvement. Once you ask them to show the abdomen, there will be vesicles over the abdomen area. So similar, there is a diabetic ketoacidosis patients who come with a severe abdomen pain and vomiting. The next red flag symptom is jaundice. This was a 55-year-old male patient who had only itching, no other complaints. That was for more than 1 month. And his LFT was mildly deranged. So ultrasound showed a mildly dilated IHBRD with common hepatic duct was not seen. So this is a MRCP image. This was a case of a hilar cholangiocarcinoma. So unless these cases are picked up early, so for that purpose, you need to give importance to the patient's complaint. We have all seen these kind of patients who come with yellowish eyes. In our region, this is very common. This indicates that patient has already tried various forms of treatment, Ayurvedic and local herbal therapy and all, but they are not improving. So the questions need to be asked is how long they are having this jaundice, how is it progressive or waxing and waning, or the color of the urine or the stool. In obstructive jaundice, usually the stool color will be pale because of absence of stercobilinogen and urobilinogen, while the urine is very dark in color. If the eyes are lemon yellow, it is more of a hemolytic kind of a jaundice. If there is orange yellow, it is hepatic, or a greenish yellow indicates that there is a severe obstructive jaundice. Any jaundice patient associated with fever and pain abdomen indicates they have a cholangitis. So GI bleed history, if there is anemia, it could be a periampullary malignancy. Weight loss, again, it indicates it could be a pancreatic head malignancies. Always ask these questions for a patient with a jaundice. One, Ayurvedic medications, which is very common, and history of alcohol or any viral infections like hepatitis B, or a history of a cholecystectomy. Next important symptom is, I keep asking this question for all my patients to see whether they are really having an issue or not. One is appetite and a weight. This was a 48-year-old male patient who came with loss of appetite and weight loss for more than 1 month. Other than that, there are no GI complaints. Clinically, there was obviously no findings. Only the endoscopy showed that there was erosive gastritis and H. pylori positive. And all other radiological and even endoscopy, colonoscopy were normal. Blood test showed that he has a normal hemoglobin about 14. But once iron profile was done, he had a very low serum iron. So this is a patient who has iron deficiency but without anemia. Now, the various stages of iron deficiency you might be knowing. So even before it causes anemia, there will be symptoms for these kind of patients. So always give importance for appetite and weight loss. Any patient who comes with vomiting loose stools for a long time, but they are not lost weight, then it is not very significant. They might be just having a reflux. If any significant weight loss is more than 5% in the preceding 3 months. Patients also complain of loss of taste. It could be because of zinc or vitamin B12 deficiency. A patient complaining of early satiety is mainly because of the stomach issues. You need to rule out CS stomach, do an endoscopy in them. The next red flag symptom will be a GI bleed. More often than not, patients definitely come to the doctor once they see blood, either in the vomiters or in the stool. So hematemesis is blood in the vomiters. It could be fresh or a coffee brown. Indicates the upper GI problem up to the DJ flexure. Anything above that, beyond that, might cause more of a melena. And hematochezia is a fresh blood mixed in the stools. Whereas bleeding per rectum is usually anal canal pathology, where there is blood after passing motions or blood stained on the stools. The anal canal can be hemorrhoids, fissure and all. Once a patient comes to GI bleed in your emergency, make sure that all these three are done simultaneously. Don't waste much time. So ask these questions while you are looking at the patient and inquiring about these complaints. You also have a look at the monitor, whether the patient has tachycardia, hypotension. Then immediately ask the sister to put a line. More often it should be a green line. Check for a hemoglobin and blood grouping and a cross match immediately. So severe blood loss is more than 20%. Obscure bleed is one where there is an obvious GI bleed. Patient comes with hematemesis or bleeding blood in the stools, but you are not able to find root source on OGD or colonoscopy. Occult bleed is when they have anemia, but fecal blood test is positive, but you are still not able to find the source. The mortality risk in GI bleed patients is high, around 5 to 20%, especially in patients with CLD who have variceal bleed. At least 1 in 3 patients die before they reach the hospital. Especially with portal hypertension, if there is a low platelet count on the CBC, that indicates they have already developed varices. This patient needs endoscopy and prophylactic banding if there is a varices. The gravity of lower GI bleeding is usually less severe compared to the upper GI bleeding, because most of them, around 80%, they stop on its own. You can use these scoring systems in your OPD, check for a hemoglobin and vitals, and then you can come to a decent analysis whether this patient requires admission or can be treated on OPD basis. This is a Rockwell score, which is easier to look at, but it is done only after the endoscopy is done. Patient age, blood pressure, comorbidities, evidence of bleeding on endoscopy, and a very high risk is score of more than 5. Coming to the next symptom is the altered bowel habits. Altered means there is a recent change in the consistency or a frequency in the stools. The first complaint is the diarrhea. Usually it is associated with food. Maybe there is a travel history. You need to ask for the frequency. What is the frequency in day and night? Whether there is any associated pus, mucus or blood in the stools. And is there an urgency? All this indicates that there is something significant and positive findings expected on a colonoscopy. Associated weight loss, again, this might indicate a malignancy. So some patients also have a drug history. Sometimes even a simple domperidone can cause a diarrhea. or patients who are taking long-term metformin, they can have a diarrhea. So, coming to the other symptoms are one, constipation. Even some patients who have constipation might have bleeding PR, abdomen distension indicates that there might be an obstruction. So you need to rule out a CA colon or a stricture. Some patients have alternating diarrhea with constipation. Again, this is a symptom suggestive of a malignancy. Female patients who have recently undergone delivery might have a episiotomy during delivery. They might have a anal incontinence. So you need to check for the rectal examination. So altered bowel habits, I keep this Bristol stool score to ask them what is the consistency they have actually in the OPD basis. So it can help us in deciding whether what kind of symptoms they have. Urgency and tenesmus is a definite indication. Suggests that there might be inflammatory bowel disease, CA, or a radiation proctitis. Obstipation indicates that patient is unable to pass both feces and flatus, and it's an emergency, needs to be evaluated further. Coming to the proctology, bottom symptoms, more often these patients go to the quacks and RMPs. Hemorrhoids, fissure, perianal abscess, and fistula. This can be diagnosed purely on the clinical history what the patient gives, even before examination. Most of the external hemorrhoids have swelling and pain, whereas the internal ones, they only have bleeding. You need to check for anemia in these patients. And in fissure, there will be always history of painful defecation associated with constipation and very minimal blood on the stools. So, coming to perianal abscess, the very severe throbbing pain will be there in the perianal area. It might be associated with fever. And sometimes that spontaneous rupture can give rise to a reduction in pain. Whereas some perianal abscess might lead to a fistula in ano where there is a chronic pus discharge. This is one of the patients who had developed this kind of a lesion. This was post-hemorrhoidectomy. They had done 3 sittings of hemorrhoid surgery, but it actually turned out to be anal melanoma. Along with this, you need to keep in mind various other histories like allergy, past history, any tubercular or cancer history in the family, comorbidities, and in female patients young, you need to be sure that they are not pregnant. Coming to the examination part, always start with the oral examination. Never miss this because many patients have the poor oral hygiene indicates that their general health is also compromised. Vitals we all check, but this should be done before the patient enters into your OPD. Always give importance to the weight. Patients, this was a recent study by ICMR India where the obesity is, the root cause is because of the roti and rice, which we consume a lot. So BMI and waist to height circumference helps us in seeing how good they are actually in their health. The general examination, you need to look at from the head to toe, look for the eyes, oral cavity, and even their skin along with the abdomen findings. So in the abdomen examination, focus on the umbilicus. This was a patient who actually had a small, this is a case with a strangulated hernia, very small hernia, but still they had a bowel obstruction. The other one, this was a female who had a small umbilical nodule. On excision biopsy, it came that she had a papillary carcinoma deposits from the thyroid. So PET-CT was done, and PET-CT showed that she also had a malignancy of the ovary also, which was actually a normal sized ovary, but bilateral, both the ovaries had a lesions. So she underwent total thyroidectomy with a total abdominal hysterectomy and salpingo-oophorectomy. And 2 years down the line, she's completely fine. So the abdomen examination should be, we all know the various inspection, palpation, percussion, and auscultation. So you need to be sure about what you are trying to look based on the history what the patient has given. So there are many signs. One Murphy sign is, for the cholecystitis, many signs for the appendicitis. But one I usually do is cough sign. Ask for all the patients to cough when you are examining the abdomen. If they have tenderness, that indicates there's some visceral pathology. So the likelihood ratio for a patient who has sonographic Murphy sign, that cholecystitis is 9.9, very highly that they have a cholecystitis. And this is a commonly used Courvoisier law. When a patient with painless jaundice and an enlarged gallbladder, if they have a mass gallbladder, it's unlikely to be due to gallstones. This was a patient who had only abdominal mass. So on examination, this patient had only abdominal mass and tenderness. On examination, he had a jejunal diverticular perforation. Another patient only had pain, very severe pain, but clinically nothing. CT suggested that there was a mesenteric ischemia, underwent a bowel resection anastomosis. So need to be very sure. This is another patient in the ward, post drain removal. She had undergone a hysterectomy for a large fibroid. This was a port site for a morcellator. The drain was removed, and 2 days later she started developing a severe vomiting, which was initially thought to be paralytic ileus. But then she actually had a small bowel coming in, sitting there, and by 2 days it had already formed a ischemia. So this required a resection anastomosis. Finally, I would say that all general practitioners should be able to look for a proctology, look to see the anal region, assess that, look for hemorrhoids, for piles, fissure, or a fistula. So recently, we all know that these are the things which we commonly do, but there is a technological disruption. Most patients come with already done reports outside, or they want a video consultations, which is actually causing questioning whether the history and examination will be relevant in the future. We all gave a lot of time for
Dr.
studying
Srishal,
this.
I think
Yes,
the time
it's
is
done.
up.
So we need to be open-minded. Clinical examination will still be relevant. To be a better physician, we need to be good, first learn to do a good clinical examination. Thank you.
We thank Dr. Srishal Chinwala for an excellent speech in gastroenterology. All the complications, the diagnostic features, and the videos also. Thank you very much again.
With this, we have come to
If you have any questions, a few minutes, please.
Okay, with this, we have come to the end of this session. I think we'll call upon the next session.
Thank you so much, sir, for moderating this event. We request all the chairpersons to get down the dais as we move on to our next session, that is our IMA KSB orations. We would like to call upon our chairpersons for the first oration event, Dr. V.V. Chiniwala, sir, Dr. Veerbhadraya T.A., sir, Dr. Harish Dilantabettu, sir. Please give a huge round of applause as we have our chairpersons on the dais. Our first speaker is Dr. Shivkumar Kambar, anesthesiologist, Dharwad, who will be talking about the topic of navigating medico-legal issues and their medical perspectives. Let's have him on the stage. Dr. Shivkumar Kambar.
Good morning to one and all. ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಕುಂಬಾರ್ ಇವರ ಪರಿಚಯ ಮಾಡಿಕೊಡುವಂಥ ಅವಶ್ಯಕತೆಯೇ ಇಲ್ಲ. ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಕುಂಬಾರ್ ಅವರು ಬೇಸಿಕಲಿ ಈಸ್ ಎ ಅನಸ್ಥೆಟಿಸ್ಟ್ ಫ್ರಮ್ ಧಾರವಾಡ. It gives me a great pleasure to introduce our esteemed orator, Professor and Dr. Shivakumar Kumbar, a distinguished medical professional, academician and medico-legal expert. Dr. Kumbar completed his MBBS from MR Medical College, Gulbarga, and diploma in anesthesia in KIMS from KIMS Hubli. Combining medical and legal expertise, he also holds an LLM business law from Kumenpu University and certifications in pain and palliative care from Kidwa Institute of Bioethics from UNESCO. He has served the IMA with distinction as Secretary, President and AIMS Chairman of Dharwad Branch, Vice President, Legal Cell Member, CWC Member of IMA Karnataka, and Standing Committee Member of Legal and Ethics at the national level. His contributions have earned him several national honors, including the Best State Chairman Award, Dr. A.K.N. Sinha National Award, and A.P. Shukla Distinguished Service Award. A renowned academician and inspiring orator, he has delivered 100 guest lectures on medico-legal and ethical issues across India. Presently, he serves as a consultant anesthesiologist and pain and palliative care specialist at the District Hospital, Dharwad. With his rare blend of medical, legal, and ethical wisdom, Dr. Shivkumar F. Kamba continues to inspire the medical fraternity through his leadership and dedication to human ethical practice. Now over to Dr. Shivkumar Kumbar.
Good morning, everyone. Respected newly installed President, Dr. Virabhadraya, immediate past President, my senior in my undergrad days, Dr. Chinwalar, and President-elect, good friend, Dr. Harish. I have with me three great stalwarts, which you call it as a present, past, and future of IMA KSB. Future means 25, 26, 27. Friends, I'm really humbled and honored to stand before you to give an oration to commemorate none other than Dr. Nanjundaiah. Friends, in a world of compassion and kindness, what you need is the most humble and ethical practitioner in our practice. Dr. Nanjundaiah, who stood tall as a beacon and hope, his relentless services to the medical profession brought an image of Hippocratic oath in front of all of us. Friends, though his philanthropic work, Dr. Nanjundaiah had touched countless lives, providing medical care who needed the most in those days. This dedication is a testimony to his character and commitment to his Hippocratic oath. I'm sure that I'm going to do a justice for this visionary in the medical profession, that is none other than Professor Dr. Nanjundaiah, which is called as Nanjundaiah Oration. Friends, Professor Dr. Nanjundaiah, who was born in a pre-independent era, that is 12th August 1941, in the Medigiri village of T. Narsipura Taluk, Mysore district. He was a stalwart of IMA Karnataka State Branch, who has done dedicated, appreciable service for the development and progress of the IMA Karnataka State Branch and for the welfare of the medical profession true to his heart. Friends, he self-supported his education by offering tuitions. As a medical student, he exhibited extraordinary accomplishment, circled 10 downtrodden fellow students right through their education. This is a very commendable service, I would say, and very few medical professionals, I would say, they would do in such. He was the founder member of the Medical University. He framed guidelines along with the Dr. Narasimha Singh and Chakran Zappa. He was the founder of the Government Medical and Dental Teachers Association of Karnataka those days. Service to Indian Medical Association, his service spans 3 decades to serve the IMA KSB, which I would say that very, very commendable. During his presidency, he was instrumental in ensuring 85% seats in private medical colleges for many students through Unni Krishna's case in Supreme Court. That was I would say that all of us stand before all of you because of this landmark, Unni Krishna's case in the Supreme Court, which brought everybody into the undergraduate as well as the postgraduate seats. The Karnataka Social Scheme was his brainchild, which has made enormous in the lives of the medical fraternity and their family. As a remembrance of such a great senior IMA leader, IMA Karnataka State Branch, during the Medicon of every year, organizes Professor Dr. Nanjundaiah Memorial Association Oration Lecture. With this, a great tribute to this visionary, I'm sure that I'm going to do a justice to commemorate his vision. Thank you for this. Now I begin my talk. The navigation medical legal issues in our day-to-day practice. Friends, I don't know how many of you have received a legal notice in our private practice. Still, it's a social stigma. Nobody comes forward. They have received a legal notice or they got a call from the media or to the advocate. One thing I would say that if anybody says that I have not received in my 30 or 40 years of practice, I would say from my legal eyes, either you are telling lie or you are not a successful practitioner or else you must have begun your practice recently. I just touch upon quickly what is medical negligence. Unless you know that, you will not be able to understand much of the things. What constitutes a medical negligence? What do you mean by consent? What is vicarious liability? What is the CPA, Consumer Protection Act 2019? Remains as a hanging sword on the medical professionals even today. And BNS, Bharatiya Nyaya Sanhita Act, which was amended from July 2024, earlier which we used to call it as a IPC, and also BNSS, which we used to call it as a CRPC, and also BSA, who used to call it Indian Evidence Act 1864. And what exactly medical records, which you need to maintain it, and if at all you got a legal notice, what exactly you need to do it, and also touch upon the common medical errors which we do in our day-to-day practice, including the general practitioners, especially anaphylaxis reaction occurs in a clinic or in the IPD, ROPD, how exactly we can overcome it, how exactly we can defend it. Friends, unless you understand this, what exactly is the medical negligence, failure to exercise a reasonable or a recommended degree of skill and a care expected of a medical professional leading to an injury or a loss of a patient. It means that you are expected to do a standard of care to the patient, having accepted the patient by paying or by receiving due consideration from the patient. Then, the medical negligence or penalties is not a new. It was there since Sushruta Samhita. If you go back to the history of medical negligence, it clearly depicts, even those days, medical practice was penalized, but the penalty was depending upon the patient's status and also the harm done by the doctor. So, what is two important things you need to understand? What is commission, what is omission? ಕನ್ನಡ ಹೇಳ್ಬೇಕಂತಂದರೆ ಯಾವುದನ್ನು ಮಾಡಬೇಕು ಅಂತ ಅದನ್ನು ಮಾಡದೇ ಇರುವುದು, ಯಾವುದ ಬೇಡ ಅಂತ ಅದನ್ನು ಮಾಡುವುದು, ಅದಕ್ಕೆ omission and commission ಅಂತ ಹೇಳ್ತೀವಿ. So a doctor commits or does something which other prudent or reasonable doctor would not do in a similar circumstances. It means that in a similar localities, not expecting a high degree of care, not expecting a low degree of care, you should be a prudent, a reasonable, you are competent, or wherever colleagues are practicing, majority of them. That is called as a reasonable practice care. For example, a lady has come with a breast lump. Suddenly you are doing a ARM without doing the aspiration biopsy or whatever it is, HPR. That is the omission. Giving a beta blocker to the hypertensive patient who is a known case of a COPD. This is an omission. And giving death certificate without ascertaining the cause of death. Again, I would say that it comes under the omission. Then what exactly is the omission? Doctor omits to do something which other prudent, reasonable doctor of your colleague would not have done it so. For example, not doing a basic investigations in pyrexia of unknown origin and not giving a test dose of any antibiotic or xylocaine, even if the patient gives the history that he is sensitive to the particular drug. And also, I being an anesthesiologist, not doing a PAE, pre-anesthetic checkup, before taking for the major or supra-major cases. That is the omission on my part. If something goes wrong, no doubt I am accountable in any of the courts. So what are the constituents or ingredients? Yes, having patient has paid you or stepped into your clinic, you are expected to have a duty of care to him because he has paid a consideration. Then, if there is a breach in that duty of care, you are accountable, and that direct breach of your duty has caused a harm to the patient, again, you are accountable for all the ODs in your practice. Duty, dereliction, direct cause, and damages caused to the patient. Then comes, most of the times we do talk about the consent. Friends, consent is not a simple thing. It is a process, I would say. I have seen a consent form wherein the patient gives a consent for any kind of operation under any type of anesthesia. We call it as a blanket consent, which does not stand a few seconds in the scrutiny in the judicial matters. So, there are two major thoughts when you talk about the consent. Earlier, you used to call it as a informed consent. Now it is called as informed real consent. A doctrine of informed consent is the doctor's responsibility to disclose every information to the patient to secure the consent. Now, what is meant by real consent, which is followed in the UK, not in the USA? Doctor must warn his patients of the risk inherent in the recommended treatment, which shall be in accordance with a Boehm's test. So, how much you should tell to the patient the harm being done, or the complications are then? If the complications are only 1 or 2%, he do not have to disclose because he is frightened, he may not agree for the genuine surgeries or genuine procedures. If the risk is more than 10%, which you call it as a substantial risk, we need to bring to the notice of the patients or relatives, whether they accept it or not, it is left to them, which you call it as the autonomy of the patient. There is a beautiful judgment, probably most of the gynecologists do agree with me, Samara Kohli versus Prabha Manchand. Everywhere is discussed, this is my favorite judgment also. A 44 years lady, unmarried girl, went for a gynecologist for some sort of a PV bleeding. The gynecologist, he said that you need to undergo laparoscopic diagnostic and laparotomy. The patient was given a general anesthesia. The surgeon, after doing laparoscopic diagnostically, he went ahead with the total hysterectomy and oophorectomy bilateral. When the patient became conscious, he was shocked to hear that the uterus and ovaries are taken away. And she ran away from the clinic not paying the bill. The hospital sued that patient has not paid the hospital bill. Then the matter started in the court of law. Then they went to the National Consumer. Then they went to the Supreme Court. Supreme Court categorically said, friends, the consent taken for the diagnostic is not a consent for the therapeutic procedures. You have done a therapeutic procedures without the knowledge of her, without her consent. You have taken a consent of her mother-in-law, whatever it is, intraoperatively, when she was under anesthesia. It is an inhumane thing, and you are accountable for that. They have penalized even in the Supreme Court. So, what are the elements of the real consent? It means that patient gives it voluntarily, without coercion. Patient has the capacity and competence to consent. It means to say that he is a mentally sound and he is 18 years measured as per the Indian Evidence Act. And also patient has adequate knowledge of information, what you are going to tell him, what you are going to do the procedure. So we call it as a real consent. Then, in reality, the doctor has to seek and secure a consent of the patient before commencing any procedure. Otherwise, it amounts to the slaughtering, arbitrary of the patient's autonomy. And consent given for the diagnostic procedures cannot be considered for the consent for the therapeutic purposes, which the Supreme Court really mandates it. There can be a common consent for the diagnostic or operative procedures if you are contemplating it. It means to say that at any given point in time, I have been allowed to go for the excessive surgery. I can deviate from the desired procedures if it is a life-saving. Otherwise, you cannot exceed or deviate from the consent what for it is taken. In the meantime, friends, make sure that whenever you are giving a blood transfusion, you have to have a consent for the blood transfusion. whenever doing a lumbar puncture, CVA line, you need to have it a consent. Otherwise, again, it amounts to the breach of what the patient's autonomy is. In a Dr. Thomas versus Srimati Elisa, a surgeon did not do appendectomy or laparotomy just because patient did not give a consent. He said in the court of law, this is the Kerala case, he said in the court of law, patient did not give a consent, so I did not operate on the patient. But vice versa, the patient relative said that we were ready to give the patient, he did not ask. The court asked only one thing. They have not given a consent. Did you document it? He said no. So failure to document, no consent, patient is not willing, or dissent of the consent is a negligence on the part of the doctor, which is clearly stated in this. In a NIMS versus Prashant Dhanankar, 2009, a patient had a biopsy. There was a swelling in the chest for which biopsy was to be done. They did biopsy. In the meantime, they did a thoracotomy, and ultimately, after doing thoracotomy, patient landed with the paraplegia. Again, Supreme Court said, consent for excision biopsy cannot be accepted as an implied consent for a therapeutic removal, except it is a life-saving. So since that mass was not a life-saving, you exceeded what you were supposed to do. You were supposed to do only biopsy, which you have not done it. You went for the thoracotomy without his knowledge, and ultimately patient landed with paraplegia. It is the negligence on the part of the doctor. Yeah. Yeah. What is the time? Yeah. Yeah, another 5-10 minutes I will take, okay? Yeah. Vicarious liability, friends, it is the imposition of the liability of one person for the actionable conduct of the another. It means that even if the consultant does a mistake, hospital cannot escape from their liabilities, telling that we don't have a stethoscope to hear what the doctor is doing to do. So it means that the employer is responsible for any acts committed by the employees. Whether the consultant is a part-time, full-time, qualified or non-qualified, visiting or non-visiting, any something goes wrong with that, he is accountable for that hospital also. There are so many cases. I will try to skip it. Yeah, Consumer Protection Act. Earlier, now it is called as a Consumer Commissions. It is not the forum nowadays. So the peculiar jurisdiction earlier, there used to be capping for the consideration being paid. Now there is no capping for the compensation being asked. So if the consideration of the hospital, what is being paid to the hospital, if it is about 50 lakhs, he has to file a case in the district. If it is between 50 lakhs to 2 crores, it is to be in the state commission. More than that will be national consumer this thing. The thing is, wherever the patient resides, wherever the patient works for gain, he can file a complaint from that place only for him to reply. For example, if the patient has undergone hysterectomy in Gangavati, if the patient stays in Delhi, something goes wrong, they can file a complaint in Delhi. You need to go there and defend your case. This is not expected, but the rule is the rule. Earlier, the party, if he has failed it, they used to penalize him by asking to pay 10,000 rupees as a deterrent, which is again taken away in this case. And one more thing is, if you know that you cannot succeed even in the National Consumer or the Supreme Court, you have done a very, very bad case, we have handled it, you are bound to penalize for this. In this case, district, state, national, they have a mediation cell. Okay, you can approach the mediation cell, you can get rid of it out of court settlement by mutually understanding with the patient. So once the mediation cell takes over a pass an order, nobody can go for the appeal. Yeah. Defense is for the doctor. How the compensation being asked, that is a multiplier and multiplier method. This is a commonly asked question. And I would say that IMA KPPS is the best for the medical indemnity. I would say medical professional protection. And many times, if they have not taken, if the private people are there, you need to have AOA, any one accident in any 1 year. We call it as a 1:1 or 1:4, okay? If you are expecting more than 3 or 4 cases in a year, probably it is the end of your medical profession. That's it, I would say that. But I would say that a minimum 1 CR is the need of the hour for the medical indemnity nowadays. In this, IMA KPPS has done an enormous job. I request everyone to become the member for this protection. Then, BNS, what has changed it is, whoever causes death of any person by doing any rash and negligent act not amounting to the culpable homicide shall be punished with 5 years of imprisonment and also with a fine. But the same thing is being done by the medical profession. The penalty is imprisonment for 2 years and also with a fine. So there is a lenience between us and the other professionals, that I would say that. Then who are the RMPs? RMPs means those who are registered in the respective state medical council and also whose name appears in the NMC register. Yeah. So having done this, we have certain differences also. Most of the doctors may not be knowing about this. Section 18.
Shivkumar, just still you have got 12 more minutes. Actually, oration is for 40 minutes, sir. Yeah. So still you have got 12 minutes.
Thank you,
can
sir.
go
Thank
ahead.
you. Thank you, Tanya. Yeah. See, this is one more very interesting topic. Section 117 and 124. It means to say that a patient becomes vegetative while performing any of the procedures, surgical, non-surgical. Section 117, 124 says that the imprisonment for this is 10 years. It might last for even for the lifelong. So there is an interpretation is very, very difficult in this case, especially in the judiciary. For example, head injury patient has come, OP poisoning has come, snake poisoning has come, and encephalitis patient is there, you are treating it. For any given period of time, if he slips into the coma, and you will do your best to revive him, and if it becomes vegetative, this holds good even the eyes of the judiciary 117, 1124. And for that, we have a defenses for that. Act done in accident without the criminal intention is a lawful manner. The act likely to cause harm done in a good faith to prevent the other harms. The act done in a good faith for the benefit of the patient with the consent. And also act done for the benefit of the patient without the consent. So these are all, I would say, that a defensive in the criminal law. So what is the judicial guidelines for this? Yes, the gross negligence requires to make a doctor criminally liable. You need to have a gross negligence. Otherwise, it will be a civil liability. Doctor followed the accepted medical practice. Expert medical opinion is the need of the hour. And no routine arrest of the doctors, which is there in the Jacometti case, still holds good. What are the practical defenses? Demonstrate compliance with your standard care through the recommended SOPs of your specialty. Maintain a thorough, comprehensive documentation. Whatever you communicate, you document. Whatever you document, you communicate to the patient. Argue that the harm resulted from the unforeseen events. You did your best, but it is beyond your capacity, or even in the medical literature, so you are not accountable for this. Yeah, there is one more. We tried our best to bring a bill to protect the doctors, but the parliamentarians did not agree for that. They said that you have a BNSS 2024. The law and order has to be maintained by the state government. This one section is sufficient, provided the law enforcing authority or police department fully gets involved into that. It acts to make violence against a medical professional a criminal offense punishable with imprisonment of 5 years and a hefty fine. This has to be enforced by the police people, but you have to bring to the notice of the police people. It is the state government's responsibility. There is a fast-track mechanism. Earlier it used to take 10 years, 15 years. No, there is a fast-track mechanism in the investigating officers. Earlier, if the person is working in a private hospital, the one who is penalized doctor has to give a FIR, but there is a provision for the institutional FIRs against the assaulters, which most of the institutions may not be knowing of it, but please make a note of it to protect your employees. And central government also given certain guidelines to have a CC cameras, quick reaction teams, and restrict the entry in the hospital, which everybody is doing it nowadays. Even in Karnataka government went a step ahead. penalties like imprisonment to 3 to 7 years and fine up to 25 to 2 lakhs for intentional insult and also addresses of violence on the social media, which most of the doctors may not be knowing it. You can take a screenshot of it and preserve it, and if something goes wrong, please go and show to the police department or investigating officers in any given point of time. It's a cognizable offense and non-bailable, and a fast-track investigation is the need of the hour, which again is maintained in the Karnataka Amended Act. Medical records. See, even in spite of so many years, NMC are not bothered to streamline how long the records should be maintained by the medical professionals. In Indian records, it varies from state to state. There is no single uniform, but we have to preserve medical records longer than what it is there or what is expected in the given. Indoor minimum, you need to keep them for 3 years, and OPD, you need to keep them 2 to 5 years, and electronic records are accepted nowadays. And if the pediatric patients are there, you need to keep them up to 21 years, because as per the Indian Evidence Act, Majority Act, it is at 18 years plus 3 years. And before you destroy medical records, you should give in the advertisement the paper, that paper needs to be destroyed because of the time constraint or whatever it is. And if anybody wants it, they can come and request us by paying a reasonable amount of fee. Then you can destroy them. If we got a legal notice, many a times I've seen my friends, they don't even take the register if it is from the court. They say that, hey, Shukmar, court is notice about Togole. They hide it. They say that out of station. Ultimately, they notify it in the door. Then comes the problem. So respond to the legal notice. It's stressful, no doubt about it, but you have to accept it. Do not panic, but in the meantime, don't ignore it. If you ignore, it shall compromise your defense and needs a professional attention in the later period, maybe 5 years, 10 years, 20 years, 30 years. Receive a notice and preserve it along with envelope and note the date of the receipt. This is very, very important. Gather all the relevant documents. Inform your medical indemnity insurance. And also, if you are a member of the IMA KPPS, your duty is to inform the IMA KPPS. Rest of the things will be taken by the IMA KPPS. Seek or engage a medical legal advisor. If you are receiving a legal notice from the consumer, there is no point in going to the criminal court, criminal advocate. High societies also, because they do not understand the intricacies of the legal notice. So many doctors have failed because they have approached the wrong lawyers in this scenario. And communicate a reply should be through your lawyer only, with the assistance of the medical legal expert. And stop communicating with the patient, their family, or their lawyer once you receive a legal notice. How exactly should reply? Acknowledge the receipt, address parawise, present a factual and medically sound version of the events, which most of the doctors will not do it, they'll end up in the court. In the court, you cannot have extra evidence or documentation. What you have written first that is enough. Otherwise, there is no entry for the extra evidence to be produced. Include supporting evidence, deny baseless allegations, don't accept them. And I have a few doctors, suddenly they go for the evidence or literature in the internet. No, sir, it's not acceptable. First you go for the Indian authors, then the foreign authors, then the Indian journals, then the foreign journals. If need be to substantiate your stand, go for the internet, which is accepted in the PubMed also. Otherwise, there is no role of this evidence. And reserve the rights is very, very important. Last para, you have to reserve your rights, telling that if you are harassing such kind of allegations, malicious intention, I have a right to sue you, ask your explanation in the appropriate court, and I can defame you, which most of the people, they do not take and try to reply within the stipulated time. Most of the times, anaphylaxis, we do come across.
Shukmar, 2 more minutes.
Yeah. This is very important, I would say that. So, having said about the BNS, consumer laws and other things, what are the loopholes? If a family refuses to consent or consent lately in the earliest years, the baby goes into hypoxia, hypoxic encephalopathy. Who is responsible? Again, surgeon, anesthetist, pediatrician, and neurologist, and the hospital is responsible. But you need to record the descent of the consent which they have not given for the cesarean. Otherwise, all four of us will be held responsible. I have 2 cases already in my office. Even if the suit fails and no one gets punished or penalized, can the litigant be allowed to go to scot-free? Yes. Even if the suit fails, he is scot-free, the litigant, the one who has filed a case against you. Who is going to compensate for the stress of going through the ordeal which scars the doctors forever? There is no answer for this in the BNS. Even if the doctors wins, there are financial and logistic costs. Who are going to compensate? Nobody has mentioned, nobody talks about it, even in the parliamentarians. Many times, orders are getting overruled by the higher courts without any punitive action on the hearing bench. See, district court is ordered, state commission reversed, national commission ordered, Supreme Court reversed. With all this, who is going to be penalized? There is no action against the one who has erred in this. That is not being addressed. Many times orders are getting, that's what I told you. The standard of care according to the court is what is written in the textbook, not what you talk about. Thank you one and all.
Thank you, Dr. Shivkumar Kumbar.
If you have any questions, I'll be happy. Lunch hours or dinner time.
So this is oration.
Yeah,
Questions
that's what I told
cannot
you.
be asked now. You can discuss at lunch hour.
ಡೆಸ್ಕ್ಟಾಪ್ ಕನೆಕ್ಟ್ ಆಗಿತ್ತು ನೋಡು. ಅದು ಅವ್ರದ್ದೊಂದು ಸೆಟ್ ಮಾಡು.
Now I request Dr. Jaiprakash B. Patil to come over the dais. Dr. Jaiprakash Patil is a laparoscopic and pelvic surgeon from Raichur. He is a senior consultant and teaching faculty at RDT Hospital, Batalapalli, founder and chief surgeon at Batalapalli Advanced 3D Laparoscopic Center, Raichur, operating faculty at multiple state and national conferences, pioneer in introducing cutting-edge technologies for women's healthcare in North Karnataka, first 3D laparoscopic center in Karnataka, first to introduce microwave ablation therapy for adenomyosis and fibroids in Karnataka, first fetal medicine center in Raichur and North Karnataka in collaboration with Dr. Raju Girade, leading center for advanced endometriosis surgery and fertility preserving techniques, expanding care through our second hospital in Yadgir. His areas of interest are deep infiltrating endometriosis surgery, fertility enhancing endoscopic surgeries, pelvic floor reconstructive surgeries, uterine sparing techniques in fibroid management. Over to you, sir.
ಹಲೋ ಥ್ಯಾಂಕ್ಸ್ ಫಾರ್ ದ ಇಂಟ್ರಡಕ್ಷನ್ ಸರ್. ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ರಾಜ್ಯ ಶಾಖೆಯ ಈ ಪ್ರತಿಷ್ಠಿತ ದತ್ತಿ ಉಪನ್ಯಾಸಕ್ಕೆ ನನ್ನನ್ನು ಆಯ್ಕೆ ಮಾಡಲು ಕಾರಣೀಭೂತರಾದಂಥ ರಾಜ್ಯ ಶಾಖೆ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಚಿನಿವಾಲರ್ ಮತ್ತು ರಾಜ್ಯ ಸಮಿತಿಯ ಎಲ್ಲ ಪದಾಧಿಕಾರಿಗಳಿಗೆ ಮತ್ತು ಗಂಗಾವತಿಯ ಎಲ್ಲ ಮಿತ್ರರಿಗೆ ಮತ್ತು ಹಿರಿಯರಿಗೆ ನನ್ನ ಅಭಿನಂದನೆಗಳನ್ನು ಸಲ್ಲಿಸುತ್ತಾ ಈ ಗೌರವವನ್ನು ನಾನು ವಿನಮ್ರತೆಯಿಂದ ಸ್ವೀಕರಿಸಿ ಈ ದತ್ತಿ ಉಪನ್ಯಾಸನ ಪ್ರಾರಂಭಿಸ್ತಾ ಇದ್ದೇನೆ. ಉಪನ್ಯಾಸ ಇಂಗ್ಲೀಷಲ್ಲಿ ನೀಡ್ತೀನಿ, ಕನ್ನಡದಲ್ಲಿ ಮುಂದುವರಿಕೆ. ಸೊ you all will agree that we doctors are very egoistic people. That includes me also. So this appropriate quote applies very apt for PCOD also, because we all think that we know everything. But it continues to be a mirage, because since 90 years of its description by Steele and Leventhal, we continue to chase what is the perfect medication or the cure for PCOD. In this talk, I'll try to demystify. At the same time, since it is the congregation of all specialties, I will be keeping it very basic and will not be going to the molecular level. It is a pride moment for me, because I did my high schooling in Hospet, and I have been associated with Gangavati for more than now 15 years, and this is a really an honor that I take, that I get this oration in IMA state conference, and that too in Hampi. We all need to be disciplined, and PCOD unfortunately is for the people who are indisciplined. Sorry to say that. And how we are approaching PCOD? We are approaching like blind men explaining how an elephant looks like. Somebody who is thinking that it looks like a fan, somebody is telling it's a tree, somebody is telling it is a snake. Sorry. Same is PCOD. A gynecologist worried about menstrual irregularities. A dermatologist about acne, acanthosis nigricans, or alopecia, or other problems. Physicians probably are dealing with the metabolic syndrome, and surgeons are often confronted because the scan showed there is PCOD. And of course, pediatricians are now overwhelmed with all these problems, and family physicians are also asked about opinion that my girl has got PCOD, what next? So all of us are concerned with PCOD, but all of us are dealing with different this thing. And remember, most of the PCOD patients are obese, 75%. That doesn't mean that those who are lean cannot have PCOD. What is paramount importance is the insulin resistance. Most of the insulin resistant patients become obese. That is the apple type of obese, that is a fat deposition above the waist, whereas the lean patients can also have insulin resistance and also can have PCOD. Alopecia in the scalp, hirsutism and virilism in extreme cases, they are very common too. Now, is it a disease? Is it something which can be inherited? It's actually syndrome. It is the interplay between metabolic, reproductive and cosmetic things, and ovary is only one organ which is involved. So remember, we are not treating only the ovaries. We are actually treating a lifestyle, and probably we are treating a generation and at large a society. Because we cannot attack one thing, okay, I am a gynecologist and I am taking care only of a menstrual irregularities and fertility. I am not worried about
inconvenience because of the power shutdown, we will continue the session. Thank you.
ಸರ್ ಇವಾಗಲೇ 40 ನಿಮಿಷ ನೋಡ್ರಿ ಸರ್. ಇಲ್ಲ ಸರ್ 40 ಸರ್. ಫ್ರೆಶ್ ಸ್ಟಾರ್ಟ್ ಸರ್. ಸೊ Steen and Leventhal, when they were observing the anovulatory women, remember those days there was no laparoscopy, there was no ultrasound. So they did laparotomy and they did what was called as wedge resection of the ovaries, and they found that women started ovulating and many of them conceived. The reason behind that was when they did the wedge resection, the stromal tissue, the reduction in the stromal tissue of the ovaries reduced the hyperandrogenism that initiated the ovulation. So it took almost 70 years till we got the Rotterdam criteria, where we defined the PCOD all over again metabolically. No, it's not working. Computer is not working. Yeah. So remember, Rotterdam criteria is very clear, very clear. Any of the three, at least you should have 2 criteria present. Oligo or anovulation, which has to be documented. Hyperandrogenism, whether it is a biochemically proven or clinically proven hyperandrogenism. And PCO morphology, which should not be loosely applied, and it has to be very strict criteria. At least 12 and above follicles, small follicles with the increased stroma and increased ovarian volume. Very, very important. Of course, you should exclude the Cushing syndrome, congenital adrenal hyperplasia or thyroid disorders, because they can mimic these 3 things. Now, there is a biggest radiological fallacy, because most girls do carry a report saying that PCOD. They are branded PCOD for life without considering other 2 criterias. And I request all the radiology and gynecology friends who are assembled here, who are reporting PCOD, please do not confuse the polycystic ovaries for multifollicular ovaries. It is very clear. We are overdiagnosing PCOD in young girls. I'm not telling there is no PCOD, there is, but we are overdiagnosing and we are branding these girls and subjecting for mental trauma forever. So just to differentiate, what is the differences? In PCOD, I already told, the follicles are smaller, stroma is dense, there is a increased ovarian volume, very, very important. It is because of the stroma. It is because of the stroma. And you hardly see any dominant follicle. Whereas in multifollicular ovaries, you have lesser stromal tissue. Ovaries are usually normal and you always will see a dominant follicle. Compared to PCO, you have follicle size which is little larger. Now, I want to spend about a minute or 2 on this slide alone. Remember, the whole gamut, whether it is PCOD, diabetes mellitus, or any metabolic syndrome, the main culprit is the insulin resistance. Till we attack the insulin resistance, we are not going to deal with any of these things. The insulin resistance increases the insulin secretion. So in diabetics, there is no dearth of insulin. In PCODs also, they have become hyperinsulinemic. Insulin levels are higher. If you get the fasting insulin levels done, their insulin levels are higher. This increased insulin secretion causes fat deposition. This fat deposition in turn increases the insulin resistance, which again body tries to compensate with the increased increased insulin secretion. So it becomes a very, very vicious cycle. So where do we break this? We have to break this not by medications, but by good diet, good exercise, and intermittent fasting. Only 3 weapons. Whether it is diabetes mellitus, whether it is obesity, whether it is PCOD, whether it is dyslipidemia, the magic 3 words are intermittent fasting, high protein, high fiber diet, and exercise. If we cannot be disciplined, then no amount of medications, no amount of research will help us. So remember, you have to break the cycle. We have to break this vicious cycle. We have to encourage them to do good diet and exercise. Nothing else, nothing short. What we are actually seeing is a tip of an iceberg. As I told in my second slide, gynecologists are worried about the fertility and cycles. Dermatologists are worried about acne and other problems. Physicians are worried about the dyslipidemia and diabetes. We are facing a bigger threat because of the metabolic, cardiac, and even cerebrovascular risks. We are only seeing very small portion of tip of iceberg. So we need to see beyond our specialty, beyond our concerns, and go deeper and evaluate them metabolically. The first and foremost contact a girl comes to us is in her adolescence. Remember, a caterpillar without effort will never become a beautiful butterfly. If you want a healthy womanhood to emerge, there is an effort. So if we cannot put that effort in our girls, they cannot be a healthy women. Nowadays, we have everything in abundance. We have everything at our dispense, and we are seeing this disease multiply and become an epidemic. So we need our girls to be physically active, understand their health, and become a beautiful butterfly rather than, the PCOD patients. Now remember, in adolescence, most of the time I am brought 6th standard, 7th standard, 8th standard girls, especially those who have joined hostels. They come with irregular menses. Now, menses is a very complicated thing. That itself will take another oration to deliver. But remember, there is so much of dietary changes, the stress level, that disturbed sleep, anything can cause disturbance in the menses. The moment somebody comes with a disturbed menses, especially young girls, we overzealously do ultrasound and then brand them as PCO. All they need is reassurance. You just focus on their diet, good activity, good sleep, and stress management. That is all is required. And remember, a girl or a woman, not to get endometrial hyperplasia, she has to menstruate only 4 times a year. So somehow in Indian psyche, regular menses is something which our women are obsessed to. So we need to talk to them, reassure the mother. Girls are okay. If you rule out hypothyroidism, if you rule out hyperprolactinemia, if you rule out the obesity, just reassure the girl, tell her to be active and advise her on good diet and good sleep. That's all is required. One very strong message, start looking at their nape of the neck. If the girls or even boys for that matter have acanthosis nigricans, please remember this is the earliest sign of metabolic syndrome. That child has good 50 to 60% chance of turning out to be obese or diabetic in future. So acanthosis nigricans is not a cosmetic problem, it is a metabolic problem. Start looking their nape of the neck or underarm. If they have acanthosis nigricans, please do counsel them. The only way they can bring back the child from metabolic syndrome is through diet and exercise. So what is the take-home message? Do reassure, don't overdiagnosis. If required, we can only give medroxyprogesterone every 2 to 3 months. And I have seen very young girls being prescribed oral contraceptive for 3 cycles, break, 3 cycles, break, 3 cycles, break. Do not put them at risk of developing DVT, CVT. So restrict the use of OCP. OCP has its role, but then it has to be selective rather than a rule. And diet and exercise will continue to be our first prescription. Young women who have very adequate income, they are now become sedentary, and most of the time they are chair bound, and with one click they get their favorite snack or a dessert delivered to their table in 10 minutes. And our companies take pride in saying so that we deliver your food in 10 minutes. Now, late night shifts also is adding to the problem, because their circadian rhythm is disturbed and their sleep is disturbed, stress levels are very high, and unfortunately because of the indoor activities, vitamin D is epidemic. Most of these Swiggy and Zomato delivered foods are, remember, they are tasty, but the least concern is paid to the nutritional value. We want tasty food, we want fast food, but we don't want to do any research on the nutritional value. And typically our Indian thali, whether from Kashmir to Kanyakumari, east to west, we consume too much of carbohydrates. Any community, any this thing you take, we consume more than 60 to 70% of our food through our carbs. Very little fiber. At least 1 gram per kg per day protein goal has to be met. If you take care of this and adequate fiber, we can solve most of our problems. We need to relook. We don't have to change the ingredients, what we eat. We can continue to eat what we eat, but we need to change the portion size. We need to change to a healthier choices. Not a good news for Gangavati people, which is a rice bowl of Karnataka. Rice, see, my father is a general physician in Manvi. When I finished my MBBS, and he told me, those days the rice eating was not that rampant. Only the Andhra immigrants were eating rice. And he said, lot of these Andhra people have diabetes because of rice. At that time, I did not believe that, because none of the textbooks told me that the rice can cause diabetes. But then, now, our heavily polished rice, and we hardly take any dal. Anna tomato saru has become the kind of, routine in everybody's house. We need to change the way we eat rice also. So, the food you eat can either be the safest and most powerful form of medicine or the slowest form of poison. So, we need to give a lot of importance to what we eat and how we eat also. So, what is the advice to younger women? Same advice, lifestyle is the therapy. Concentrate on high fiber and high protein diet, vitamin D supplementations. Nowadays, I don't even get the vitamin D levels. I just give them a prescription. And again, they may take cyclical progestins if only and if required. Now, fertility management. Again, this takes another 1 hour of talk. I'll not be going into the detail, but remember, most PCO women will have difficulty to conceive because of the anovulation. Now, just induction of the ovulation does not solve the problems. There are bigger hormonal imbalances. We struggle as IVF specialists, we struggle as the fertility specialists to induce ovulation, and to even to get a pregnancy positive, it is a big deal. Can AMH be used as our diagnostic tool for PCOS? Yes, usually AMH is increased, but we don't have to get the AMH done for all the patients. Only fertility, and especially if you are going for artificial reproductive techniques, then AMH can be our guide. We need to use metformin judiciously. If we suspect that there is a insulin resistance, then yes, metformin or myoinositol and dichloroanisole can be prescribed with judiciously. But remember that if you start prescribing metformin for everybody, it can cause a lot of nausea, and then, it's not everybody is compliant with metformin. So be judicious. And there is again a role of cyperternostate or drospirenone containing OCPs if we are planning for fertility or if they want contraception together. Yes, we can. Even if they achieve pregnancy, is it a smooth sail? No. They have increased incidence of abortion. Spontaneous abortion, missed miscarriages, they are very, very common because of the terrible hyperandrogenemia. There is an increase if the patient is PCO, very likely chance that she will become JDM. So we need to do the glucose challenging test in all 3 trimesters just to see. There is increased incidence of hypertensive disorders. Fetal growth restriction is not uncommon, and tremendous weight gain during pregnancy. They become 100, 110, 120 kgs. It is not very uncommon. When I started practice, I rarely used to see 1 or 2 patients in a year. Now we do get 1 or 2 in every month who are above century. I told that, when will you hit your century? So they will be around 78, 80, and they will hit century by the time they are full term. So they pose more surgical anesthesia risks as they become over 100 kgs. So what is the take home? Artificial reproductive techniques like IUI or IVF should be after good lifestyle trial. Unfortunately, the complaints rate these young women is 5 to 10%. Those 5 to 10%, when they follow the advice, when they reduce the weight, most of them do conceive spontaneously. But unfortunately, more than 90% of the women, they don't. Yeah, one more message. For all the gynecologists and general surgeon friends who are doing laparoscopy for fertility, please, a biggest request, do not do ovarian drilling. Do not do it. It is an outdated procedure. It is a cruel procedure. It is a very, very barbaric procedure, I can say. For last 7-8 years, I have not done even a single ovarian drilling. There are beautiful protocols available, beautiful drugs available. Do not do drilling because you cause more harm than the good. If at all one message had to be carried from this podium in my oration, I would say, please, please do not do the ovarian drilling. Metabolic women, those who are not desirous of fertility, they do have amenorrhea, they have obesity. See, typically we see after the children starts going to the school, women become little relaxed and they are at home. Even working women also, their lack of physical activity, by then usually economical prosperity would have come in. So they start eating snacks, lot of snacks, high carb diet and barely any exercise. This is the problem. The food is convenient, but it's not nutritious. They also get lot of sleep disturbances. Depression is not very uncommon, and they do have low self-esteem, which they struggle to come out. Remember, the exercise is the best antidepressant you can ever prescribe to anyone. It is known to reduce the depression rates, but unfortunately, most of our women don't exercise. Endometrial hyperplasia and endometrial malignancy is on the rise. The good thing is, in last decade, not only in Western world, even I am seeing a reduced cervical malignancy rates in our area for various reasons, but endometrial malignancy and breast cancer is on the rise. We are seeing almost every month 1 or 2 women, either they get endometrial hyperplasia with atypia, that is as good as endometrial malignancy, and endometrial malignancy per se. So they would either be requiring progestins or Mirena, which is the 11-orchestral intrauterine system. Any woman above 30, obese, maybe PCOE, metabolic syndrome, comes with amenorrhea or oligomenorrhea, we need to do ultrasound. If the endometrial thickness is high, pipal biopsy had to be done. There is no compromise about that. There is no role of only medical management, because women would refuse a biopsy because they'll say, I am all right, why are you worried, I am fine, only give me medication for namak muttonde sari madre saaku. This is their statement, but it is our responsibility to make sure that they don't have endometrial malignancy. The long-term risks are very high. It is written 40 here, but most 60 to 70% of PCO women will become diabetic one day. They have very high risk for cardiovascular diseases, dyslipidemia, cerebrovascular discs, and metabolic syndrome is always there. Is it genetic? Yes, PCOD can be genetic. But remember, there is a old saying, it's not that the obesity runs in the family. The problem is nobody runs in the family. So everybody at the family, remember, see all, they say, nammane gella ringe divu sir. This is a common dialogue. True. Why? Because you eat same kind of food, and if you don't exercise, your children will not exercise. It is a vicious cycle. You are imparting the same values what you are following. So, and male siblings of PCOS will also look like them. So it is not that PCOD is only for women. Metabolic syndrome is not for women. PCOD genes don't wear saris. It is for men also. So, but the good thing is, epigenetic reversal is possible with good lifestyle.
5 minutes more.
You change your diet, you change the way you work, that means exercise, intermittent fasting, you can change your epigenetics.
JP?
Weight loss is possible. Even 10% reduction in the weight loss, if somebody is say 70 kg, if they reduce 6 to 7 kgs, they start having regular cycle. That is the miracle. They will experience, they themselves will come and tell. Those who comply with the medication, they will say, sir, nanige correct muttakattini sir. Can I conceive naturally? I say, yes, of course you can try conception naturally. So discipline is the bridge between the goals and accomplishments. So if you want to achieve something, you need to have the discipline. So what is the take home? Metformin uninstall may be required, stress and sleep management, and we need to have a regular metabolic screening. Most of the women, I do screen for dyslipidemia and also for sugars. We need to create a lot of awareness in our schools about the menstrual health. Now Foxy has taken up this in a big way, and we are happy that we are doing school educational programs through Foxy. And
Jayaprakash, just 5 minutes more.
Yes sir, I'll wind up sir. So the physical activity has to be part of the curriculum. We need to encourage girls to indulge in more and more physical activity. See, these PUC girls are obsessed with studying. Remember this, if you make them do physical activity for half an hour to 1 hour, their cognitive efficacy improves. So they can grasp better than somebody who is sedentary. So it's very important that both from their physical and mental health perspective, we need to encourage them to have a good physical activity. If we can fix the teenage lifestyle, we will definitely prevent the adult disease. So is it an epidemic or mirage? It is no more a mirage, but only thing is our generation is drifting more and more away from the healthy lifestyle. It is an epidemic, no doubt. It can be prevented, this epidemic can be prevented, and what has happened is social media influencers, everybody will come, somebody tells their story, idol, they don't see what has happened behind. In this age of information, confusion has become more epidemic. What is the hope? As I said, PCOD is not a disease. It is a syndrome. It is a dialogue between your body and your habits. So if we can change our habits, our body will also change. And the great thing is 80% of the PCOD will be reversed only by lifestyle change. And only 20% of them would require medications. But what has happened is now we are medicating 80% of them and less than 10% of them are compliant with the lifestyle changes. The Hanuman's strength was not in the muscle but in the restraint. He could have gone to Lanka and brought Sita Mata, but he did not do that because of the orders of Rama. And Vijayanagara's glory was also not without discipline. So remember, PCOD will also bow to us if there is a balance in our life. We doctors need to forgo our ego We need to collaborate. We need to take cross consultations. We need to join hands and forgo our ego, because when we unite, patient heals. But when our egos unite, medicine will definitely fail. Last message, please read this book. Take a screenshot. This will change the way you look at life. There are 2-3 more books, but read this book. It is available on Flipkart and Amazon, just 200 or 300 rupees. It will change the way you look at life. Jason Fung is a nephrologist. He is a medical doctor. He has written it in a very, very beautiful way. It is written for common man, but we as doctors, we need to read this, and we need to tell the patients the importance of diet and exercise. So thank you very much for this opportunity, and I hope that I have given some messages through this.
Thank you, Dr. Jay Prakash. It was wonderful presentation. Now we'll felicitate you, sir. Please.
Please give a huge round of applause as we felicitate our guest speaker. After this session, we will be moving on to our scientific session before we break for lunch. I would like I request Dr. Madhusudan KN sir and Dr. I request Dr. Madhusudan KN sir and Dr. Nagraj sir to hand over the mementos to our orator. We are now handing over the mementos to our chairpersons for their patient guidance and the moderation for the event. It's our token of gratitude for their immense contribution for the oration. We will now be moving on to a scientific session that will be where we have Dr. Manikappa S., Dr. Suresh Sagarad, Dr. Narayan Swami as the chairpersons. We request you all to please come up on the dais. Dr. Suriraju sir too. Our first guest speaker is Dr. Manoj Butte from Secure Hospital, Hubballi.
ಈಗ ತೆಗಿಲಿ.
ಇದು ಮೂವ್ ಆಗ
Next slide and reverse slide and
I invite Dr. Manoj Kumar V. Butte.
Okay.
He has done MBBS, MS, MCH neurosurgery, has also done fellowship in endovascular neurosurgery from South Korea. He is a consultant neurosurgeon at Secure Hospital, Hubli. He has got many publications in national as well as international journals and conferences. Limca Book of Record 2014 registered in the field of medical science. He received an award and honor. Area of interest, microvascular neurosurgery, skull-base surgery, spinal surgery, minimally invasive neurosurgery, neuroendoscopic surgery, endovascular neurosurgery. I welcome Dr. Manoj Kumar V. Bhutte.
Thank you, sir. At the outset, I would like to thank the organizing team for having given me this opportunity. I would also like to congratulate them for having organized such a wonderful conference. The hospitality from IMA Gangavati has been great. Thank you one and all. ಇದು ವರ್ಕ್ ಆಗ್ತಲ್ಲ ಇಲ್ಲೇ ಮಾಡ್ತೀನಿ ಬಿಡಿ ಓಕೆ ಸೊ ಬಿಫೋರ್ ವಿ ಗೋ ಆನ್ ಟು ದ ಮೇನ್ ಟಾಪಿಕ್ 29th October is observed as World Stroke Day. So this is basically done to raise awareness among the general public about the disease. The burden of this disease is huge. This year alone, somewhere around 12.5 million people are going to be suffering from this disease, out of which 5.5 are going to die. The main problem with the disease, apart from mortality, is the disability it causes. So this problem is not just to the family, but to the state and to the country. Recent trend shows that the disease has a rising trend among lower and middle income countries, to the fact that out of 3 strokes that are occurring worldwide, 2 of them occur in these countries. So the disease now has reached an epidemic proportion, with 1 out of 4 individuals above the age of 25 is going to experience stroke in their lifetime. So every year the World Stroke Organization rolls out a theme, and this year theme is every minute counts. And it's based on the fact that somewhere around 1.9 million neurons are going to die every minute. And this also forms a basis on which the current guidelines are formulated. Coming to the topic, stroke is defined as a sudden onset of neurological deficits caused by an acute focal injury to the central nervous system due to vascular cause. I will not be going into the details about the etiology, risk factors, the clinical features. So this disease is evaluated by the following 4 modalities. CT is the main investigation which is done. This is mainly because it's readily available at most of the places. But the most important reason why you should get a CT done is to rule out hemorrhage. So once hemorrhage is rolled out, you can start the treatment for ischemic stroke immediately. Other signs which you want to note on CT are hypodensities on the respective vascular territory, and also signs such as hyperdense MCA. So this is a hyperdense MCA. We have scoring system on the CT, and that's known as aspect score. It's different for anterior circulation and posterior circulation. In the anterior circulation, it's the middle cerebral artery which is taken into account. So there are 2 levels which are taken. One is at the level of the basal ganglion, other is at the level of the ventricle, just above the basal ganglion. And each point is detected on noting the hypodensity. A score of 6 and above is considered as a good candidate for intervention. Similarly, we have scoring for posterior circulation also. Here, each point is given to the each thalami, each occipital lobe, and each cerebellum. Whereas 2 points are given to the pons and midbrain, irrespective of whether they are involved unilaterally or bilaterally. So MRI remains the gold standard, but it's not wise to get MRI always because it's time consuming. These are the different protocols which we'll get in MRI stroke protocols. The disease is diagnosed on diffusion weighted image. Here you will be seeing hyperintensity on the diffusion weighted image with a corresponding hypointensity on the ADC map. So whenever you are getting an angiography, CT, better to get CT angiography because it is more sensitive and specific. And it's better to get the angio from the arch so that you can plan your procedure very well. So this is the flow chart what we follow in our hospital. Once the patient comes to the emergency room, and we are suspecting stroke, we usually get a CT brain done. If there is no hemorrhage, then IV thrombolysis can be started if the patient is in the window period. In the meantime, get a CT angio, and if there is a large vessel occlusion, then the patient can be taken for mechanical thrombectomy immediately. So one thing which you should all know is, once the patient comes to emergency and you are suspecting stroke, there are only two relevant blood investigations which are to be done. One is random blood sugar level and the other is renal function test. Getting other blood investigations is not necessary and it is time consuming. So the indications for intervention are, it has to be a large vessel occlusion, patient has to be in the window period with a NHS score of more than 6. So coming to the procedure per se, these are the three routes through which we usually go. Femoral is the most commonly used route. Wherever we have difficulty, we use radial access, and extreme rare cases, we use carotid. The artery is cannulated in the standard Steldinger technique, and this is the short sheath. So once we cannulate the artery, this is the one which we place in the access route, that is the femoral artery. Through this, all other catheters go in and we do the procedure. So this is how it looks like on the cath lab table once we have taken all the catheter. Here we will be having a short sheath. In that we will have a long sheath. This usually goes till the level of the common carotids. And then we have a distal access catheter which usually goes till the petrous or the cavernous segment of the ICA. Through that we take a micro catheter and a micro air which will cross the lesion, and we will do the procedure with this. So the intra-arterial therapy started with IA thrombolysis, then came the wire manipulation of the clot. The initial device that was approved was known as Mercy. These three things are now rarely done. So the two things which are done at present are, one is aspiration, the other is stent retriever. Coming to the techniques, basically there are three techniques. So the first one is the stent technique. So here what we do is we we place the stent across the clot, give time for the clot to get stuck to the stent, and remove the clot along with the stent, and so that we will establish the flow. Coming to the next technique known as ADAPT technique, that's a direct aspiration first pass technique. Here what we do is we take a large bore catheter and go and attach to the clot, then use a section catheter to remove the clot. So coming to the next technique, this is known as Solumbra. It's a combination of the above set technique. Here we place the stent also, place the catheter also, and we usually do the procedure. So can one device work in all cases? Definitely no. So it's better that you have all the armamentarium in your basket so that you will have a good results. So the post-procedure grading of recanalization is done by known as TICI score, that is thrombolysis in cerebral ischemia score. Grade 0 is no perfusion, grade 1 is only minimal perfusion, grade 2A is where 2/3 of the territory is reperfused, whereas grade 2B is whole of the territory is revascularized, but it's slower, filling slower than the normal one. Grade 3 is where the filling is as good as normal one. So there are variables which will affect our outcome during this procedure, and they are what is the location of the stroke. So whether it's a large vessel or a branch vessel, and in that whether it is stenotic or embolic, and in embolic whether the embolus is soft or hard. So all these variables will affect our results. So let us quickly run through some of the cases. So this was a 25-year male who had right-sided weakness. He was a known case of congenital heart disease. So a clot from his heart had embolized to the brain. So on arrival, so we got in, took him to the cath lab. On left ICA injection, we saw that his left MCA was blocked, mainly the inferior division. So we went in, crossed the lesion, confirmed that we were in the MCA, then placed the stent across the lesion. On first pass, we were able to achieve a TICI 3 result. Coming to the next case, this was a 43-year male with left-sided weakness. On presentation to the year, he had an hemiparesis of 2/5. We got an MRI done, which was showing that it was a hyperacute infarct. On angio, MR angio, there was no flow in the middle cerebral artery. So we took him on right carotid injection. We saw that it was a ICA top occlusion. So there was no MCA or ACA seen. So we went in, crossed the lesion, confirmed that we are in the MCA, placed the stent. This is how that stent retriever looks like. On first pass, we were able to open the ICA top. So the ACA were filling, the M1 segment was filling, but there was no distal flow over here. So we went in again, crossed the lesion into the distal MCA segment, again did the pass, and we were able to achieve good recanalization. So this is the debris which we had removed. This is the immediate post-op video showing that the power of the patient had improved immediately. And this is a recent video. Patient had come with one and as an attendant on the day of Diwali. So I just happened to do this video for the sake of conference. Coming to the next case, this was a 67-year-old male. He had comorbidities. He had COPD. On that, he had aspirated. On arrival, he was in altered sensorium, and he had right-sided weakness. So we got a CT done, which was suspicious of acute infarct. So what we did is we thrombolized him initially and took him to the lab. So on left ICA injection, we saw that his superior division had blocked. So we went in, crossed the lesion, placed the stent, and confirmed that we were in the MCA. We did place the stent, and on first pass, we were able to achieve TK3 result. So coming to the next case, this was a 74-year male who had left-sided weakness. He had gone to Chirai Hospital, Gadag, where since he was in window period, they got an MRI done, thrombolized, and sent to us for definitive procedure. So on his right common carotid injection, his right ICA was blocked. So we went in, did a balloon angioplasty, opened this. On the right internal carotid injection, we saw that his right MCA was blocked.
Sorry for interrupting, Dr. Manoj. Kindly conclude within 5 minutes.
Yeah, sure.
There is, due to some technical issue,
there
is shortage of time. Thank you.
Sure. Kindly consider, okay, sure. So this is a Solumbra technique where we took a large bore catheter, that's React 71, and also took the stent across the lesion. On first pass, we were able to achieve TK3 results. On completion of the procedure, we waited to see if the ICA, there was a good flow in the ICA. Since there was a good flow, we didn't stent. Usually we avoid stenting in acute settings. So coming to the next patient, this was a case of, this was a 70-year male with altered sensorium. He had right hemiparesis. So his left ICA had blocked. This was relative of one of our anesthetists. So the ICA was totally blocked. Under the roadmap guidance, we went in, did a balloon angioplasty, and saw that the ICA had opened and MCA had also opened. So due to time constraint, I would like to skip some of these cases. This was the case where similar to what I just to the previous case. So we went in, did a balloon angioplasty, opened the ICA, but the ICA got blocked. So we had to do an emergency stenting in this case. So coming to the next case, this was a posterior circulation stroke where he had a basilar occlusion. So we went in, his left vertebral was too small to intervene. On the right vertebral, it was almost blocked on the origin. So we did a balloon angioplasty, and it opened, and we saw that his basilar had also opened. So this is his recent video. Patient is doing fine except for his cerebellar signs. So coming to the next case, this was a 35-year-old male. He had headache for 2 days. So he became unconsciousness somewhere around 10 p.m. They got an MRI and had suspected basilar stroke, so was shifted to our hospital. So once we came in on left Voltr injection, we saw that there was a thrombus and the basilar artery was blocked. We went in, crossed the lesion, and on first pass, we were able to open the basilar. This is the immediate post-op picture of the patient. The patient was weaned from the ventilator and not even tracheostomized. I had happened to go to his village in the month of April, and this is him with me, and he's a priest in that village. Coming to the next case, I'll skip some of this. So it's not that every time we will be successful in doing these cases. So this was a 50-year male who had developed dizziness after the yogasana in the morning. By the evening, he had become unconsciousness, went to other hospitals, reached our hospital somewhere around 2:30 a.m. By then, he was unconscious with low GCS. They had got an MRI done, and it was suggestive of basilar arteries blocked. So we went in, took a femoral puncture, and we saw that his femoral artery was totally blocked. So tried the other side, it was also blocked. Then we had to go through the radial. So went in through the radial, and this was his left vert, which was very, very small. So we had to go through this small right vert itself and saw that the distal vert with the basilar was blocked. So we tried to go in, tried to cross the lesion multiple times, but you can see that my wire is getting kinked, and we couldn't do the procedure. So this patient ultimately succumbed. So to conclude, endovascular thrombectomy is safe and highly effective procedures in patients who are in window period. The main problem with the procedure is the cost, especially in our places where most of the patients are not insured. And there might be requirement of other procedures like additional decompressive craniotomy, long-term ICU stay, and tracheostomy. So these all will be difficult to manage.
Thank you,
So, okay.
Dr. Manoj.
There is only one slide. So this is where we do the procedure. This is our cath lab team, and this is our intensive care team. This is the hospital where I work. This is Secure Hospital, Hubli. This is where we started as a single hospital. Then we started services at other places in Karnataka. Now we have crossed the borders and started hospitals in Maharashtra also. I'd like to thank you all for having been with us throughout our journey. Thank you one and all.
Thank you very much, Doctor. If any questions are there, you can discuss during the lunch hours. We will proceed to the next topic.
Hello.
I request Dr. Manoj Kumar V. Butte to receive the token of appreciation at the near the auditorium.
Yeah. I call upon Dr. Girish Nausundi for the next talk, which will be addressing a newer intervention in cardiac practice. He is a good friend of mine and a relative. He is attached to Apollo Hospitals, Bangalore, and he is a senior consultant cardiologist.
Thank you.
Over to you, Girish.
Hello. Thank you. I think Mike. Hello. Yeah. Namaste, and I belong to this place, and I even today eat the rice that is grown from here. So this is what keeps me going, and it's a great pleasure to be here. Such fantastic leaders in the community for the science, and we look up to all of them. Chandrapa sir in particular, we've been inspired for a long time to bring highest level of science and to practice and bring to the rural Karnataka, and asking us to push the limits of science has been one of the inspiring aspect of their leadership to us. And on behalf of IMA, the invitation that's been offered to us, I express gratitude from Apollo Hospitals, Bangalore. Until my slides load, the intention of today's discussion on cardiology is that, this is a devastating disease only next to the stroke. Many people either die or live with limited physical capability. So that's why it's very imperative that each one of us know the cardiovascular disease. There are 3 diseases that afflict the heart. One is called heart attack. The second one is called heart failure. Third one is sudden cardiac death. There are 3 different entities, but it's a continuum of the same spectrum. Heart attack happens usually due to sudden reduction in blood flow in the coronary artery. Either it could be a thrombus or progressive narrowing due to atherosclerosis and calcium. This reduced blood supply would injure a part of the muscle, leading to a heart attack. Every time there's a myocardial infarction, about 7 to 15% of them don't survive the first 30 days. So it's very important to prevent the very first heart attack. And I'm very glad to say that, the Gangavati Heart Center here, they've done close to about 1,500 angiograms and more than 350 angioplasties at Gangavati, and I extend my heartfelt congratulations to them. These require a commitment to offer the highest level of medical care, either for stroke or myocardial infarction, because every minute the muscle will die if it's a heart, brains will die if it's a stroke. So please set up more facility locally so that people do not suffer from acute emergent care deficiencies. Coming to the heart failure, it's a condition where heart fails to pump adequate amount of blood to meet the needs of the body. So either there is a reduced stroke volume or it has become so stiff that it cannot take the blood inside. This is called heart failure. The third condition is called sudden cardiac death. This usually happens due to irregular heartbeat. What we call is arrhythmia. It could be bradyarrhythmia or tachyarrhythmia. So you need to treat all these. Now, coming to advances, I will just breeze through because the time is so short. When it comes to acute care, I think it can be delivered at any place. It could be Gangavati, Raichur, Hubli, Tumkur, any district place, Hassan. But when it comes to complexity, I think we need to have centers of excellence. And we take pride in saying that we have created one of the best centers in the south of India. Even for the state, we take pride in saying we are one of the best, both for robotic cardiac surgeries, minimally invasive surgeries, chronic total occlusion, transcatheter valve replacements. We have emerged as one of the leaders in offering global standard of care. When it comes to coronary artery, today no more interventions are done just looking at an angiogram. We put a camera inside. They're called optical coherence tomography or an intravascular ultrasound. The biggest challenge when it comes to heart is calcium. When you do at a peripheral center, the calcium is so hard that you cannot expand. So there are special tools like this. You can see that when the obstructive plaque hardens, it becomes like teeth. No balloon would expand inside that, no stent will expand. You need to drill through it, grind that obstructive material into fine powder and allow it to go out in the microcirculation and outside in the urine. This is how we do. This is called orbital atherectomy. So when you come to a tertiary center like ours, this is the standard of care you get. There are no challenges. You will never meet a point to say, sorry, we can't do something. Anything that can be done by any human in any part of the world can be done at our place. And that's been our endeavor to achieve as a center of excellence. These are the cases where you don't just go and balloon them. You convert that obstructive material into fine powder and then expand the balloons and stents to get amazing final results like this. I hope it plays. Can somebody play this, please? Okay. This is what we can achieve. And then as you go forward, the next one is what we call, can you help me with that? It's also not working. Can you escape and replay? Yes, leave it. Let me play that. This is called optical coherence tomography. You can see here that a camera is inserted inside the blood pipe, gives you the complete imaging at that point. And what is that obstructive material made of? And what is the thickness of that plaque? It's a 1 millimeter, and there's a calcium, there's a fibrotic tissue, and here there is atherosclerotic lipid-rich plaque. So depending on what is the content, we choose whether only balloon should suffice or we should drill through it, or we can directly implant a stent. So this is the level of advancement that has happened, and this happens for 80 to 90% of the cases. We don't just look at an angiogram and treat them. And now we also practice something called stentless angioplasty. You know, very often you think if there's a block, that all has to be treated by a stent. No. If you image, put a camera inside and realize that it is just a thrombus, we go and suck all that clots away. Can you hear me? Yeah, sorry. So if you put a camera inside and see, then if there is no more thrombus, it is dissolved. There is no need of a stent. This is what we do. And also we do dissolvable stents. These stents go and scaffold the obstructed vessel and dissolve over a period of 3 years. So there is no foreign body left. That is the level of, exceptional care available to us. Now let me go to another case in a heart failure where ejection fraction is just 30%. These are the patients who are vulnerable for sudden cardiac death. Can you see this? This is a ventricular fibrillation. This man was VF. We had to cardiovert him and he was revived. The left anterior descending artery is blocked. We did an angioplasty, but he continued to have profound hypotension. In these cases, we put an artificial heart in the cath lab. This is called an impeller. I will just show you. This is how this world's smallest heart pump. It is there in the cath lab with us. We go from the leg and implant that pump into the heart. It sucks the blood from the left ventricle and ejects it into the aorta and produces a cardiac output of about 5.5 liters per minute. Can you imagine? It sucks from the left ventricle and it can perfuse the brain, it can perfume all the organs. And this is how we implant them. And while that artificial heart pump is working, we do the angioplasty. Even if there's a continuous ventricular fibrillation, we are able to do an angioplasty, and this can be kept for 5 to 7 days. This is the level of expertise that we have, and now you can see the LV has almost normalized at the time of discharge. Next, there's a condition called severe aortic stenosis. Here, the risk of sudden death is about 35% every year if not treated. Very often, it's a disease of the elderly beyond 65 to 85 years. You don't have to do sternotomy. You don't have to open the chest. Either do a minimally invasive cardiac surgery or what we call a TAVI, transcatheter heart valve implantation. This is a valve implanted through femoral artery and a bypass which was done through a minimally invasive surgery. This is the first case in India where in the same patient, a bypass and a valve were done simultaneously without sternotomy, without putting the patient on heart-lung machine, because many of them don't withstand. How do we do? Go from the leg, we bring a heart valve and implant it in the, you can see here, the valves can be just brought from the leg and just blown out and implanted in the aortic place. It's so simple. It's pretty easy these days to implant an artificial heart valve. This patient had a previous valve. That valve had degenerated and we had to put a second valve. This is called valve-in-valve. This person did not have any femoral access. We went from the axillary artery to implant this. And this is the level of expertise that exists today. So then going forward, I think the sudden cardiac death is another thing that we must all discuss. The defibrillators that we implant are what we call leadless pacemakers. These days, when you call a pacemaker, it need not be cut open from the chest. It goes from the femoral vein. We go and implant it in the right ventricular apex and come back. These are called leadless pacemaker. I'm sure recently you must have heard, Khargeji was also implanted with the same pacemaker. It's a very small size of a large vitamin capsule and directly implanted in the ventricle. So no scars. Patient comes in the morning, goes out the next morning. That's how simple the procedure has become. You can look at this here. So it's a pretty simple procedure. After implantation, this is how it looks. It's called leadless pacemakers. And then we also want to show you for stroke patients, many of them have a patent atrial septal defect or what we call PFO, patent foramen ovale. If they are closed, the stroke can be reduced. The third condition is called resynchronization. When there is a right and left ventricle don't contract together simultaneously, they call dyssynchrony. It's called left bundle branch associated LV dysfunction. If you put 3 wires, one in the right ventricle, one in the right atrium, one in the left ventricle, it synchronizes all the 3 contractions. This patient had a CRT and this is the mitral valve implanted in the same patient. So that's the complexity that we can handle. This patient previously had a mitral valve replacement, had a complete heart block. So we had to put another mitral valve and a cardiac resynchronization therapy at the same go. And patient is still doing excellently well. So this is last one. I would show you a defibrillator. It's very important to prevent what we call sudden cardiac death. Whenever there is a sudden cardiac death, 80% of the time it is tachyarrhythmia, 20% of the time it's bradyarrhythmia. Whenever heart beats very fast, it does not have enough time to fill, so the stroke volume comes down, there's a hypotension. At that time, it's very important to implant a defibrillator and shock the person. If there is a cardiac arrest due to ventricular tachycardia, only 20% survive, 80% will die out of the hospital. But if the same person is implanted with a cardioverter defibrillator under their chest like this, the 70% of the lives can be saved by automatic defibrillation that this device produces. Who are the candidates who benefit from this? Anybody who's got an ejection fraction of less than 35%, their risk of sudden cardiac death is very high. Just by implanting this arrhythmia can be shocked and slowed down. So all these therapies are available. So my request to all the physicians is kindly be aware of contemporary medical science beyond the regular to prevent sudden cardiac death, to treat severely dysfunctional heart valves, and very advanced obstructive coronary artery disease, and very poor heart functions, high risk revascularization, either through angioplasty, we can implant artificial hearts and can do this. So we just wanted to bring this contemporary science on behalf of cardiology from Apollo Hospitals to all of you. Thank you for this opportunity.
Thank you, Dr. Girish. If there are any questions, one or two we can take. It was an interesting talk regarding cardiac interventions in recent advancement. From coronary, we have moved to structural heart disease management. And he didn't show regarding LA appendage closure and mitral valve, mitral regurgitation treatment nowadays is picking up in a big way. So there are still many areas because of want of time, we didn't take it up.
Yes.
If there are one or two questions we can entertain. Thank you, Dr. Girish, for that wonderful talk.
Thank you.
Now I invite Dr. Manjunath Patil to give a talk.
Hello. Dr. Manjunath Patil is MBBS, MD General Medicine, MD Gastroenterology and Hepatology, Fellowship in Advanced Therapeutic Endoscopy and Endoscopic Ultrasound. He is working as Chief Gastroenterologist and Hepatologist in Bangalore Hospital and Dr. Satyaprakash Center for Digestive and Liver Disease, Director and Head in Care and Research, Awards and Honors, Gold Medalist in Gastroenterology, Area of Interest, Advanced Therapeutic Endoscopy and Endoscopic Ultrasound. Thank you.
Thank you for the introduction, sir. The talk given to me is gut-liver axis, to understand the bidirectional link in health and disease. Coming to the introduction, as we know, the gut and the liver, okay, it is like a pathway between gut and the liver. The portal vein carries 70% of the blood from the gut, and the key players here are the gut microbiota and liver, along with metabolites and immune components. Coming to the gut-liver axis, the portal vein, primary route for intestinal products that to reach liver, the nutrients, microbial metabolites, mainly short-chain fatty acids and bacterial components, liposaccharides and other toxins, and biliary system, the primary bile acids are converted into secondary bile acids and it is eliminated from the body, and it helps in enterohepatic circulation as well. This is a little bit about short-chain fatty acids. These short-chain fatty acids are fermented from the dietary fiber, inulin and fructooligosaccharides, which are there in our banana, onion, garlic and everything. These are the key functions. Okay, it promotes immunity. It has overall health. Okay, actually the disease starts from the gut, what Hippocrates told 2000 years ago. That is true what we believe as a gastroenterologist, because the gut and the liver are the first areas to be affected and which are silent in obesity and fatty liver. Around 38% of Indians have fatty liver and 25% of Indians have gut leaky syndrome. These are the main primary things which are causing disease in India. This is suggested by the recent study. Coming to the global evidence that indicates what Indians and others should eat. This is a study. This is called anti-inflammatory diet. This is called Mediterranean diet, but what we call is like this is the original diet of India. Okay, if we select how to choose it. And Western diet, as we know, it is called inflammatory diet according to studies and research. This Mediterranean diet is very simple. This is what our elder generations used to follow. It is all about vegetable, fruits, non-refined sugar, low fat and unprocessed foods. Here you can see gut liver mediators, GLP-1 analogs we use for obesity. This is actually produced in the gut microbiota naturally. If we take care of, if we give the body sufficient fiber, that is 25 to 35 grams for males and 20 to 25 grams for females, this GLP-1 automatically naturally produces, and primary bile acids, it has antimicrobial action, which is also naturally produced by these foods. These are exactly opposite. High cholesterol diet produces dysbiosis, fatty liver, ethanol, high fructose levels. Actually, this is what we are eating, all doctors. I am going to show you one data which is done on doctors, around 200 doctors. What is the effect of stress on gut? The effect of stress itself is sufficient for everything because it raises cortisol and adrenal adrenaline in the body. The parasympathetic activity is always cooling effect on the body. The stress can cause anything. It does not matter for the brain what type of stress. Stuck up in the traffic jam also can trigger these all symptoms, as we know. Coming to the leaky gut and its consequences. Leaky gut, the primary pattern now what we are able to understand is we can extract gut microbiota and stool microbiota. We have checked it and we have found that like gut microbiota and stool microbiota, whatever the composition of gut microbiota is there, it is different, and we have lost already 25% of gut microbiota, and we have started eating beyond the restricted time where the insulin secretes. That is where the diseases are linked. NAFLD, overweight, obesity, genetic predisposition, metabolic syndromes, metabolic dysfunctions, endotoxemia, inflammation, and gut dysbiosis. Coming to gut-liver axis in specific diseases, as we know, these metabolic dysfunction associated fatty, now we don't call it as a non-alcoholic fatty liver disease, we call it as metabolically associated steatotic liver disease. And alcohol effect, as we know, it causes endotoxemia and gut leaky syndrome. What are the therapeutic strategies? Therapeutic strategies here, main point is to modify diet to support the beneficial gut microbiota like inulin and fructooligosaccharides, pre and probiotics. When it is combined, it is called a symbiotic. What are dietary choices are high fiber, polyphenol diet. Polyphenol diet promotes anti-inflammatory short chain fatty acids, while Western diet increases pro-inflammatory bacteria. Coming to the pharmacological interventions, here is to using medication to target microbiota and signaling pathway. Antibiotics, rifaximin, it is safe. We use it for up to 6 months in hepatic encephalopathy, and other uses are small intestinal bacterial overgrowth and others. And targeted bile acid signaling is FXR agonist like obeticholic acid, and gut peptide modulation, that is GLP-1 receptor agonist. These are the injections for obesity which is very famous in USA and it is entered Indian market. It is weekly injections and monthly injections are available, but we don't know how it is safe in India. But according to research and initial data suggests it is safe, but the effect is till we take injection. And we can expect 20% of weight loss. Coming to advanced and emerging therapies, novel approach to restore gut-liver axis function. There is fecal microbiota transplantation, which we are doing lots of trials on that, which has a promising data, which we restore microbial diversity using healthy donors sample from the relatives or primary first degree relatives. There are engineered bacteria and phases. These target pathogenic bacteria directly and produces therapeutic compound in the gut. And postbiotic, which delivers beneficial metabolites like short chain fatty acids directly. Conclusion, a multi-pronged personalized approach is the future treatment. Gut-liver axis is complex. Combining therapies is often most effective. What all diseases we are going to discuss discussed in the meetings, it is started in the gut. That we should never forget. We are doing expanded research on these all things, and important thing what I want to tell you today is, we are doing one, I'm the director and I have started this Anti-Life Sciences and Research Center. I have my own R&D. Here what we have done, we have followed just 4 simple steps. One is time restricted eating. As we know, insulin secretes from sunrise to sunset. We know the saying from the saints, this is what we have done here. We have restricted their diet initially. First 4 to 6 weeks, we have restricted between morning 8 a.m. to 8 p.m. And over a period of time, we restricted to 6 o'clock. And this itself is sufficient to cause lot of beneficial effect in the body. Around 6% to 8% of weight loss we are seeing, and insulin sensitivity increases. There is a autophagy in the body. There is a regeneration activity goes on in the body. And the data, because of some technical things, I cannot show it. But these 100 patients, all are doctors who are physicians, gynecologists, who we have included, and it is shown almost 95% of them have become normal below 40 years if we start. And disease is under control if it is later age. And 2 meals with 10% modification diet is enough for Indians. And any physical activity of their choice weekly 5 days. And we have developed an anti-health revitalizer. It has pro and prebiotic and protein balance. The main thing what we are looking for metabolic problems now is only time restricted eating, 2 time eating, and protein balance. We know we talk about so much of oil problems, so much of problems, but the real thing is there are 2 things. We doctors, we don't have so much of control of the system. We cannot change the diet, but we can change ourselves. At least our body, if we make it strong, it will tolerate the food what is available now. And once the body is normal, when the body is healthy, once in a while, if we eat processed, ultra processed, anything, body will tolerate. This is what the message I want to give. Thank you, sir.
Hello. Thank you, Dr. Manjunath Patel, for your speech, elegant speech.
Thank you, sir.
Madam.
Thank you very much, sir. Thank you very much. Uncle, thank you.
Thank you, sir. Work up.